पढ़ी है अभी कोई ये ऑनलाइन है पहले पूरी चली गई इनसे अनीता मैडम से स्टार्ट करें अनीता मैडम से स्टार्ट करें हाँ उनको अनाउंस
Very good morning to everyone, respected colleagues and dignitaries. Today talk is on about the question number 10, that is investigations for incidental gallbladder cancer. I would like to invite the chairperson, Dr. Karan Pipre, who is the head of the department, Professor Nuclear Medicine. Dr. Swati Purohit Joshi, who is Associate Professor in the Department of Radiodiagnosis at MGMCH, and Dr. Vinay Mehla, who is Associate Professor, Department of Surgical Gastroenterology and Liver Transplant at MGMCH. Dr. Somil Vyas and Dr. Anita Balakrishnan ma'am will be joining online, so I thank them for that. Shall we start the discussion, please? Okay. Okay. Good morning, ma'am. Welcome to the discussion. Ma'am, can you please start the discussion, please? Okay, ma'am.
Good morning, and thank you very much for the kind invitation to comment on the subject of investigations for incidental gallbladder cancer. I'm aware the previous speakers have covered this topic in detail with an extensive review of the literature, so to avoid any repetition, I'll keep this brief and primarily focus on our current approach in managing cases of incidental gallbladder cancer at our multidisciplinary meetings in the UK. One of the key pieces of information we look at is the histological status of incidental gallbladder cancer, including cystic node status, whether there is any high-grade dysplasia or cancer at the cystic duct, and the T stage and the presence of lymphatic or perineural invasion. We also look for operative details, including bile spillage and gallbladder perforation, as well as for anything to indicate that there may have been piecemeal extraction of the gallbladder due to a difficult cholecystectomy. The operation note may also specify other findings, such as the presence of liver lesions or peritoneal deposits, which would influence our subsequent management. CT tends to be the most widely used modality in the investigation and staging of incidental gallbladder cancer. It can be used to assess the extent of the disease. This includes looking at CBD involvement, extension into the liver, involvement of the rest of the biliary tree, other organs or vasculature. It can also be used at looking at the involvement of regional or distant lymph nodes, as well as for the presence of distant metastases. The CTs in this slide show at the top subclavian metastatic nodes, the middle CT scan shows metastatic periceliac nodes, and the CT scan at the bottom shows the presence of a cystic Mary-Joseph's nodule and a peritoneal deposit. All of these might preclude further decisions to operate for gallbladder cancer. MRI is also a very useful modality in staging incidental gallbladder cancer. It is more sensitive than CT for certain features. It exhibits between 87.5% to 100% sensitivity for the detection of liver involvement. It's 92% sensitive for nodal involvement, but we have to be aware that it may underestimate liver involvement in around 11% of patients. The MRI image at the top shows nodal metastases, and the MRI image at the bottom shows a liver metastasis. PET-CT can be quite relevant for the assessment of nodal status or metastases. It may, however, be less reliable for T stages, particularly in early stage disease. We should be aware that gallbladder fossa uptake may be confounded by recent surgery. PET-CT scan may have a role in confirming or refuting any specific findings on MRI or CT scan, such as distant lymphadenopathy or peritoneal disease. CT is resolution dependent and therefore the size has to be taken into account. As a result, PET-CT may be correspondingly more useful in higher stage disease, such as in patients with T3 gallbladder cancer and above, where you may be more likely to suspect the presence of distant metastases. The PET-CT scan in the slide here shows the presence of a hilar node showing uptake in a patient who's had a cholecystectomy for incidental gallbladder cancer. Several other points bear brief mention. I won't go into detail, as some of these are covered elsewhere today. Ultrasound can be of little value as an investigation once cholecystectomy has been performed for incidental gallbladder cancer, does not form part of our routine staging. Staging laparoscopy can be quite useful, and I understand it's being covered elsewhere today, as is molecular profiling of gallbladder cancer. FNA of enlarged distant lymph nodes may be useful, but we have to bear in mind the possibility of false negatives here. In summary, our practice is to organise a CT of the chest, abdomen and pelvis as the main staging modality for patients who present with incidental gallbladder cancer, and we would subsequently organise an MRI and PET-CT in select cases if there are specific concerns. Once again, I thank you for the opportunity to present this and for the invitation to this important meeting. Thank you.
Anita, I would like to thank you personally for joining in online, even if it is 4 a.m. in UK. Thank you very much. I'm sure all of us know Anita is the first author of the Omega study, which has collated a large multi-center clinical experience on gallbladder cancer. Please.
Thank you very much. That's very kind. I don't know if you can hear me. I'm having problems with my computer volume and sound. Can you hear me?
Yes, 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 please. And please
thank
feel
you.
free to interrupt in between if you want to make any point during the discussion, please.
No problem. Thank you very much for inviting me. I'm away at the moment at another meeting, and so I'm going to keep my video off. My Wi-Fi connection is not very good, but I look forward to joining the rest of the meeting. Thank you again.
Thank you very much, Dr. Anita, for excellent presentation. And now I will invite the delegates for discussion.
Actually, our lead presenter, Dr. Rohit Dhawan, is on the way. So, meanwhile, can we have Dr. Somil Vyas and his online comments?
Somil has joined.
Can you please play Dr. Somil Vyas' presentation? Or either he is online?
No, he didn't. Actually, he had a last-minute change, so he hasn't sent a video, but he probably would join once again. So in the meantime,
Important initially to diagnose the disease and pre-operatively also, but to detect the lymph node involvement and distant metastasis also, and even in recurrence of the disease also. So nowadays PET is available everywhere, and the surgeons and oncologists also referring for the management of the disease. So PET, I would like to add that this society should include the PET as a mandatory tools for the diagnosis.
so Shiven, your group has published on PET in CAGB. What were your findings and what is your current?
Separate lecture, and even we are doing even within 4 weeks. But the standard is you one should delay up to light up in PET scan, and then we clear those areas to do FNAC. So it might be useful even in T2. T1 is, I think it might be doubtful still because the nodal positivity rate is less.
Sir, I just wanted to ask you. Actually, I think in our literature, the dilemma is that everybody has done established role of PET in T2 and above. But as sir has rightly said that ki T1A or T1B disease, nodal metastasis chances are very less. So exactly what period of time we should wait post surgery, either 2 week or 4 week? Because in our institutional protocol, we used to wait for 3 to 4 weeks, and then we used to do the PET. As NCCN has only level 1 evidence for PET in incidental CAGB workup. So what is your expert opinion as you have already recruited your patients for incidental CAGB and your trial is going on?
For trial, we are recruiting whether it comes in first week or 2 weeks, we are recruiting. But the standard recommendation for all inflammation is around 4
7 days.
If the previous imaging is not there, so we doing a CT scan plus PET scan also we are doing for study purpose.
Then, sir, if you will do the PET within 7 days,
Shraddha can
Yeah, so
give
the
her.
ballpark figure is usually 4 to 6 weeks, and also the main reason is the index, the mean time after which the patient presents to us is also 2 to 3 weeks. So usually 2 to 3 weeks have already elapsed since the index surgery. It doesn't harm waiting another couple of weeks to get a baseline staging investigation done. And in our study, which evaluated the role specifically of PET scan in incidental gallbladder cancer, says that around a third of patients get upstage, which is a significant number. 1 in 3 patients, if they are getting upstage, you're obviously changing management. So it's definitely a worthwhile tool. The only 2 caveats is the timing. So, I mean, it's more or less agreed that 4 to 6 weeks to wait for the inflammation to settle. The second thing is the false positivity rate, especially for mediastinal lymph node, given the prevalence of COX in our country. But we've not found very high false positive rate in our study for picking up mediastinal nodes. And for us, the routine practice is if a patient presents to us within 4 weeks, we get a CT scan done, it's a CT scan of the thorax, abdomen, pelvis, and after 4 weeks, it's a PET scan.
if within 7 days,
It's usually a CT scan.
then because in routine practice, if a patient comes to us or everywhere in India within 7 to 10 days, immediately people will use to prescribe PET. You should do PET. So what should
I'll request the chair to ask my pointed questions are, agreed, if the patient comes after 2 weeks, you have no option. Suppose the patient, as we are trying to generate the awareness that get a biopsy done, if it is showing positive, go to the specialist. Suppose the patient comes early. Do you get a PET scan done the next day, or do you wait for more time? If you wait for more time, how much time? That is number 1. Number 2, if you see a mediastinal node, as you rightly, or say a para-aortic node, do you prove it by FNAC before you condemn the patient to no treatment or no surgery at least? And third was this, again, point blank question, T1B disease. Would you do a PET? Would you recommend a PET? Is it being included in your trial? Yes or no?
Yeah, T1B also we are including all patients who present. And the issue is we have a difference of referral pattern in the government hospitals, in the private sector.
Suppose the patient comes on 5th day, what will you do?
We are doing as a PET scan because the issue is even the false positivity rate in our study which was published, that though that was non-incidental, false positivity rate was only 7%. And we have proved all patients, if they were found even a lung nodule, we have proven with the endoscopic ultrasound guided or CT guided FNAC was done. And false positivity rate was around 7%, false negativity rate was around 10-11%.
Extend the question. So you do a PET and you find that there is a lymph node positive in say periportal or then what is the next step in your management?
If we have found initially post-cholecystomy or nodal disease, our policy is to go for neoadjuvant chemotherapy and then take up for after 3 months, 3 cycles of chemotherapy. That is our policy. If we find on evaluation whether it's a nodal, whether it is regional or non-regional, we take up after neoadjuvant chemotherapy after
so any disease.
It could be inflammatory, but most of the time these are usually positive. Whenever we have tried to cause, most of the time they are usually positive.
So any disease seen on PET CT, your approach is to do a neoadjuvant therapy.
If only GB fossa lesion is there, then we have gone ahead with, but if we found a nodal disease, and GB fossa is only most of the time inflammatory many times, but if we find any disease on the lymph nodes, then we have given neoadjuvant. What TMH has proposed, if any disease they have found, they have gone for neoadjuvant chemotherapy.
So that's as a part of a ongoing trial where we have said that if you have residual disease or which a nodal positivity which is picked up on PET, these patients are recruited on a neoadjuvant trial. So that's part of a trial protocol. But as sir rightly said, if we have conclusive evidence, and our radiologists have also defined criteria for the nodes to be positive. The SUV max level, the characteristic of the lymph node, which suggests that it could be metastatic. So if all these criteria are fulfilled, then patients is subjected to neoadjuvant.
So let's flip the question. If there is no uptake on PET CT, do you operate or you don't operate?
Operate. So the ideal, in
But
patient, then we again neoadjuvant.
Without documentation, removal of the gallbladder piecemeal.
Piecemeal,
The
yes.
suspicion is there, there must have been done.
But Shraddha, your paper said that when there is no PET uptake in PT1B or PT2, no surgery. So,
Not T, only T1B.
but, I mean, I'll quote that paper. I have that. But it says that there is N-PET, L-PET, and in N-PET without liver showing, you are not going in to do any
So
surgery.
that was a corollary which we saw retrospectively from our study, in which if patients who had PT1B disease on histology and had a PET negative scan, when we reviewed the histology subsequently, we found that none of these patients actually had residual disease or in the nodes, and they never recurred locally. So that was a corollary of the paper. It was not a prospective study. It is what we found later on when we reviewed
So
our
have
study.
you changed your practice?
As of now, we've not changed, only for PT1B, because the number of PT1B we get, if we see 100 patients, we get around 2 PT1Bs.
So, the group which is addressing this question has to provide clear, all the review of whatever information is available and clear statement or answer about the indication of PET based on T stage, in timing of PET, presuming that all patients present within 7 days, then what do you do? And third, if you find no disease on PET, no activity on PET, what is the approach? If you find activity on PET, if it is in the GB fossa, if it is in a removable node, if it is in a distant node, and of course distant metastasis doesn't matter, that everybody is clear. So all these answers have to come clearly. Whosoever is, I don't remember who's addressing this question, but these are the issues.
Exact criteria for the lymphatic to be labeled as a malignant.
Yeah, and to the tissue
Because
diagnosis.
the dilemma is
Tissue
everyone
diagnosis.
has their own SUV uptake criteria. Some used to say 5, some used to say
Yeah.
more than 6, more than 7. So we need a proper cutoff value.
Actually, we have jumped on to PET, but I would step back and ask Swati that a patient comes to us with a diagnosis of incidental gallbladder cancer.
Yes, sir.
Should we go for a conventional cross-sectional imaging? If yes, CT or MRI? Or should we straight away go for a PET CT?
Good morning, everyone. Sir, I believe that the first imaging which we should go for is definitely CT scan, because we have lots and lots information we get from CT scan. But yes, when it comes to the early T staging, definitely MRI is better. Again, it actually depends on what kind of information we want. Starting with this, of course, the baseline imaging is USG. And very commonly, when we are talking about incidentally detected GB carcinomas, in our practice, we find incidentally a lot of polyps in the GB. So that also, sometimes if it is more than 10 mm, we tend to ask for further investigations. However, it is proven that only about 0.4% cases in polyps greater than 10 mm, there are chances of malignancy. So definitely the next line of investigation, because of its easy availability and all, is CT scan. But if further for T staging, and if we require more details about the biliary anatomy and all, then definitely we can go for an MRI with contrast for the arterial phase. And of course, the biliary anatomy is definitely better seen in MRCPs. So basically, CT and MRI are complementary to each other. Sir, I also had a question. What about the incidentally, because in our practice, many times we are just writing that there is a GB polyp, whether it is in the CT scan, in ultrasound, and at times we say that it is an enhancing one. And of course, what we have seen is that if it is greater than 10 mm, then definitely we ask the surgeons that please investigate it further, or maybe according to the guidelines, like in 2021, the SGAR said that if it is greater than 10 mm, then definitely we can go for a cholecystectomy. And then according to the size, again, like if they say that if it is 6 to 9 mm, and if the patient is at high risk, like if it is of Asian ethnicity, greater than 65 years, PASC, then definitely we should think of a cholecystectomy, and if there is no associated risk factor, then we should just go for a follow-up. So then what is the take of the surgeon when it comes to this? Because this is what we are doing, but then when we are, because it's very common that we are giving polyps in our this.
Actually, we didn't include polyp in the program because the theme was incidental gallbladder cancer. But
Sir,
since
I
you've-
agree.
Yeah, since you've raised that point,
Yes.
I suppose most of the guidelines emphasize the points which you've already mentioned, the number, the size, the nature of polyp, and the ethnicity. So I suppose in our population, different people would follow different guidelines, but any polyp of a reasonable size, I would say 6 or 9 mm, probably would be an indication for surgical intervention, because the only other option is follow-up, a close follow-up with serial imaging,
Yes,
which
sir.
becomes an impractical kind of situation.
Yes, sir.
So going back to CT and MRI for incidental gallbladder cancer, you said they are complementary, but what is the practical recommendation? Because Anita in her presentation said that MRI is better than CT for certain things. So should the first investigation be a CT or an MRI, presuming that patient has no jaundice? If the patient has biliary obstruction features, then probably MRI may be better, but presuming that patient has had an incidental gallbladder cancer diagnosis, within 7 days patient comes back with the histopathology report. Now we want to see whether there is distant disease or not. So would CT be the, and what is the practice of
Yes, sir.
surgical
Sir,
procedure?
definitely I think CT, because we at one take we can just go for chest abdomen CT, and we can have all kinds of information, whether it is just an intraluminal, extraluminal, the extent of the disease, if there is any metastasis. Then we are also doing a triple phase, so we also know if there is an arterial involvement. Even if there is any variant anatomy, that also we can pick up on the CT. If there is any metastasis or anything in the liver,
So
in
what
the
would be
region.
the situation where you would do an, or you would say MRI should be done rather than CT?
Sir, if it is very early, like for the T staging, okay, we can go for an MRI, but then I think MRI can only be done if, like you said, if there is biliary involvement.
Post-cholecystectomy scenario.
Okay, post-cholecystectomy.
Yes, Shalini.
Sir, I feel that we will waste a lot of time if we keep on beating around the bush. There's some very specific points I would like to mention, because the previous two, Dr. Shive and Dr. Shraddha, I'm a bit confused now that they are doing PET on day 7, while it's well known that you can have high false positivity rates after initial surgery because of the inflammatory changes. So I have my serious doubts that whether PET should come into the recommendation that whatever time the patient presents you, whether 5th day, 10th day, 12th day, you straight away go for PET CT. We need to talk about that. We need to sit down, because if you are putting it into a recommendation, then many people will follow it. So I think as per the existing literature, PET should come only once there's a reasonable surety that the inflammation has subsided, which usually is around 6 weeks, although it may take longer. And my second point with regards, and I totally agree with the speaker, the first speaker, that MR for local staging. So we have to have our fixed endpoints. What are we looking at? We can do everything, but we have to have a guideline that, okay, for local recurrence or local disease, MR is definitely better, not simply better because it has so many modalities to differentiate between malignancy, although it's not 100%, but it can differentiate between inflammation and residual disease much better than a CT, especially when a patient is presenting within the first 4 weeks. And third point is that how can you justify giving neoadjuvant chemotherapy just without having a tissue diagnosis, because till date it is said that you should have tissue diagnosis before you go for neoadjuvant chemotherapy. So these are the 3 points that
Shive.
because lymph node, yes, in his study there were only 7% positivity rate, but that was a non-operated patient. It was a primary gallbladder cancer that they studied upon. I believe that once you are finding a lymph node, maybe in the like a periportal lymph node, and it's lighting up on a PET. So how justified would it be to go for neoadjuvant therapy just because it's lighting up? It may be an inflammatory node, it's a post-operative setting.
So let's take questions one by one. CT versus MRI. Swati's opinion is for CT.
Yes.
He agreed that
So for
disease, it's always MRI.
so it's MRI.
No, but how do we know that whether we are, see, you are looking for disease anywhere.
So I would say that you combine the two things, that is an MRI and a PET CT. A triple phase CT with an FDG PET is a combination. So you get both the things, like for local disease, MRI, for liver, whether it's liver specific mets or it is nodes in the pota or GB PET. Most important is the GB PET. MRI is far superior. I think
Yes, definitely. So that's what I'm trying to say. Both are complementary, but yes.
So in a
and CT
simplified,
part is covered in the
in a more simplified way, what exactly is our aim if a patient comes to us in our OPD with a T1A or T1B disease? So what exactly the ideal investigation we are going to advise the patient, MR or CT? So I think Dr. Shalin sir and ma'am has already pointed out their points that MRI is better in the assessment of local involvement as well as nodal involvement, as well as differentiation between the post-op inflammation as per the residual disease. Exactly what you are saying then. So ma'am, being as a radiologist, what is your opinion? MRI is better in all these three aspects above CT or not?
Yes.
Because we have to, because sir has conducted this thing, because we have to give him a take-home message. For a surgeon who is practicing in a periphery, he doesn't have the liberty of advising a couple of investigation that first you do the CT, then we will do the MR, then we will do the PET. So we have to advise him a investigation to conclude whether we should go for our next step or not. So MR versus CT. That exactly sir is asking.
valid point that you do a PET CT, if you find something suspicious in the GB PET, then go for the MRI.
No, no, so then we are reversing the sequence. Then you are saying that we do a PET CT first, for which we are saying we will wait for 4 weeks. So those who do an early, where is Shiven? He is saying PET as soon as the patient comes. Why he wants
Yeah,
that?
that is my point. I want to ask him to bring this clarity.
But any one of us is doing a PET as soon as the patient comes?
On the first time when they are presenting, because the primary staging has not been done. Now the patient has a metastasis in the medial stand-up.
Your
That
primary
patient is
will
out.
help you in deciding that. If it's a TGB
But
leading
then it is not. Then it is unlikely. If it is T2 and beyond, then it is.
Because I know that some clinicians are of the opinion that if you do a PET CT and it shows distant disease, then there is no need to do any other investigation. So it saves the cost. But then at the same time, most of us are saying that PET CT you would like to wait for 4 weeks. So which means that 4 weeks you are doing nothing.
Actually, sir,
Then T1A, T1B, we are not doing, we are not giving a PET scan time. T2 and beyond.
So what are you doing? T1B patient comes to you, he has come to your opinion. What would you say? You would say I would do nothing?
We'll wait.
That's what? Doing nothing. Waiting means doing nothing. No, no, one by one, please, one by one answer these questions specifically.
Sir,
T1B patient comes to you day 7 after surgery, what would you do?
Sir, in cases of T1B, if there is no bile spill recorded, no stone spill recorded, and our pathologist confirm that it is T1B, we do the CT chest and abdomen. We go ahead with, if there is no detectable disease, we go ahead with the extended cholecystectomy.
So why not add PET, because the incremental cost of if you are able to do contrast this way, why not do PET at that time, because
Sir,
you have no staging.
that's okay. I think PET CT combines in combination with CT is okay. It gives all information what CT gives contrast CT.
The point is that most of us said that if PET is to be done, it has to be done after 4 weeks.
Sir,
That is
in
what
No, sir.
cases,
Sir.
cases with T1,
No, sir, no. Just after completion of surgery, immediately recommended that for the PET CT to characterize the disease and involvement of the
How would you
nodes.
differentiate between post-surgical inflammatory changes and tumor on PET scan? Suppose we do PET scan 7 days after cholecystectomy. Even if there is no malignancy, normal cholecystectomy, you do a PET scan, you will see some activity, avidity there. So how would you differentiate? That is the reason why most reports say that you should wait for a few weeks, and most people say at least 2 to 4 weeks.
If we were not resource constrained, would it be suppose we both of we would we like to do a PET then and later, and actually if it's showing
that is my question to Nag. He says T1B, day 7 patient comes, he does a CT chest and abdomen. If no disease is found on CT scan, he doesn't do a PET, he straight away goes for completion extended cholecystectomy. That means we are saying that for T1B disease, where there is no bile spill and CT is normal, there is no need for PET scan. Do we agree with that?
So that's what we follow.
And Shiven, the specific question to your group is, why early PET scan? Why not wait?
Problem is that once the patient is diagnosed with gallbladder cancer, they are very worried about it, and especially in the private sector, they will be after how to get the further treatment to be started as early as possible. And the other thing is you can do a delayed PET scan. They do a delayed PET scan after 2 hours, and they have a much better sensitivity of doing whether it is inflammatory or malignant. So delayed PET helps in differentiating between inflammation and malignancy.
And moving on, distant disease, no problem. The single reason is bile spill is not documented. So if
and second thing is also, it is very difficult to get all the slides and blocks to be sure that it is T1B only. In most of the places, only one slide is available. So we are not sure what pathologists have said, whether it was actually T2 or reported T1B. You can't be sure that it is T1B unless you get all the tissues possible.
Actually, indirectly we are saying then PET CT is required for each and every patient.
Every patient will have a chances of metastasis or nodal mets, so doing a PET scan will not harm.
Because we don't have the background, timing is most important.
Yes, sir. Then indirectly we are saying PET CT should be done in all cases beyond T1A.
Yes.
That's what we are saying. And then comes the timing. What time we should do?
The real life scenario is that unless the cholecystectomy was done in your hospital, which is rarely the case, most cases will come to you from some other person. So T stage is very doubtful. You don't have, in most cases, you don't have operative details, so you don't know whether bile spill occurred or not. And even if it occurred and you ask, the surgeon may not be able to recollect, and most of the time they will say no. So we have to presume that if we are dealing with incidental gallbladder cancer, unless you have your own pathologist report, and there are a couple of publications in the literature where it has been shown that when these so-called T1B cases were reviewed by an experienced pathologist with multiple sections taken from blocks, it became T2, because in some area the perimuscular connective tissue was involved. So I would agree with Nag when he says that for all practical purposes, unless the T stage and bile spill is well documented, it should be taken as disease which is beyond T2, where definitely PET scan is indicated. My question is timing of PET and sequence of investigation. Because if you are doing PET CT early and it shows distant disease, then it is an advantage. Then you don't need a CT or MRI. But if you are waiting for 4 weeks and then comes the social issue, the medico-legal issue, that can we say, and I don't remember that the recent SGPGI publication where they are saying 12 weeks, although again that is a retrospective. No, the best results time 4 to 8. So even if it is 8 weeks, it is retrospective because they had to wait for 8 weeks because the patient came after 8 weeks. But like Shraddha said that even after their analysis, they haven't changed their practice. So has SGPGI changed its practice that if a patient comes at 7 days, would they wait for 8 weeks before doing the reoperation? These are the questions which you need to...
Sir, most of the cases where we are waiting for the this thing to get operated or re-evaluate, most of these patients go for the neoadjuvant chemotherapy, and they usually get PET CT at the other center where they go, sir.
So
it is pre-operative evaluation for that.
So let me again, let's start one by one. If T1B or T2 you will operate, what is the purpose of surgery there?
Purpose of surgery is mainly of restaging to be sure that it is only...
I mean that's the answer we are looking at. So it is restaging to see nodal disease, and then that gives you an idea whether patient needs adjuvant therapy. If you can get a better method of staging that disease, then resurgery may be very selective.
Yeah,
so that means that's what you are trying to do,
Yeah.
the PET CT. Now what Puneet and Shalin are saying is that early PET CT may have inflammatory. So would you add histological documentation of PET positive to?
If any finding which is going to change our management plan, that has to be proven by biopsy. If you find any disease, a PET is light up in the mediastinal lymph nodes or neck nodes or a left paralytic nodes, we always document and prove it.
Correct.
If anything which is not going to change our treatment plan, then we don't do FNC. Like if we are planning if the periportal node is there that is light up, then we plan for NSCT and then take up for surgery. We don't prove that node. That is the only thing that we are proving.
So within
Anything which will change the treatment plan, because we are changing from curative intent to palliative intent, then we always definitely prove it.
So within 7 days, lightening up of periportal node and without tissue diagnosis, directly go for chemotherapy. As you are saying in your study, this is your protocol.
This is the protocol that we have been following most of the time, because periportal nodes are there, are residual diseases there. If you presume that it is positive, then it is a good, not a good case to operate, because it's an aggressive tumor, more likely to fail. So that is why it is better to give neoadjuvant chemotherapy, and there is no harm in giving 3 cycles of chemotherapy and then doing a surgery.
My only point was, and from this discussion, what I gather is I think it would be, like Dr. Kapoor just said, that can you sit and how you deal with the family, that okay, we'll wait for 4 weeks if he's presenting on 7th day. So it would be a good idea that you do a PET CT initially, and if you find something light up in the GV bed, then confirm it with an MRI. And if you are planning neoadjuvant, at least see if the periportal node is lighting up on after 2 weeks of surgery. You cannot just say that it is metastatic and we will give just chemotherapy because it is harmless. You should have some proof to say that okay, these nodes are metastatic, and US guided FNA is such an easy thing these days. So at least prove it.
US guided FNAC costs much more than even
See, now we are talking purely cost comes later. We always try to hide things behind cost. Put aside the cost. Talk of science at this point.
It is totally agreeable, but we do post-operative lot of GV fossa areas there. So where are we going to prove every GV fossa to prove it? That because most of the time you will find a fluid collection in the GV fossa area, which will light up.
Yes.
So whether you are going to prove.
So what time will you do the PET? My question, I put back the question to you.
We do all whenever.
No, timing.
We are for study. We are doing all patients whenever they come. For if they come within 1 week.
So what should we put in the guideline that PET? Agreed, PET should be done. It's agreed that 1B, 2, 3 you do a PET, but timing is important. What time?
Timing is very difficult, because many times patient will come at around 7 days or 10 days. Most of the time they come around 7 to 10 days.
Yeah, maybe 2
they will
weeks.
get the biopsy that what we see around 7 to 10 days.
Yes, agreed.
Most of the patients which are operated in the urban centers, they will come. If they only in the patient with rural background, they come at around
Agreed.
2-3 weeks.
2 weeks within 1 month. Okay, put it that way. We are getting
So
patient within the 1
that
month.
is why our intention was, because we are not doing PET scan for all incidental. For this time we are doing just to rule out whether it is useful or not. So we have still not analyzed. We don't know whether it is.
Even the problem is we cannot get level 1 evidence or even level 2 evidence for all these questions. So from the literature and from own experience and putting reasoning into it, we have to formulate a guideline. So it's reasonable to say, because histology may not be from patient coming from outside, it may not be very reliable. So you do PET in all the cases. That's agreeable. That sounds to reason also. But timing of PET remains debatable, as we said. So this is just my thought process, that if something lights up in the GV fossa, go for MR.
How the MR will again you need to prove it. So why not do FNAC? Why to do MR?
MR is definitely MR is definitely better in especially the diffusion weighted images are much better in differentiating.
Diffusion weighted is the best, but still if you see inflammation versus even diffusion weighted imaging is not able to help.
It's not 100%. I totally agree.
So that is why again
specific.
You will end up doing FNAC. Tissue diagnosis you will end up. So you have to do a tissue. Either we decide if we do any area which lights up on PET scan, we are going to prove it. That is the easiest to say.
So, sir, can we have Dr. Sorry to interrupt. Can you have Dr. Anita Balakrishnan's opinion, ma'am? Can you hear me? Ma'am? Dr. Anita?
Can you hear me?
Yeah, ma'am, you're audible, ma'am. So, ma'am, what's your opinion regarding, we are discussing about the role of PET or the timing, ideal timing of PET to do in post-op. So, what's your opinion, ma'am?
Yes, so sorry, I have been trying to comment, but I think you may not have heard me, so I put some comments in the meeting chat. But our radiologist would not recommend a PET within a few weeks of surgery. We see this particularly when we deal with colorectal liver metastases, and so we see it a lot where we see post-operative changes of inflammation, etc., that it will really make a big difference in terms of the interpretation. And our oncologist would definitely not give chemotherapy if we picked up nodes on such an early PET, because there's a really high likelihood of a false positive, particularly in patients with T1B, where if your pathologist has looked at the gallbladder, the whole gallbladder, and you've got correct histology, the likelihood of picking up a genuine metastatic lymph node is quite small. And so if you are picking up lots of nodes immediately post-op, if you do a CT, there's a very high likelihood some of those are false positives. I think a PET CT could be useful, but we wouldn't do it in all patients. I think we would always start with a CT chest abdo-pelvis. If you can't see something on the CT chest abdo-pelvis, at least in terms of size, so lymph nodes of a certain size, it may not show on PET CT anyway. So we would not do a routine PET CT. And I agree with the speakers who say that an MR has a role mainly in terms of assessing local extent of disease in terms of liver involvement. It may pick up liver involvement if the CT does not. Again, some of this boils down to whether your gallbladder has been staged properly and whether the pathologist has looked at the whole gallbladder. So I think they each have very different roles, and I think we would always start with a CT chest abdo-pelvis first. The other comment in terms of how do you deal with the fact that some patients may present really early within 7 days of their initial operation, and does it not feel like a waste of time if you tell them to just wait for a few weeks while you sort of get the time to do a PET at a later date? I think you could employ that time in doing a chest CT abdo, a CT chest abdo-pelvis first, and getting that looked at. I don't think it's a waste of time to wait a few more weeks and then do the PET if necessary. I think if you're concerned about disease progression in that interval, you're talking about really poor disease biology. And so actually, I'm not sure you've done the patient any favors by rushing forward too early. Thank you.
Thank you, ma'am. Thank you very much. So, yeah, ma'am. You want to say something?
Yeah, I wanted to say the same thing which Dr. Anita said.
Sorry?
I wanted to say the same thing which Dr. Anita said.
So if you want a take-home message, so can we have our experts' opinion? Like a patient came to our OPD with pre-op sono suggestive of everything is normal, like we used to see in peripheral sonographies, and then suddenly with biopsy suggestive either T1A, like we were talking about the T1B disease. So biopsy suggestive of T1B disease. So then for the take-home message, CT, MR, PET. Sir. It's not all these things. We have to advise the patient either CT, MR, PET. So one by one, can we start, Puneet sir? Your opinion, CT, MR, PET. One.
So
we have to choose one.
Yeah, so she suggested triple CT, chest abdo pelvis, which in our center would be almost the same cost as PET CT. So I personally would say that since PET gives us the additional information of a distant met, I would prefer PET. And MR is a problem solver, MR slash confirmation, biopsy confirmation.
So your preference is PET. And if PET is showing some lightening, and then according to that you will plan.
Apart from the bed bit, everything else we will get to know.
Okay. Sadiq sir.
I second that.
Sorry?
I second what Puneet is saying, that I would adopt that approach, because see, you have to also, we are also putting a rider that we are not sure about the T stage depending on where it is done. So, that makes it a little difficult, because if it is T1B, we have options to understand whether there would be liver disease in that or not. It's unlikely in that. If it is T2 or plus, then the possibility of a liver a residual disease is more in that situation. So keeping all that in mind, if we have to do something which one test which will at least rule out a distant disease without differentiating between T1B, T2, T3, I would agree with Puneet that we do a PET CT. If things light up, we do a biopsy. If it is not there, then we take a call. So in PT1B and PT2, if nothing lights up on PET, we still would do surgery because there are certain lesions which may not be picked up on PET. So that would be complete staging by doing a resurgery at that point of time.
So your opinion is PET. Shalin sir.
So only rider is that the PET should have a contrast because some places do PET without. So
Okay.
The whole rider was that if it is not done in that center with a contrast.
You want to say
it
PET
should
with
be a-
triple phase
then
CT,
the-
combination of
then
both.
Then what she's recommended also.
Combination of both PET with triple phase CT, as every center have their facilities. Shalin sir.
PET,
We do along
should
with the contrast.
like convey that PET should be with CT contrast also. No,
Yes.
but my only question still remains that if we are doing it early, then we will have lots.
Sir, we will come on this second. We have to conclude. We have to give take a message. Biju sir, sir, PET CT MR, post surgery T1B disease.
See, practically the issue is, I put it this way, we are putting guidelines based upon a retrospective information.
No sir, we are not putting guideline. We are making consensus. So
just
we will
explain to
conclude.
that.
Yes sir.
Old things will make upside down. That let us say we do an MR and found that it is T3. Are we going to change the liver resection? Probably no. T1 we are finding. Are we changing liver resection? No. We don't have time here. Carcinoma gallbladder, we don't have time to keep on investigating till after 4 weeks I'll do PET. Patients will develop metastasis. This is not a disease where you can debate on when to do. I agree with Shivendra that we do when you get a malignancy, carcinoma gallbladder, you are sitting on a time bomb. You can't manage that patient in 6 weeks. There is no point in discussing theoretical discussion.
No,
Window
sir,
is gone.
sir, we will
Let
come
me
on
explain. Let me explain.
timing.
The problem is we are trying to define a locally advanced disease by portal lymphadenopathy, which is wrong. This is not locally advanced disease. Scientifically, where is the locally advanced disease if a regional disease?
Fair enough.
Correct? The regional disease and locally advanced disease are totally different. I think so. Even the Tata Institute, you see the publication, they try to define the locally advanced disease by regional nodes. There is something called regional metastatic disease in carcinoma gallbladder. Okay, nodal disease comes to the stage 4. So what I'm trying to tell you, very simple thing. We don't have time, over-investigate. We have FAPIVET and all that. Please do it, but please don't try to make a guideline based upon A, B and C because it doesn't change whatever is in the field. You do 4B5, T1A you do the same, T1B you do the same, T2 you do the same. What are you trying to do by doing an MR and telling them that, okay, it has infiltrated liver beyond the 1 millimeter. Are you going to do right extended particularly? No, we are not going to do that. So there should be a change in the ground level. When you suggest MR, no, I don't think, I don't do MR in CAGB at all. Okay, you get a good CT, you get a PET at whatever stage patient comes. Patient comes today, you get a PET, whatever investigation you have to manage it right now. We can't tell that I will expect so you find an inflammation report. Are you going to change the lymphadenectomy? Are you going to change the lymphadenectomy? No, you keep on investigating EUS and all another 2 weeks to prove that the patient has to go for neoadjuvant therapy. That 2 weeks is enough to upstage that patient. Here we are talking about a totally different disease where a series of investigation by delaying 2 weeks, it actually upstages. That is the molecular biology of carcinoma. That's what I feel.
Biju, 2 questions on that. If in 2 weeks it gets upstaged, is it the nature of the disease or you are going to change that course by doing this surgery? And the second thing is that now after all these retrospective data which one has collected, what is evident is if you find that there is residual disease, irrespective of you have an R0 resection, the outcome of that is poorer than the one with no residual disease. So that means surgery is not curing or doing good for them. You need to have alternative approaches to those who have residual disease. So your surgery was only identifying residual disease and then saying they don't do well after surgery as compared to those who don't have residual disease. So both the things, if it's upstaged in 2 weeks, it's an aggressive disease. You are not having an impact by doing the surgery at that point of time.
So, sir, actually, sorry to interrupt you. We are running out of time. We have only 5 minutes. So, everybody has agreed on that PET should be done. Then second point is what exactly the ideal timing should be done. Like everyone have their opinion, including Anita ma'am. So, early PET is a diagnostic dilemma showing inflammation versus residual disease. So, what would be your opinion regarding the ideal time? 6 to 8 weeks? Okay. So,
Let's summarize it by saying that
Yes,
I
sir.
totally agree what Dr. Biju and Dr. Shiven has said, that if we have to do one investigation, do it when the patient comes, because you have to understand the ground reality. You cannot tell the patient go home, come after 4 weeks. That's totally agreed. So you do a PET CT. My only point was that early PETs will pick up a lot of GB fossa collections lighting up, and you end up doing unnecessary biopsies for so many patients. So maybe you just end up with PET CT and plan your surgery, do nothing else.
Okay, fair
But
enough.
if you are
So-
planning a new adjuvant, then I would suggest you get a tissue diagnosis.
Okay. So our so it's clear. So whenever the patient comes to us, we will do the PET. So to summarize, sorry sir, sorry to interrupt you sir. To summarize, T1B and above the PET CT whenever the patients come to us immediate post-op with a good triple phase contrast, and according to that, then we have to plan our patients. Yes sir.
So
Thank you
for,
sir.
in PET, we need to have criteria which are conclusively of
Definitely,
either a
we
residual
have-
disease or a node. If there is any doubt or it's equivocal, I suggest that we advocate for a tissue diagnosis before subjecting to neoadjuvant. not before it.
Dr. Shraddha, the group who is working, the group working on this topic, they will definitely conclude this one, the diagnostic criteria for the malignant versus benign nodal disease on PET uptake. So last conclude by
My
Dr. Kapoor.
question is, patient comes on day 7, we do a PET CT, it doesn't show any disease. Now, do we operate the next day, or do we tell the patient that there is evidence, although retrospective, to say that surgery done after 4 weeks or 8 weeks is better, you wait, I will operate upon you after 4 weeks.
We'll discuss that.
Okay, so because if we are waiting, then do we repeat a PET before surgery again?
Yes.
Ideally, yes. So, so can we close this session? So that's
I
it.
think we have to conclude that
Yeah.
whenever the patient comes to you, you have to get a PET scan, and this is just a baseline PET scan if the patient has to be followed up. If the patient needs a surgery now, we'll discuss subsequently.
Yeah,
but this is a baseline PET scan.
We have other sessions for the reoperation timing and everything. Subsequent sessions we have. So PET immediately when the patient comes to us, and according to PET we will decide our further treatment. Thank you very much, experts, for your opinion. Thank you very much, sir.
Thank you very much.
And Anita, thank you very much for joining very early in the morning. And we hope to see you physically here in Jaipur in the next Jaipur Surgical Festival. Thank you very much.
Yes, sounds like an amazing meeting. I'm very sorry I couldn't attend. Thank you for having me.
Thank you.
Thank you, chairpersons and dignitaries. Next session will be about question number 11 to 14, that is on indications and contraindications of reoperation. I would like to welcome Chairperson Dr. Anand Nagar, who is Associate Professor in the Department of HPB Surgery at MGMCH, and Dr. Setin Yohan, who will be joining online from Nepal. He is a Senior Consultant at Kathmandu Medical College.
So I would like to invite for this session lead presenter Dr. Marugappan. Dr. Marugappan is working as a consultant at Hyderabad. Dr. Marugappan working as a consultant in Shastra Hospital, Bangalore. And I welcome Dr. Setan. She's joined online.
Good morning, everyone. I've been tasked with the discussion of indications and contraindications of re-resection in IGBC. So to begin with, we did a literature search using this research query, which we try to include almost all of the possible papers, with including gallbladder diseases with a Boolean operator and an incidental findings. So this is what we found when we looked at PubMed. The number of records that were obtained were 678. After excluding case reports, editorials, technical reports, reviews, and non-English language, we were left with 183 papers. The abstracts were screened of these. After the abstract screen, we were left with 131 papers for full text screen. 21 of them we couldn't retrieve. 72 had no relevant data or data discrepancies, unclear data, or they had combined data of a diagnosis where an intraoperative diagnosis was made along with a postoperative diagnosis. So at the end of it, we were left with 38 studies. So the following thing will be on these 38 studies. So I've put up a series of tables. I've tried to maintain the commonality in these tables with the year and the author mentioned initially, then the number of IGBCs here, the disease which the topic of discussion, the management option, the survival outcomes. I'll be going a little fast with these tables. This is for your to get accustomed to it. So the coming to PT1A, the first thing, there was just one registry, German registry, which had offered an extended resection for these patients. It compared extended resections with the simple cholecystectomies in these patients, and they found that there was no survival advantage. All the other studies showed that the 5-year disease survival was roughly in the tune of around 100% in these patients, suggesting that a simple cholecystectomy is a sufficient surgery for these patients. Coming to PT1B, again, most of them are from the registries where they were treated with extended resections versus simple cholecystectomy. There was a comparison. The extended dissections provided an improvement in survival. However, they were not found to be significant in any of these reports. PT2, again, extended dissections and versus simple choles. So many more number of studies, more number of patients, except and an extended resection showed better survival in almost all of these studies, which didn't reach significance in 2 of these reported. Coming to PT3, all of them were from again national databases, and there was a survival advantage in most of these. PT4, ideally we shouldn't be encountering PT4. Exceptions were discussed yesterday, where when once surgery is being done for a complicated gallstone disease, one might encounter these. So the case reports that have been mentioned are few and far between, so and all of them universally have dismal prognosis reported. Coming to the next risk factor, this is the tumor grade. The following studies have reported on the grade, G1 being well differentiated, G3 poorly differentiated. G3 disease or the poorly differentiated disease is shown to have higher odds of having residual disease, more higher odds of having residual disease, more distant residual disease, and consistent poor survival in these patients, which is significant. Lymphovascular invasion was the next risk factor, study which had 15 patients of IGBC, 10 of them had lymphovascular invasions, 9 of these 15 were re-resected. So in the group of patients who didn't have the lymphovascular invasion, that is 5 of them, 2 didn't undergo any re-resection. They didn't have the number I've put in the brackets, the mortality. They didn't have any event up to 5 years of follow-up. In the patients who underwent extended resection, there was 1 patient who had a mortality event. In the 6 patients with LVI present, of the 10 patients, 6 patients with LVI present underwent extended resection. 2 of these had a mortality event, and the extended resection had in fact increased the survival to more than 2 years in these 2 patients. And of the 4 patients who didn't have extended resection, 4 patients of LVI who didn't have extended resection, all 4 of them had a mortality event within 2 years of diagnosis. So they predicted that it's a indicator of prognostic indicator of a mortality event. Similarly, another report with 59 IGBC patients, the reported lymphovascular status were 15 positive and 32 negative. The residual disease with respect to lymphovascular invasion, there were 11 of the 15 patients who had positive, residual disease. 10 of the 32 had, and this was found to be a significant prognostic indicator again. Perineural invasion, again, is the same paper which had 59 IGBCs. They had reported 16 positive cases and 19 negative cases. The residual disease seen in them were 11 of the 16 patients with positive perineural invasion had residual disease, and 5 of the negative cases had residual disease. Again, this was found to be significant. Coming to the next factor, which is the cystic lymph node, this group did a registry study with 73 patients of cystic lymph nodes were retrieved. 29 were positive, 44 were negative, 114 were the other unknown group. A positive cystic lymph node meant there was more PNI, more LVI, higher incidence of residual cancer, higher likelihood of cancer in the lymph nodes, increased recurrence, and higher likelihood of positive hepatic pedicle lymph nodes. They didn't find positivity in the N2 nodes, but they did find positivity in the N1 group of nodes. However, this currently with the number of nodes being more important, but this is what they found at that time. And this meant that there was a worse disease specific survival in these patients with positive cystic duct lymph nodes. The same group looked at the cystic duct margins 2 years later. They found that of the 179 patients, 33 patients had margin positivity at initial cholecystectomy. They had resected 42 of their 179 patients. A positive cystic duct margin meant that the 5-year survival was poor. A CBD resection did not improve the survival. It increased the morbidity. However, if on extended resection no residual disease was found, still the cystic duct margin meant an independent predictor of poor overall survival. But a CBD resection in these patients provided a survival similar to a cystic duct negative group, but when a CBD resection was not done, the disease survival was poor, significantly poor. Coming to the incidence of residual disease, the discussion that's been spoken of since morning, these are the papers which have reported based on the T stages of these tumors. So roughly the incidence in T1B is around 20%, extending from 0 to around 20%. T2, that it goes up to the tune of 60 to 68. T3, it is around 80%, and finally in T4, all these patients, most of these patients had residual disease. So what is the impact of residual disease on survival? Again, the thing that's been discussed from morning, most of them uniformly showed that there is decreased survival with the presence of residual disease. I would like to bring your attention to these two papers. The one which was discussed yesterday, the paper by Duffy et al. The median survival with no residual disease was 72 months. Where a residual disease was found and an R0 resection was achieved, it was 19 months. A residual disease was found, no R0 resection, it reduced further to 12.7 months. Similarly, a report again from, I think from the US itself, 3-year survival, disease-specific survival, that is 64% for extended resections without residual disease. In presence of residual disease, it comes down to 30. In presence of residual disease, if no resection is done, it reduces to 8%. The next and the final factor, that is the bile spill. There were around 20 papers which discussed bile spill as a factor. However, most of them were one-off, special one-off mentions. These are the papers with significant numbers reported. All of them universally reported poor, all the surgical outcomes that were reported were significantly worse in patients with bile spill. To just skip this slide, the bile spill is associated with increased likelihood of finding residual disease, finding distant peritoneal disease, and lesser chance of curative resections. So I would like to leave with this final slide. So for patients with T1A, ideally we would observe the presence of cystic duct margins, cystic lymph node positivity, LVI, grade 3, bile spill. This is the gray zone. T1B, you would again re-resect because the possibility of finding a residual disease in the tune of 20%. Resection of a residual disease found to be better than leaving it alone. T2, T3, resect after metastatic workup. However, these in presence of an LVI, PNI, grade 3 disease, bile spill, we would, what's being discussed now, would try to do an extensive workup and consider neoadjuvant therapy in them. A delayed presentation in these again is a gray zone. T4, so you would individualize treatment for these patients. So I would like to end it with saying that we should have a predictive score for the finding of residual disease in these patients, which should also even help us in coming up with our workup strategy. Thank you.
Thank you, Dr. Marugappan. For the comments, I would like to invite Professor Yoji Kishi. He is a professor in hepatobiliary and pancreatic surgery, National Defense Medical College, Japan.
Okay, good morning, everyone. First of all, I'd like to express my sincere gratitude to Professor Kapoor and his colleagues for the kind invitation and the great hospitality here in Jaipur. It's my honor to have this opportunity to make some comments on the clinical question of the indication and contraindication of reoperation for incidental IVGBCA. I'm from Japan, and in our country, recently the third edition of guideline for the treatment of biliary tract cancer was published. But in this book, there is only one clinical question regarding the treatment of IGBCA. That is, should biliary resection be performed for pathological T2 or more incidental GBCA? And the answer is biliary resection at the same time or afterward is recommended. The recommendation grade was 1. So let me introduce our own experience for the last 3 decades, which including rather old cases. We could identify 21 cases of incidental or missed gallbladder cancer for the last 3 decades, which accounted for about approximately 3% of all cholecystectomy cases in our institution. The median age of the 21 patients was 70 years old, and the distribution male and female were almost half and half. The main etiology was cholecystolithiasis, gallbladder stones, followed by acute cholecystitis. Bile spillage during the index cholecystectomy occurred at least in 3 cases, and biliary resection was performed in 17 patients, which accounted for 81%. And the final pathological staging was mostly the T2 and T1, and the T3 patients accounted for about 1/4. Only 5 patients were found to have lymph node metastasis, and the number of metastatic lymph nodes was only 1 or 2 in most cases. This is the outcome of the 4 patients who did not undergo resection after index cholecystectomy, mainly due to the early tumor stage with T1 stage disease or physical conditions, mainly due to the patient's elderly age. Of course, the patient's advanced disease with T3 or virus fields in the first patient died of the disease. On the other hand, 70 patients underwent free resection after the median interval of 34 days after the index cholecystectomy. Again, T1 and T2 accounted for the 3/4 of the total population, and T3 for the 25%. The main procedure as a resection was the hepatic vein resection and lymph node metastasis and lymph node dissection with and without bile duct resection. Only a few patients underwent WIPO procedure due to the extensive disease along the hepatoduodenal ligament. And of course, there's a big difference in the prognosis between the patients with and without residual diseases, like this. None of the patients, 10 patients without residual disease died of gallbladder cancer. On the other hand, only one patient here is T2 and one disease with residual disease in the stump of the statistical duct could survive for as long as more than 10 years. As a whole, the 5-year survival rate with and without residual disease was 70% and 86% respectively. This is survival according to the pathological stages. Of course, the patients with less advanced disease showed better survival, but T3, the patients with T3 or non-positive disease, also in certain proportion of such patients could survive for a long time. So these patients should not be contraindicated for resection. As Dr. Margupan presented, there are many papers that evaluated the outcomes of resection, mostly the retrospective cases, and only a few studies were evaluated with a large series. This is a paper from Netherlands using the National Cancer Registry, and 102 resection patients and 353 patients without resection were compared. Of course, the patients with resection showed better survival as a whole, and of course, the patients without residual disease showed significantly better survival. But it should be noted that only approximately 10% of especially T1B or T2 disease had residual disease finally. This is another paper from Chile and United States, M.D. Anderson, which also evaluated the outcomes of resection. Among the totally 187 patients, residual cancer was not recognized in more than half, 102 patients. And of course, no residual cancer was showed significantly better survival compared to those with residual cancer in the total population and in the subgroups of stage 2 or stage 3 respectively. This is another paper from Sweden using national cohort, and 92 patients who underwent resection among 249 patients with incidental GBCA were evaluated. Again, no residual tumor was associated with better survival, and the multivariate analysis for disease-specific survival showed that only the residual tumor, rather than pathological staging, was an independent prognostic factor of disease-specific survival like this. Also, the site or extent of residual disease could be an important factor to predict prognosis, as several papers described. Like this, the limited residual disease could be associated with better prognosis. So, in my opinion, we do know that in the patients who receive resection, residual cancer could be a significant factor that predicts fast prognosis. But one question is resection should be mandatory in the whole patients with residual cancer. These certain proportion of patients could have received over surgery. And on the other hand, as most papers shown, residual cancer was definitely a predictor of worse survival, and mostly showed very dismal survival was shown. So resection only will not be enough. And some multidisciplinary treatment could be expected, I think. And on the other hand, among the patients who had been actually followed up without resection, potentially certain proportion of patients could have residual diseases. And these patients should have been received resection. So the discrimination of potential residual cancer could be a problem. This paper has been mentioned yesterday by several speakers, which proposed a predictive risk score of residual diseases using T-stage, tumor differentiation grade, vascular invasion, and permeable invasion. Such score could be help distinguishing the patients with or without residual disease in the future, but it could not be perfect. So let me introduce finally our most recent really experienced very regretful case. The patient was 77-year-old male. Preoperatively, we did not at all suspect the possibility of gallbladder cancer, and under the preoperative diagnosis of gallbladder stones, we performed RAPC. But due to severe adhesion around the gallbladder neck, incidentally, the bile spillage occurred, and the conversion open cholecystectomy was performed. And only after pathological evaluation, the gallbladder cancer of T2 was recognized. So what we did was a delayed resection because we are afraid of tumor dissemination due to bile spillage. This PET scan performed only after 1 month after initial cholecystectomy, which does not show any sign of distant metastasis. And now the patient has been receiving oral chemotherapy with S1 for about near half a year, and we are wondering when to take this patient to the operation room for the resection. So this is my final slide. There are several questions or issues that should be addressed. First, although we did not focus on this issue, the interval until resection is still a controversial issue. Yesterday, many discussions mentioned that median or long interval for more than 4 or 8 weeks would be feasible than short interval after index cholecystectomy. Probably due to it enables accurate staging, and less effort in adhesionectomy would be required. Second, strategy according to TMS stage or location of residual tumor should be mandatory, but I think there is room for resection for advanced disease even in T3-4 or node-positive diseases. And lastly, this would be discussed in the later session, but pre and post resection additional treatment could be an expected issue in the future. Thanks for your kind attention.
Thank you, Professor.
This one.
For the next comment, I would like to invite Professor Kun Min, maybe online videos.
ना उसका नहीं उसका बोल स्विच कर
Hello everyone, my name is Kunmin Chan from Chang'e Memorial Hospital at Linkou, Taiwan. Our hospital located in northern Taiwan, and it also has the largest medical service in Taiwan. It's my honor to be invited to participate in this meeting for the International Study Group of Ovarian Cancer. I'm sorry that I could not attend this meeting on site, so I would like to express my appreciation to the organizing committee and chairman as well as all the participants of this meeting. I am sure that this international study group of consensus meeting regarding ovarian cancer will provide us most updated information in terms of management of ovarian cancer. I am responsible for question 12 that this 12 has two sub-questions. 12A is in which cases with incidental ovarian cancer reoperation is not required, that we only need observation and the follow-up alone is enough. I think if the patient tumor stage only T1A that only limited in lamina propria, not beyond T1A, and during operation there is no biospillage and the gallbladder stem is intact and complete, and also has no 60 lymph node involvement. And I think this kind of patient can be only observation and follow-up alone is enough. On contrast, if the tumor beyond T1A, which is T1B, there might be need further radical operation for these patients. And 12B is observation and follow-up alone enough for T1B, that the tumor involved muscularis propria, incidental ovarian cancer, yes, in which cases. And I think the most important thing is 60 lymph node involvement. If the patient has the tumor located at the peritoneal side, and also the 16 non-active and the 6 margin active, for this group of patients with T1B ovarian cancer, they might be can only follow up or observation is enough. However, the observation will be benefit for tumor staging that has lymph node invasion. Meanwhile, we also can use some predict risk score as a tool for evaluating with operation for patients with T1B incidental ovarian cancer. However, we also need to concern about the patient's physical status. That means that we need to concern about the perioperative mortality associated with radical resection. Is my responsibility of the question 12. Is welcome to give us some comment, or we can discuss in the discussing session. Thank you.
One more online comments from Professor Jaipur D. Bala, Senior Surgeon from Chile.
क्या नाम बताया
Kapoor Festival. It is my honor to be part of this Congress. Today, I express my point of view about the indication and contraindications of reoperations in incidental tumors. Before deciding on the therapy, the most important fact is to know the exact level of wall invasion. This slide shows the different possibilities of invasion of therapy. All patients treatment. Survival at 5 years is higher than 95%, and the patients must be considered already treated with cholecystectomy. In patients with a T1B tumor, the invasion reaches the muscle layer. This slide shows a typical gallbladder cancer with an invasion of the muscle layer. For this group of patients, there needs to be a clear recommendation. These slides show the author's different positions concerning the management of these patients. In our center, we have studied a large number of patients with T1B tumors, and there is no difference between those who underwent resection and those who underwent only cholecystectomy. In the same way, the number of patients with lymph nodes or liver invasion in these patients is extremely low. From now on, and based on the results obtained in our center, we will not operate on patients with T1B tumors. In T2 and T3 patients, the recommendation is to reoperate the patients. There is a consensus to adopt the above recommendation. What about the contraindications for resection? Before operating on a patient, we must study possible dissemination using images. Although there is no consensus, PET-CT could be helped to discard distant compromise. Due to the cost of PET-CT, triphasic CT is a good alternative. In my opinion, the compromise of lymph nodes number 8 and 9 should be a reason not to proceed with the reoperation. The compromise of the number 13 lymph node is a matter of debate. The next station from the number 13 lymph node is the retropancreatic lymph nodes. By lobar or massive liver infiltration and invasion of the vascular structures of the hepatic pedicle, randomized trials support the value of reoperation in incidental tumors. Most papers show a difference in survival between patients who underwent reoperation versus those who underwent only cholecystectomy. However, the groups are different and not comparable. Patients who underwent reoperation and resection were already staged and selected. In these patients, we know the absence of distant or local compromise before the surgery. On the contrary, we do not know the exact level of dissemination in those who underwent only cholecystectomy. Unfortunately, due to the low incidence of this tumor in the world, it is difficult to get a randomized clinical trial. Another critical topic is the value that neoadjuvant chemotherapy or chemoradiotherapy could have before operating the patients. Currently, a couple of clinical trials are in the recruiting phase to answer the above. Thank you very much.
Can we show the online Professor Saturn is connected?
Namaste from Nepal. There is substantial evidence for us to suggest that T1A disease do not require reoperation, whereas T2 disease or more benefit from reoperation unless the patient is unresectable or patient. Much controversy exists in T1B disease. If you see here, the overall survival ranges from 37.5% to 100% after cystectomy. After radical resection, there is varying results, some showing benefit, others showing. Before we consider T1B disease, I think it is important to understand the controversy that exists with T1B disease. The fact that there is diversity in literature, which means that most of the T1B disease is either clumped with T1A disease or T2 disease, when it's reported, has to be considered. Second, we know that there is difference in incidence of carcinoma gallbladder, of T1B incidental gallbladder carcinoma per se, Eastern countries as well as Chile showing less incidence compared to West. This could be because of the fact that there is difference in histopathological study of the cholecystectomy specimen. Studies reveal that 29% of PT1B disease reported after random sampling focused on gross abnormality were actually T2 when comprehensive mapping protocols were used. However, there is a possibility that some T1B disease are actually better than the others. And there could be various factors which actually might differentiate a bad T1B disease from a good T1B disease. We know that lymphovascular and perineural invasion can occur in about 33.3% of cases. They're both associated with high incidence of locoregional disease and distant disease. Node positivity can occur in 10 to 20% of cases. We know that in simple cholecystectomy, a lot of nodes must be undetected or neglected. And we know that when cholecystectomy is only performed, the disease-specific survival and overall survival is less compared to when lymph node dissection is done. And if radical cholecystectomy is done, disease-free survival and overall survival is better. We also know that poorly differentiated gallbladder carcinomas behave poorly. They have early recurrence and survival is poor. And you can see here that when grades are high, locoregional disease and distant disease are both high. And with resection margin, we know R1, R2 have poor prognosis, whereas R0 is associated with better prognosis. In fact, these factors have been combined into a gallbladder cancer predictive risk score, which stratifies incidental gallbladder carcinomas into low risk, intermediate risk, and high risk group. Now, intermediate risk group has a locoregional disease incidence of 24%, and the chances of distant disease is 3%. And studies reveal that 78% of T1B disease have intermediate risk, which means that they benefit from operation. Now, there are studies to suggest that bile spillage is associated with high incidence of distant disease and locoregional disease. Now, distant disease is more common than locoregional disease, and we know bile spillage is associated with both shorter disease-free survival and shorter overall survival. Fortunately, locoregional residual disease is more common than distant disease with T1B disease. 17% is the incidence of locoregional residual disease, and when it's present, the overall survival is 20.7 months. Now, the problem with residual disease is it is very difficult to identify it before the surgery. The imaging modalities do not help much. PET seems to be of some benefit because some study shows that when it's PET positive, the prognosis is poor, but we also know that it is subject to misinterpretation because post-operative inflammation can also lead to PET positive. Now, I did show that articles conflict in terms of the result after reoperation, but this is a decision analytic Markov model study done by Abramson et al., and which showed that if you consider other factors, the post-operative factors, simple cholecystectomy is inferior to radical resection in terms of disease-free survival and overall. So I believe that if there is lymphovascular invasion, perineural invasion, if it is poorly differentiated, the nodes are positive, it's R1, R2 resection, it has to be reoperated. We need to avoid bile spillage as far as possible. PET positivity at the moment seems to suggest residual disease and therefore probably necessitates reoperation. Thank you.
So regarding the question in which we are discussing our all topic is indication and the contraindication of reoperation. If we discuss the definitive contraindication of the reoperation, then rest of we can consider these are the patient in which we should go for the surgery. So I want to ask from the house, in which cases we'll definitely will not go for surgery or not go for reoperation. Sir, your opinion.
My job is to raise questions, not answer. So I will raise the question.
So I will ask from the faculties
So
or the senior
I'm raising
faculties.
a very specific question. T1A, but histopathology from some other center, just a one-line report, adenocarcinoma, T1A. No other information available. We don't know whether bile spill occurred, bag was used, or whatever happened during surgery. What would you do? Biju.
Sir.
Shiven, reoperate. Sadiq, T1A, a very cursory report from some pathologist whom you don't know, no surgical details available. No blocks available. Puneet, PET, okay, you've done PET, negative, yes. No distant disease, there is some avidity in the fossa, some avidity in the regional nodes, as Biju said. So what I'm saying, T1A with no complete information, a very cursory pathology report, because it has been shown, and I think Sumaira yesterday commented, that if you see an incidental gallbladder cancer, ideally you need a mapping of the gallbladder, because at some other place it may be T1B. So what I'm trying to emphasize, T1A, a very not a reliable or not a known source of pathology reporting, no surgical details available. We don't know where the tumor is, what is the cystic duct margin, no other information. What would you do? So that is what I said in the suggestion, that in my opinion, the only situation where I would not reoperate is T1A, no bile spill, reliable pathology, cystic node was in the specimen and is negative, and cystic duct margin is negative. This is an ideal world. And PET-CT, of course, negative. Shaleen, so the situation given by me? So in real life, if you ask a surgeon 7 days ago who's doing 5 cholecystectomies a day, who doesn't keep any operative record. Yeah. Satin, what is your opinion? Can we have Satin on the screen, please? So in this situation, because that is the real life situation in incidental gallbladder cancer. Most cases you don't have complete information.
First of all, thank you for having me participate in this program. I'd like to thank you and congratulate you as well. And at the outset also apologize for not being able to be there physically. And I think to answer the question, I think obviously it's a hypothetical question and a lot of things are in doubt and a lot of caveats and a lot of, if in doubt, I think it is more to be on a safer side and to reoperate.
Okay. Now the other situation, T2 or sometimes as it happens T3, all reports of incidental gallbladder cancer include T3, although ideally it should not be there because a good imaging should have detected a T3 lesion. But again, the real life situation is that T3 also comes as incidental, whether it is true incidental or not, that we have discussed yesterday. So T3 or T2, PET scan or CT scan, whatever we have done, shows beyond regional, that means para-aortic nodes. What would you do? Satin,
Sir.
you first.
So the para-aortic nodes are positive. Is that the scenario, sir?
Yeah, either they are enlarged on CT or they are showing some avidity on PET scan.
I think then any benefit with neoadjuvant chemotherapy before a reoperation should be considered.
Anand?
Sir, we'll consider these patients like metastatic disease, M1 disease, So if we want to try and put confirmation of diagnosis, EUS guided biopsy of this FNAC of these nodes, and we'll consider these patients as an M1 disease, metastatic disease.
No, so
Yeah,
suppose
we'll
FNAC is positive, what would you do? Suppose FNAC is
We'll consider this is a metastatic disease. We'll give palliative chemotherapy only.
and
We'll not
if
operate.
FNAC is negative?
Then we can.
Shiven wanted to say.
If your leg paraortic is there, then definitely you go do a FNSC or interaortic level. If it is positive and there is no other site, what our philosophy is to give a neoadjuvant chemotherapy. If there is good response, even resecting in these group of patients will have a much better survival as compared to metastatic. If the only site is aortocaval lymph nodes. And this we have published our experience also for it.
So that is very interesting debate. I am medical oncologist. I think I am the only or somebody might be there. But that is very interesting that you give neoadjuvant chemotherapy in such situation where there is doubt. At least we will have the idea about the biology of the disease, that how aggressive the tumor is. If the tumor shows good response, even that will give to like better disease-free survival or overall outcome. May not be cure, but at least good survival outcome may be there with this approach.
So although it is not the theme, but Shivendra, I will ask you, primary GBC, para-aortic node, CT, you've done an FNAC, it is positive, you give neoadjuvant. Now, do you look at, after completing a neoadjuvant, do you look at only the anatomy? That means this nodes have reduced in size or disappeared, or again you will do an FNAC to make sure that they have become negative before you go for reoperation? For operation?
We will not do the repeat FNAC if there is a response is there and there is no progression of the disease, and we don't need extended resection like SPD or major liver resection. Only simple radical cholecystectomy is required, then we'll go ahead and operate.
You do a para-aortic lymph node dissection?
Complete para-aortic lymph node, all stations 16A, B, C, D, both, all we do, all four.
That is, now that means that we are challenging the, I wouldn't say dictum, but accepted philosophy of many centers that para-aortic node positive is as good or as bad as metastatic disease, so no surgery. But so that means you are kind of making a change there.
Standard is recommendation is these are metastatic, but we have seen if these are good risk patient, they definitely prolong survival in our experience. They are after response, after seeing the biology of the tumor, they are responding, and these patients do well. With PET also, we do PET CT as well as CT, PET CT with triple. Response is metabolic activity as well as size should come down, and even if there is no progression, that is also a sign of response.
So we are clearly segregating one subgroup of stage 4 patient indirectly. We are saying this group of stage 4 patient, there is role for surgery.
I think
indirectly we are saying that.
AGCC 6 and 7, this used to be M1A disease. They were not clubbed out with a disseminated disease. So I think that is that previously it used to be segregated between M1A and M1B. Still it remains the primary chemotherapy.
Okay. So are you trying to define a subset of oligometastatic disease?
Yeah, I think it is a we have published our experience. This is not a prospective. These are very selected. That is why next step should be that once we do a new prospective neoadjuvant trial, then this will be one subgroup of patients. But in our experience, they have a reasonable better survival as patient as compared to patient in which we have not operated.
Survival may be due to only better tumor biology.
That is why. That is all the neoadjuvant chemotherapy. If you see if you see from pancreatic cancer, all the neoadjuvant chemotherapy is only helping in select good risk patients, good biology of the patients. This is the basic.
Good biology patient should have, one group should have surgery, one group should not have surgery, then we should follow and then we should have result and then we should say ki
that is right.
Sir, my point is we should define guidelines on the basis of evidence available.
I think Dr. Nag, there are a lot of data from Japanese and Korean studies. They have also shown even in irritable the survival is better in T4 and N2 disease. All these data have shown at least 20% 5-year survival they have shown in a Japanese study also.
No, I think we have to discuss from the standpoint of what we are aiming at in today's meeting, this meeting. So if we are trying to make some consensus, then see, for every cancer we are trying to extend the boundaries. We all know that even in T4 advanced age, there are subset of patients who will do well. So by giving neoadjuvant, by waiting, you are just trying to define the biology better. It's not that neoadjuvant is a game changer. I personally feel that after going through all the literature, so many cancers, there are very few cancers where neoadjuvant actually has shown to help per se. It is basically you are trying to define the biology better. Those who respond to neoadjuvant are actually better biology. So this is a small subset. I don't think we can just publish a recommendation for this small subset. We should have a publication. Absolutely agreed. Japanese have published, they have been publishing for years about those advanced cases which the Westerners said that they are unresectable and you should not resect. So the philosophy is different between the East and West regarding the outcomes of surgery. But I would say that once we are talking about making a not guideline, even if consensus, and it's for people who are
this setup is only for increased discussion between among the peers,
yes,
so that we can move forward to what should be next
step. It's good, but if we are trying to make a consensus on something, then we should stick to broad topics. We cannot change the world in this single meeting. Okay, go ahead and do, if you find a parietic note, it becomes very confusing.
That is why at present we can't recommend.
Yes.
But in selected group
you can publish anything these days. In every cancer, all metastatic cancers don't die within that 3-month period. That's why they always put a range 3 years to 1 year.
To neoadjuvant, only that subgroup is going to benefit. Sir, so one more comment about the chemotherapy part. Like in the CA breast colon, it has made significant difference, neoadjuvant chemotherapy. Same thing about the GB cancers, like yet the molecular biomarkers which will be guiding us for the neoadjuvant and adjuvant therapy is yet very much in progress. Even vaccine is also being attempted. So if we are able to identify certain biomarker, then biomarker-driven treatment, including immunotherapy, may be useful in particular subset of patient. And again, agreed that all patients with GB cancer do not respond to neoadjuvant chemotherapy. It is ultimately the surgeon's decision and surgeon's domain for GB cancer to treat.
So the last question of discussion of the this is. So last one thing I want to include in this discussion, irrespective of the stage of the disease, if we get to know the patient has a bile leak intraoperatively, so can we defer these patients for reoperation or re-resection irrespective of the T stage? House is open for if you are agree or not. Should we go for surgery or should we not go for surgery? Okay, so from our discussion, we know mainly the contraindication of the reoperation is we know like one of the discussion of the intra-aortic cable lymph node positive, the matter of debate is here, but the question was the LVI, PNI, and the grade 3 tumors is still the debate is there. Should we go or not? So we have discussed many things. Yes.
South it was fairly common and they had the best prognosis, the papillary tumors. So they will not have a margin positive, but for instance they will need a bile duct resection. So those were the I think probably of the long-term survivors, the largest group cohort was from the papillary tumors. Even, although it wasn't all that common, but those are the ones which had. So whether we should be having any, sort of recommendation for papillary tumors?
Usually not associated with stones. It is the tumor which is more frequently seen in the Japanese series. It has less propensity to metastasize to lymph nodes, but it has more propensity to have multifocal or multicentric origin. That is why CBD resection is recommended by some Japanese groups. And yes, they have better prognosis.
We've had recurrences even after 15 years also.
In papillary tumor, if you haven't done a CBD resection, many groups recommend that even if otherwise not indicated, you should give adjuvant chemotherapy.
The last one more contradictory thing was there, sir. Cystic duct margin was positive, CBD was resected, but there is no difference in survival. Should we go for resection or not? Yes or no? So yes, should we go for resection or what the house says for this? If the CBD is cystic duct margin positive, should we go for CBD resection or not? One of the paper was showing that. We should do CBD resection. Thank you. Thank you for the discussion.
Thank you, chairpersons and dignitaries. Next, we would like to address the question number 15, which is the timing for reoperation. I would like to invite Dr. Ram Naga sir, Professor and HOD, Department of Surgical Gastroenterology, SMS Hospital, as a chairperson. Please, sir.
Session whether to operate or not to operate, what are indication contradiction, now when to operate, this is our new question now. So we have a lot of controversies regarding this question, whether to operate early, immediately after initial surgery, or should we wait for some time, or should we wait for longer time. So for this discussion I would like to invite our first speaker, Dr. Shraddha Patkar. Ma'am, please.
Thank you, Dr. Kapoor, and the entire organizing committee. After a brainstorming couple of sessions regarding what should be done before for staging for incidental gallbladder cancer and who actually constitutes a surgical candidate, we come to the next contentious issue is what is the exact timing of reoperation for incidental gallbladder cancer. As we've agreed that there is dearth of evidence, we don't have randomized trials and are unlikely to have it in the near future for the management of incidental gallbladder cancer. The timing remains controversial. We don't have exact evidence for the same. And the fact remains that here we are trying to balance two factors, to address the biological aggressiveness of the tumor as well as to facilitate a safe surgery, avoid post-op inflammation, and with patient safety as a priority. The question which was given is to address the timing of revision surgery. We did a literature review, reviewed around 76 abstracts, of which we obtained 10 full texts in English, and finally selected 7 studies for addressing this question. I will review some of the important ones. One of the earlier studies which was there, this was a US extrahepatic biliary malignancy consortium, and it was a multi-institutional analysis, retrospective as expected, where patients of incidental gallbladder cancer who underwent revision surgery were divided by the timing of revision surgery into 3 groups, less than 4 weeks, 4 to 8 weeks, and more than 8 weeks. And other tumor characteristics were more or less balanced in all the 3 subgroups. What they analyzed was the patient who underwent reoperation in between 4 to 8 weeks has the longest median overall survival as compared to the early and the late groups. closer home, when we looked at our own data, which is a single institution study of 382 patients, we divided the patients into 4 groups: less than 6 weeks, 6 to 10 weeks, 10 to 14 weeks, and more than 14 weeks. The reason for this 4 subgroups was we analyzed our own data and found that the median time to revision surgery in our cohort was around 10 weeks. So if we were to take something which the previous authors were to take, we would have a skewed distribution among the subgroups. So this is what we chose. The baseline characteristics, except for the T stage, were comparable. Hence, we did a propensity matching after matching the 4 time groups with respect to the T stage, and we had 74 patients in each group. And the survival advantage in the group C was better compared to the rest. Again, a data from China, which is a retrospective study, a small subgroup of 80 patients, where they divided it into 3 groups: early, which was 2 weeks, 2 weeks to 4 weeks, and more than 4 weeks, with again baseline comparable characteristics. The median subgroup in the early, this study actually showed that the patients who were operated earlier, that is within 2 weeks, had a better survival and a cumulative 1 year, 3 year, and 5 year survival rates, which were better than the other 2 subgroups. Another small study of 65 patients looked at time periods which were similar to the earlier studies and also identified predictors of early recurrence after surgery. This said that on multivariate analysis, T3 disease, node positive, poor differentiation, presence of LVI were identified as risk factor for early recurrence with comparable survival between all the 3 subgroups. However, when analyzed for patients undergoing surgery with early recurrence risk factors, surgery timing between 2 to 4 weeks portended a better survival. However, with patients who didn't have these early recurrence factors, there was no difference in survival. This is another study with around 95 patients of incidental gallbladder cancer with, again, different subgroups. The problem with analysis or the literature review for all these is the timing is variable. It mainly depends on your institutional referral pattern when a patient presents to you after index surgery. This study chose a subgroup which underwent early surgery between 4 weeks, intermediate between 4 to 12 weeks, and late just after 12 weeks. Again, this study showed that patients had a better overall survival in the early subgroups as compared to the intermediate and delayed subgroup. This is one of the largest retrospective review, which is the National Cancer Database Study, and patients were here again divided into 4 subgroups: less than 4 weeks, 4 to 8 weeks, 9 to 12 weeks, and more than 12 weeks. The survival here was appreciated in patients who were operated in between 5 to 8 weeks as compared to the early subgroups. However, there was no survival difference in between whether the patients were operated in between 5 to 8 weeks, 9 to 12 weeks, or more than 12 weeks. So ultimately, at the end of this, there is a confusion. We know that there is a trade-off between doing a safe surgery, that is delaying a little bit further, and timely removal of the residual disease to possibly achieve a cure. We don't have still great evidence to show that revision surgery is actually improving survival. What it does, it actually gives us a better staging of the disease. No strong evidence to support early intervention versus delayed. We know gauging the disease biology is important. We very often don't have intraoperative events which have happened at the time of index cholecystectomy. We have discussed this, whether bile spillage occurred, didn't occur. Most often we don't have exact T-staging of the disease, which ultimately impacts survival. The rationale for buying time for restaging and delayed surgery is to identify unresectable or metastatic disease and possibly avoiding a futile laparotomy. And in a small subgroup, offering neoadjuvant therapy to downsize these patients to select patients with favorable disease biology and then offer revision surgery. So I would like to just conclude that I think the verdict is still out. We don't have a clear answer as to what is the standard time of revision surgery following an index cholecystectomy. A general guideline recommendation which we can all discuss is to restage probably after 4 weeks, proceed with revision surgery. If it is easily resectable, there is no significant residual disease or a nodal burden which is encountered, or possibly offer some neoadjuvant therapy and reassess if a locally advanced disease is found. Thank you.
Thank you, Dr. Shraddha. Now we'd like to invite Dr. Shalin Agarwal, our lead commentator.
So Dr. Shraddha has almost covered everything. Most of the good papers have been presented here, and she has already reviewed the literature, but I have also reviewed the same papers. So the message remains more or less the same, but I would like to make a few points. मेरा laptop भी है. इधर लगा दीजिए. So one is, what is the like timing of reoperation? So since this is the question for discussion, so first we have to define what is an ideal time for reoperation. And before that, we need to know, does timing of re-resection impact outcome in terms of survival? Then how to define an ideal timing? So what I tried to put together from the literature is that ideal timing is one that reduces the technical complexity of re-resection by allowing the inflammatory process to subside. At the same time, allows it's long enough for and allows the tumor biology to manifest, and then of course provides the best long-term outcomes. That is how we define an ideal timing of reoperation. And then what is that ideal time? So these are the three questions that came to my mind as sub-questions for this lead question. And so first of all is timing of reoperation. Does it matter? I would say after reviewing all the literature, this timing remains debatable. Dr. Shraddha has already said so. So there are two schools of thought. One just discounts that. It says timing does not impact survival, while there are several studies to suggest that yes, timing is important. But again, in these studies, there is no consensus on ideal time of re-resection, as has already been discussed. So I would go back to Shraddha, your center's earlier publications which showed that timing doesn't matter. There are two papers. You have published a third recently in which you did that propensity score, but the earlier papers clearly showed that its primary determinant was the disease stage and lymph node status, that is the tumor biology, not the timing. So they said that they were in the first paper in 2008, at the time of when Dr. Parul was there, they resected patient even who presenting 11 months after their first surgery, and they did well, could show long-term survival. So the gist of these two papers are that timing does not matter. Well, then the other school of thought is that timing does impact survival. And yes, this paper again that showed that even the operability is not different when you consider the time periods of 1 month, 2 to 3 months, and then more than 4 months. So the operability rates remain the same. That is, you didn't have a lot of fallout because of patient presenting with advanced disease or metastasis, nor does the timing impacted the outcome. Now coming to the other school of thought, which says that yes, timing does matter. But here again the controversy. So whether to resect early, that is within 2 weeks, this is the Chinese paper you quoted. So there are two Chinese papers, one says that within 2 weeks is the best time period, other says if you operate within the first month, it gives the best results compared to patients who are operated at longer intervals. You have shown, I'm not going into the details in terms of difference in survival advantage, but there was a significant survival advantage if you operate early. This is what the Chinese go to say. But then you have these widely quoted papers, the Ethun's paper, which is a multi-center study from US published in JAMA. But actually, if you go into this paper, there are 10 centers, collected data over 14 years, only 207 patients. So there's wide variability. And they have clearly gone on to show that if you operate within 4 to 8 weeks, you get the best outcomes, that is 40 months versus 20 months. But in the same issue of JAMA, the editorial board has criticized this paper by saying that although they have shown that there was no difference in the stage of the disease, but in terms of actual numbers, the patients who were operated late had higher T3 patients, though the difference was not statistically different. And then each group, the number of patients were very small to make any significant comment on statistical outcomes on the basis of statistical analysis. So there are criticisms for this paper, although this is widely quoted and published in a reputed journal, but it said that 4 to weeks is the best time. But again, if you go to the SGPGI paper, they say 4 to 12 weeks. So first we have no consensus on what is the intermediate period. First was Chinese said operate within 2 weeks, that is the best. Another Chinese paper says operate within the first month. Then we come to this more widely quoted papers which say within 4 to 8 weeks or 4 to 12 weeks, and then there is a Brazilian consensus and there is another consensus. Due to, in the interest of time, I have not put all the papers, but 4 to 8 weeks have been recommended. Again, these are some consensus coming from different part of the world, but still there is lot of confusion. The reasoning which has been given is, we have already talked about it, that it allows time for the inflammation to subside, gives you a better chances of staging, there is reduced technical complexity, and then waiting beyond this may lead to dissemination. But the data doesn't support that. So, and then there is paper which says that late resection is best, that is late means after 3 months, because it allows the tumor biology and occult disease to manifest, and therefore it avoids unnecessary negative laparotomies, because many times even at staging laparoscopy you miss a disease and you land up with negative laparotomies. And 4 to 8 weeks, although it's widely quoted, may not be enough for inflammation to subside, which is often quoted as the reason for doing the surgery within 4 to 8 weeks, because the inflammation subsided, but that may not be true in all the cases. So in nutshell, I can say that, one, there is no consensus whether timing impacts outcome or does not. Second, even if we consider for once that yes, it impacts, then what is the ideal time? There is no consensus on that. Different papers from different parts of the world have given different time intervals, less than 1 month, 1 to 2 months, 1 to 3 months, more than 3 months, all showing good outcomes, all showing good operability rates. So there is no consensus. And when there is no consensus, that means that is a gray zone, and probably the previous papers saying that timing may not be the most important thing, that stands true. So my final comments are that re-resection improves survival, we all know, and that stages. And as we said that even in T1A, where you don't have clear-cut histopathology or about the surgical details, you should go for re-resection. So we should go for re-resection. But tumor biology, as with almost all cancers, is the most important, which includes the T-stage differentiation, microvascular invasion, nodal metastasis, residual disease at the time of resection, or detect residual disease. And therefore, R0 status at re-resection, that justifies re-resection, but you have to achieve R0 status. But again, achieving R0 status is not as important as the presence of residual disease. And probably that correlates with the advanced stage of the tumor. The higher the tumor stage, you are more likely to have residual disease. Timing of re-resection is probably not as important, so we should not harp a lot on this issue. International, not guidelines, but consensus statements which are based on these papers have suggested 4 to 8 weeks for ideal time of reoperation, but individual studies, as we have talked about, have supported all time frames. So re-resection should not be denied to a patient who is presenting beyond this time limit of 8 to 12 interval or coming early. We may ask, but if sometimes you have to look at the ground reality, and if the patient is very anxious, we may, after doing that staging, we can go for early resection, we can stick to this. So it all depends at what time the patient is presenting to you, rather than sticking to a fixed time frame. That may not serve the patient well. So more important is the role of thorough preoperative staging, though you may fail even after that. So review of previous histology, talking to the surgeon, getting the notes, PET-CT, CE-MRI in selected cases, and then staging laparoscopy cannot be overemphasized. So more than the timing, it is the nature of the disease, presence of residual disease, and then whatever time it is, stage the patient thoroughly before you go for re-resection. Don't stick to fixed time intervals. That is what I got from all the literature. Thank you.
Thank you, Dr. Shalim. Now we have online comments from Professor Orlando Georges from Brazil. It's recorded, or?
नहीं है, मैं पहले चेक कर नहीं सर, उसमें से आपने कर
Right, sir. So, as we have heard both the speakers, still there is no consensus on what is timing, what is early, what is intermediate, what is late. Still we don't have even that consensus. So timing of surgery we cannot make out as such right now. But I have some questions from the house. Whether location of tumor in the neck surgery will change your timing of surgery, reoperation.
think that is very important.
Whether it's
I
a
think
fundus
that's
or at the neck of the gallbladder.
No, I don't think I would wait for just because the site is different. You can say that the prognosis may change. Tumor on the peritoneal side penetrating the serosa has a higher likelihood of disseminating peritoneal dissemination early rather than those on the liver side. But its impact on my timing of operation will not be there. It may impact the outcome. I may do more staging and more investigation if it's a tumor which is likely to have on the peritoneal side, but it won't impact my timing.
So what about fundus and neck lesions, sir? One of the reasons is at the neck of the gallbladder.
I don't think it will impact the timing. As sir rightly said, it may impact our preoperative or pre-staging workup, whether you want to look at the patterns of spread and ultimately decide which tumors are going to behave adversely. But I don't think it has an impact on the timing of surgery.
So what is your selection? How do you select? You
No, I don't think again it makes impact on timing of surgery. You again it may you want you may, on the other hand may want to give neoadjuvant therapy.
Dr. Shraddha, what do you recommend? Early at the immediate after surgery or after 4-week interval, or what do you recommend?
So I'll tell you, based on our experience, our index time of presentation of most of our patients is 10 weeks. So at 4 weeks is a reasonable time to restage the patient, and if the patient at that point of time is non-metastatic, then he or she definitely warrants a resurgery.
But patient come early, suppose after 2 weeks, then what you will do? Will you operate at the time, or you will wait for 4 weeks or 10
I
weeks?
think it's subjected to staging the patient, and if after an informed consent and informed decision making with the patient that this is what it is at this point of time, you don't have any residual disease. So it's fairly warranted to subject the patient. We don't have great evidence to suggest one or the other. So as long as the patient on restaging is non-metastatic, I don't think you can deny a patient a resurgery at that point of time.
Will you like wait? Will you like to wait for that time inflammation to settle down?
Ideally, yes. So 4 weeks is the cutoff which we've used in our practice for now.
Dr. Shalin?
Again, so just a small subset of patients, because if you, as you said with the previous question, that if the margin is positive or it's a bad biology. So if you have a trial going on and you want to attempt or try neoadjuvant, then the timing may get delayed. But otherwise, I won't like to wait. Whenever the patient presents, do a good staging and go for reoperation, because as literature shows, there is no ideal time. Even the Chinese are saying operate as early as possible. But most of the patients in real life scenario, until unless it is your own operated patient, will present towards the end of 1 month, that is 3 to 4 weeks. So even if you are not choosing, most of your patients, if you look at your data, would be get operated automatically within that time.
So my question is, if they present early at 2 weeks in the house, how many of you will operate in as early as possible?
We'll go for operation early. So as I said in my talk, don't stick to fixed time frames.
Just a small question. Are we doing the same surgery? All the data, what we are seeing, Chinese, Tata, SGPG, no. Okay. So that is the foremost important. When we start comparing the results of early surgery and late surgery, we have to admit that we are not doing the same surgery. Okay, that is one. Probably why the difference is coming, because in centers who does aggressive surgery, I think majority of them go early. Probable reason I assume is the window period of spreading and the benefit you are getting by little bit extending your surgical margin in terms of lymphadenectomy or liver, those subgroup may get benefit. Other way, whatever you do, whichever time you present, you do a small wedge resection or liver and you do a standard lymphadenectomy, definitely it is not going to change your outcome.
I totally agree.
So
with
this
you
is
that the extent of
what I am trying to
surgery
tell is,
we'll discuss that.
Yeah.
But extent is not going to make any difference. It's been shown best. Maybe by doing extensive lymphadenectomy, you may have a stage migration. But in terms of your surgery making an impact on the outcomes, I don't think the two procedures.
No, I'm just talking about timing of surgery.
Yeah.
Timing of surgery.
And yeah, coming to that, I think in this era of lap polycystectomies, actually there's not so much of inflammation. We have seen repeatedly, if you have operated early, there's no harm in operating early.
So that's the question I wanted to ask the House. We seem to have this equipoise between inflammation to subside, and is there so much inflammation after a simple cholecystectomy?
Yes.
What have all of you
I've
felt?
not seen that much of
Because this is what actually I want to ask actually.
I've done only.
We can have cholecystectomy for empyema gallbladder, or we can have cholecystectomy for simple gallbladder. So will it?
These are, see, each individual case.
No, not the inflamed, not the bile leak ones.
Yeah.
Yes, sir. Not the
Apart
bile leak
from
ones, but
these
inflamed.
two, has
In
anybody
any
had
case, a
problems
patient empyema
of
with
inflammation?
incidental CAGB or bile spill will
Even
have
for
an
1 week,
inferior
you've
outcome.
had?
Whether you wait or don't wait, they will have inferior outcome. So better to put them into trial of new adjuvant. See, new adjuvant is not a standard procedure for CAGB till date. There are a lot of papers coming up, but maybe it becomes standard. So start a trial and then put them on new adjuvant rather than wait for just wait. Pure waiting is not going to help.
So because staging can take in hardly 2 to 3 days nowadays.
I have two philosophical questions. If you see an early primary gallbladder cancer, suppose you have by chance detected it, looks early, would you wait? Then why wait for an early incidental gallbladder cancer? Second question is, the data group said T1B PET negative, when they reoperated, they found no residual disease. So which means reoperation was not required. On the other hand, you say if there is a residual disease, outcome is poor. Reoperation doesn't help. So how do we solve these philosophical issues? And my question to those who recommend waiting for 4 weeks, 8 weeks, and I think it is in SCPGI paper, it is 4 to 12 weeks, the intermediate group. If you are diagnosing, suppose a patient comes to me at 7 days with a histopathology report of incidental gallbladder cancer, whether I do a PET scan today or suppose I do a PET scan as we all agreed and it shows no residual disease, do I tell the patient go back after 12 weeks, then I will reoperate? Will any patient accept it? So that is different. If a patient is coming late, you have no choice. That is not the discussion. Discussion is when the patient has come to you on day 7. But the problem is these two papers are giving rise to guidelines or recommendations saying that wait, which I think is wrong.
So
if we look at reoperation from non-malignancy, normally in the first 7 days, we don't have vascular inflammation. We don't, it is all simple adhesions. So with that, at least the worst time is around 2 weeks or so. So I don't know where that cutoff came. If it's 2 weeks, then we wait for another 2 weeks or so till it settles, the vascular bit settles.
So SGBJ paper.
So the caveat to all the papers has been they have chosen timelines based on the referral pattern to their own institution. So if obviously, as sir said, that if you have a patient who's going to refer to you after 4 weeks and that is your median time of presentation, naturally you are not going to have patients refer to you at 2 weeks, and the experience of doing an early surgery or even proposing anything gets nullified. So
you might find on the meta-analysis it's their median time is what they're recommending,
exactly.
Which is ridiculous. I think we should probably meta-analyze that.
And since we have so many time intervals, I think timing doesn't impact at all. I would say that we should operate when it's over.
We are talking of referral. So you have done a cholecystectomy. The incidental report comes after 48 hours, 72 hours.
Do that as quickly as possible.
So you won't wait, right? So then the timing is irrespective of referral or whatever. So perhaps the conclusion would be that based on the disease factors and the T stage and all other things which we said, if resurgery is warranted, should be done at the time of presentation, period. Which you would agree with that?
Practically, there won't be much inflammation. Okay, we are unnecessarily talking about inflammation in the hilum. There won't be practically nothing. It never pose any challenge. That's what my experience. And I don't discharge a patient who is diagnosed with carcinoma gallbladder incidental gallbladder and go home and come back. I feel it is beyond my limit.
I think this confusion arose from the MSKCC paper in which they said the reoperation was difficult and increases the chances of bile duct resection was higher because lot of inflammation was there. They were not able to decide whether it was inflammatory change or it is malignancy. And that is why the timing of dilemma came up. But that is why if you do very early, sometimes additions are so that you feel that you have not done the ideal lymph nodal dissection that you would have liked. So many times it, because of dense inflammation, sometimes problems are there. But in our analysis, we have also realized we have categorized within less than 4 weeks, 4 to 8 weeks, and we didn't find any difference in survival or resectability rate. Slightly, blood loss was slightly higher in the early group, maybe because of a result, but not much difference. That was also noticed.
Before deciding the timing, will you not ask the surgeon, previous surgeon, what was the condition of Kellert's that time? What was the condition of gallbladder that time? Because it depends on that. If the condition, you must talk to the surgeon and ask that what is the condition of the gallbladder. If the condition of the gallbladder was bad at that time, I think you must wait in. So timing depends on the type of gallbladder which was there at the first operation.
I think it is very difficult to get all the information from surgeon, but most of the time once you do a CT scan, many times you find there is a lot of inflammation is there and that area is not good time to go ahead with surgery. That many times you will find lot of collection is there, sometimes all loops are adherent on those areas, many times you will find on CT scan. But how to not operate these patients, that is very difficult. So we started a trial around 10 years back for giving neoadjuvant in these incidental gallbladder cancer in which these are T2 or T2 or more, but we were not able to recruit more than 10 patients because the patient will go at multiple places and there is no guidelines to give neoadjuvant chemotherapy, there is no time to restop the trial. So we operated at present and we didn't find any difference, statistically difference in survival or any resectability rate.
Sir, if I am interpreting it correct, if the patient comes to you after a week, you will do a PET scan first. And PET scan shows a nodal disease, you will send him for a neoadjuvant. If the patient does not show any disease, this is the only patient whom you will do a extended chole now. If the PET shows nothing, then do a so if you find PET scan normal, that is the only indication for extended chole. So the only reason.
Only gallbladders which would be bad are the ones which are, since this is IGBC, are the ones where the gallbladder cancer is obstructing the. So, I mean, the question somebody asked, will the location make a difference? Possibly yes. Because if that is causing the inflammation, then it is probably better for it.
Sir, I have one query.
To answer Dr. Shaline's question, that PET scan, if it is negative,
Sir, I have one
the
query.
only indication to do an extended chole is to have a histopathology of a nodes that they also support your diagnosis that he will have a better stay.
Okay, I think now we should move on to our next session.
We'll be having a short tea break. Yeah, thank you very much, sir. We'll be having short tea break for about 15 minutes, so kindly proceed. Welcome back everyone. We'll be starting the session now. We'll take question number 16, that is neoadjuvant therapy before reoperation for incidental gallbladder cancer. I would like to invite the chairpersons, Dr. Lalit Mohan Sharma sir, who is senior consultant hematologist and medical oncologist at the Department of Medical Oncology, SRCC, Mahatma Gandhi Hospital, Rajasthan, and Saurabh Kalia sir, who is senior consultant, Department of Surgical Gastroenterology, CK Birla Hospital, Jaipur. Welcome sir.
So very good morning once again. And next session is on the new adjuvant therapy in gallbladder cancer. And to deliver this talk, may I request Dr. Safalta. Dr. Safalta, she is senior consultant in the Department of Medical Oncology and Cellular Therapy at Amrita Hospitals in Faridabad. Welcome to you.
Good morning to all, and thank you, Dr. Kapoor, for giving me opportunity to express my views in such an important meeting. I am presenting few slides of Dr. Piyush Varshney, who has some family emergency. We'll discuss about the new adjuvant therapy in patients of incidental gallbladder carcinoma. So we all know for India, it's the most common biliary tract cancer and contributes 10% of the global GBC burden. Incidental gallbladder carcinoma, it has 0.3 to 1.5% of all the cholecystectomies done. And we all know it depends like 20%, depending on the stage, it can be 20%, 50%, 100% of the patients who have residual disease after initial cholecystectomy. So resection, yes, we have discussed it in vast in previous sessions. But do we have an all non-operative management? So GBC, as we all know, has strong predisposition for peritoneal seedings, and when the gallbladder, as such, when the resection is done, presuming it's a benign gallbladder disease, then there must be a violation of subserosal plane during cholecystectomy, and which may lead to dissemination of the cells. So theoretically, it negates the benefit of re-resection. But then, despite of that, the re-resection has been associated with improved oncological outcomes. In a French study, 5-year OS was 41% for the patients who had underwent re-resection and 15% who did not underwent re-resection. There are multiple single institutes and multicentric trial from the Japan, Europe, US that has observed that re-resection is beneficial and it has given overall survival advantage. Median OS of 26 months in patient who has undergone resection and 5-year OS of 35 to 42%. So this is the study which was in previously quoted as well, that is from Netherlands. 110 patients, they underwent re-resection, and out of 432. And here we can see that the patient who underwent re-resection, they have median OS of 52.6 months versus 13.7 months in the patient who did not. And you can see how beautifully the curves are separating. But here you also see that the patient who had T2 disease, the re-resection really helped, while the patient who had T3 disease, it did not. And the patient, definitely it is understandable, the patient who had re-resection and again there is a residual disease, then outcome is inferior. So the T1A, as such it has been discussed, so I'll skip this slide. So currently what is being followed is, if there is no residual disease, then no residual disease on investigation, then it is revision radical cholecystectomy. If there is residual disease, people do tend to treat it as a locally advanced gallbladder carcinoma. But why NACT, that is neoadjuvant chemotherapy, immediately treats the micrometastatic disease, optimize patient selection for surgery for curative intent resection, allows in vivo assessment of chemosensitivity that can guide future management, downstaging primary tumor, favors treatment compliances already given in other GI malignancies. As we see that there is level 1 evidence for resectable gastric cancer, borderline resectable pancreatic malignancy. And we also know that GBC is also having this predisposition of micrometastatic disease. It has the same poor prognosis as these malignancies are. It is also having an early recurrence, it also has a distant recurrence. And based on these experiences, can't we try a neoadjuvant approach for gallbladder carcinoma patients? And that can be considered in high risk for early distant recurrence. So what are the criteria for successful NACT, that is, assess the tumor biology, and we should know who to be given so that we can minimize the toxicity and what should be the effective chemotherapy regime. So patient selection is the key. Important to select patients who are likely to benefit with the neoadjuvant chemotherapy, and so that, because if we use it indiscriminately in low-risk patient, it will impair the functional status, delay surgery, make surgical intervention riskier, and compromise the surgical candidacy. So who are the high-risk patients? We have already discussed, and in fact the patient who have higher risk of micrometastatic disease, advanced T-stage, node positive, patient who are having residual disease, hepatic versus peritoneal location of the disease. From a TMH study, it has shown that the patient who are having locally advanced or borderline resectable GVC, it has shown a good response on neoadjuvant chemotherapy. And it also helps in identifying the high-risk patients. So what was the TMH criteria? Here we can see that low-dose station, what they have mentioned is hepatic artery, station 8, hepatorenal ligament, and retropancreatic and retroduodenal state. And the size of the node should be more than 1 centimeter in short axis, round in shape, and heterogeneous enhancement on CT or PET-CT scan. And for incidental gallbladder, it is any residual disease, recurrent mass in GB and liver bed, and one node as per nodal criteria, and if there is involvement of bile duct causing obstructive jaundice. Now coming to the dose neoadjuvant chemotherapy studies, there are very few retrospective, and usually the management is extrapolated from the gallbladder carcinoma. So from where we got this regime, that is GEMSIS, it is from the ABC02 study, and which has shown an overall survival benefit, because in this study also locally advanced gallbladder carcinomas were included, and gallbladder carcinoma patients were 149 in this study. Coming to the retrospective studies on incidental gallbladder carcinoma. So this is also from TMH, in which they have analyzed 160 patients in which neoadjuvant chemotherapy was given. They also included incidental gallbladder carcinoma patients, but we don't know the exact number in this paper. And those patients who had high-risk disease, that is the TMH criteria, which I have already mentioned. Here we can see that these patients, all the patients, in 160 patients, the response rates were 50%. And 66, that is 41%, could undergo curative intent resection, and R0 resection was done in 63. Out of 66 patients, R0 was in 63 patients. And here we can see that the patient who underwent this curative resection surgery, the OS was 49 months versus 7 months. EFS was 25 months. So definitely, neoadjuvant chemotherapy has really helped in these patients. Another study from MSK. Their data was of 74 patients, out of which 25 patients were of incidental gallbladder, and 25 years they had shown a disease progression, 50% had stable disease, and 25% had partial response. Their definitive R0 resection was just 14%, and these 14% patients have shown an OS of 51 months as compared to 11 months in the rest of the patient. Another study which was already being quoted in the previous presentation, in which 517 patients of incidental gallbladder were analyzed. Here we can see that there was about 135 patients, they received neoadjuvant treatment. And the patients who received neoadjuvant treatment had superior OS when operated after neoadjuvant therapy as compared to the locally advanced disease patient who did not undergo neoadjuvant therapy. The 3-year OS was 60% versus 32.3%. So there are some smaller series from TMH and from Japan who had shown some about 60% response rate, and in Japanese study the response rate were lower. But there is some other perspective as well. This is a systematic review which was published from Kashmir, and they analyzed 6 published studies of 420 GVC patients. And they have seen that 30% of the patients had disease progression despite of neoadjuvant chemotherapy. 67.3% patients, yes, they show good response to chemotherapy, but just 1/3 underwent curative surgery. So yes, the OS is better in these patients, but only 1/3 of the patient actually benefited from the GPC. So we also agree that not all patients will benefit from the NSAT, and we will have to find out those patients who actually get benefit with the neoadjuvant chemotherapy. This is an ongoing trial from Germany, that is a GAIN trial, and they are doing it on new incidental gallbladder carcinoma patients. That is, they are giving to locally advanced incidental gallbladder patients a perioperative chemotherapy, that is 3 cycles of GEMSIS, then surgery, and followed by that 3 cycles of GEMSIS, and which is compared by upfront surgery, that is resection, followed by whatever the investigator has planned for. The inclusion criteria is, if it is node negative, then T2, T3, and if it is node positive, then T1 to T3 patients will be included. The primary endpoint is OS, and we will be getting the results soon. They have suggested like 2025. Now, any role of NACTRT. As such, we don't have any data on NACTRT in GBC or incidental gallbladder carcinoma. Ning Ma et al. Has analyzed had done some meta-analysis, and it has shown that the patient who received adjuvant chemotherapy had better OS than patient who received CTRT or RT. Polka GB study that is also ongoing in TMH, and this is a phase 3 randomized trial which is evaluating perioperative chemotherapy versus NACTRT in locally advanced GBC patients. So this will help us in further extrapolating or defining its role in incidental gallbladder carcinoma. For how long to be given neoadjuvant chemotherapy? ABC02 study, it has given 3 to 4 cycles. GAIN trial is giving 3 cycles. So 3 to 4 cycles of chemotherapy can be given to any of the patients who are actually fulfilling the high-risk criteria. So consensus statement from our side is literature for neoadjuvant chemotherapy in IGBC is scarce and yet to be validated. Incidental gallbladder cancers, they usually present in early stage but should be benefited most with a resection. The certain patients of IGBC, they are beyond T2 and have no positivity. We should consider for them for neoadjuvant chemotherapy, as well as the patient who are benefiting, are in the high risk criteria from the TMH. So, however, there is a subpar response of NACT raises a possibility of local progression of unresectability, and chemotherapy side effects can worsen the functional status. So we have to select the best treatment plan according to the patient and the risk the patient has. A GAIN trial may help to better define the management. Till that time, we suggest that T3 and N positive nodes can be given neoadjuvant therapy. Recurrent mass, or there is a residual mass in the GB or liver disease, N1 node as per nodal criteria, or the patient who is having involvement of bile duct causing obstructive jaundice can be given neoadjuvant chemotherapy. This will help us understanding the tumor biology, downsizing the tumor, eliminating the micrometastasis, taking care of intraoperative events like gallbladder perforation with bile spillage during dissection. Thank you. That's all from my side.
Thank you, Dr. Safalta, for such a nice talk. Actually, this is a very debatable topic. Still, NCCN does not have a clear guideline that neoadjuvant therapy should be given. But for surgeons like me, we would like to resect if it is possible to do a R0 resection. Obviously, when you see a residual disease, patient has been operated somewhere else, and we need to see the tumor biology. If the tumor is already spread, micrometastasis may be there. So giving some time to the patient while giving chemotherapy, we can see if the patient will justify the big surgery. So if the trials that are going on will come up with better drugs, or time will tell actually if neoadjuvant therapy will be very important in this type of tumors. So, yeah, thank you.
Congratulations again for Dr. Kapoor and the team on this incredible meeting that we wish we next time hopefully will join in person. Again, also congratulations for Dr. Varshni and Dr. Bagmar on excellent work in regard to neoadjuvant treatment for gallbladder adenocarcinoma. This is Ghassan Abu Alfa from Memorial Sloan Kettering Cancer Center in New York. Superb subject and very important, understandably for India, but globally too. Gallbladder cancer, after all, is an issue that comes along because of a concern about a direct extension into the liver and the adjacent organs, including lymph nodes. Why is that? Because, as we heard, the thin wall of the gallbladder, a narrow lamina propria, and of course a single muscle layer. And as such, and very important to define the word neoadjuvant. This is not conversion therapy. This is a disease that already is amenable for resection. We're not trying to convert it to become resectable, but the question is, can we give some therapy beforehand and then proceed with therapy afterwards, with the surgery afterwards? By all means, we can and we should. However, clinical trials are needed for that purpose. Many of them are ongoing. Proudly, many of them are in India. Others are throughout the world. But sadly, collaboration is not there. And if anything, it will be very important to join in hand to be able to gather the best information that we come out with in regard to how to best treat the patients with gallbladder adenocarcinoma. And of course, this brings up the question of incidental, because know that many of our colleagues, not necessarily in the cancer domain, being surgeons or oncologists, are involved in the care of a incidental gallbladder mass. And the question is, how can we pass on the information for all our colleagues to make sure that whenever you feel, smell, or see a potential gallbladder carcinoma, just close the patient and make sure that it gets to the correct experts for a potential neoadjuvant therapy, followed by an appropriate resection, which include, of course, the gallbladder, as well as the segments potentially affected segments of the liver, segment 4 and 5, plus the lymph nodes. How should we do that? We should really first do a joint trial throughout the world, and number two is devise the teaching venues to ensure that our colleagues will do what's right for our patients with gallbladder carcinoma. I thank you again, and hopefully we'll have a continued great meeting, and thanks for the invitation.
Thank you. Next is Dr. Milind Javedi ji online. Okay.
Kapoor for first holding this meeting every year. It's certainly a labor of love. And second, also for inviting me to give this introduction on the case for neoadjuvant therapy for incidental gallbladder cancer. My name is Milind Javle from MD Anderson Cancer Center. So gallbladder cancer is a rare disease of the West. It is estimated between 7,000 to 9,000 patients are diagnosed every year in the US, certainly more in Chile, Japan, India. And majority of the patients are diagnosed incidentally in the US at the time of cholecystectomy, which is different, I know, from what we find in India, and 30 to 50% may present with advanced stage of disease. In fact, the cancer is discovered in about 150 to 200 cholecystectomy specimens, one in every 150 to 200 specimens, and is associated with a relatively poor survival. The prognosis following surgery has improved, but it certainly depends on the extent of surgery and now perhaps the administration of adjuvant therapy. So we know that patients who have incidental gallbladder cancer who undergo re-resection have a better survival as compared with those that do not undergo re-resection. And the table here shows the survival 1 year, 3 year, and 5 year survival after re-resection as compared with those that underwent just simple cholecystectomy. And the prognosis after the re-resection is T-stage dependent. So certainly if it is T1B, T2, T3, or T4, the likelihood of recurrence and poor prognosis is going to increase proportionately so with the T stage of the disease. So therefore, in the consensus guidelines that I was a part of, patients who are incidentally diagnosed with T1B, T2, and T3 disease at the time of simple cholecystectomy should undergo re-resection unless there is a contraindication, for instance, with poor performance status or advanced stage of disease. In this case, the likelihood of recurrence is higher if there's a residual disease at the time of re-resection. And this table here shows the likelihood of residual disease depends on the T stage of the tumor, with a higher likelihood with T2 and T3 as compared with T1A and T2, T1B disease. So the incidence of the presence of residual disease also corresponds with prognosis. So if you have, this table shows that the comparison of disease-free survival with or without residual disease, clearly patients that have residual disease in the presence of say T2 tumors or T3 tumors or T1B tumors will have a worse survival as in comparison with the corresponding stages without residual disease. So this is therefore the rationale for neoadjuvant therapy. In this setting, it decreases the incidence of residual disease, it improves resectability, improves patients' selection for re-resection, and improves survival. So such a study is going on in the United States by the ECOG group led by my surgical colleague, Dr. Mehtal, where patients who are diagnosed with incidental gallbladder cancer undergo re-resection, but they are randomized to either surgery upfront or re-resection upfront versus a course of neoadjuvant chemotherapy with gemcitabine and cisplatin. And then these patients also get adjuvant therapy as standard of care post re-resection. So this study will then establish the value of neoadjuvant therapy prior to re-resection. I want to add here that in the days of targeted therapy, immunotherapy, this paradigm is likely to change as we're going to have more effective therapies than gemcitabine and cisplatin. So again, I look forward to the discussion that follows, and I want to thank Dr. Kapoor again for his efforts.
So now the forum is open for any comments and discussions. So before we take questions and comments, let us summarize that the best treatment for GB cancer is surgery. Patients who are ineligible for surgery or borderline resectable, or patients who have not undergone adequate surgical resection, they are the candidates for neoadjuvant chemotherapy, where revision surgery is to be considered. So it is not the palliative intent, it is the neoadjuvant therapy, where we expect that this patient has potentially a curative intent of chemotherapy. As mentioned, that in patients who have not been adequately surgically resected, the neoadjuvant chemotherapy gemcitabine cisplatin has been backbone, that after 3 cycles or so we do a reassessment, revision surgery followed by 3 more cycles. So gemcitabine cisplatin, 5-fluorouracil, these are the major backbone of the cancer, the gallbladder cancer chemotherapy. So with this brief sum up, may I request the surgeons to have any questions, comments, queries? How many of you believe that neoadjuvant chemotherapy is good for gallbladder cancer? Thank you so much, sir. Thank you. I am so happy that I was feeling that no surgeon ever believes chemotherapy. They believe only in cutting and surgical intervention.
I'm surprised that you gave the comment which you gave. Because this particular, the IGBC is probably the best hypothesis for, you've already breached planes, there will be micromets. This is probably we should be joining that kind of a trial, like Dr. Nag was saying. That we should be doing that trial as well for protocol.
I think what probably, and this is where I would again request the group, Safalta, because you are looking after this question, to generate a statement which could say something like this, that if for whatever reason you are waiting, it could be disease related, so high risk cases, advanced cases, where you want to see the biology, bile spill. If you want to follow one of the publications which say that 4 to 8 weeks or 4 to 12 weeks is better, then probably the patient should receive the benefit of neoadjuvant therapy. Now, only problem is that because it is not the standard of care, whether it would be right for us to say that while you are waiting, you should receive chemotherapy. So that I think we need more input from the medical oncology group, how to frame it, how to frame the statement. And but definitely advanced disease, bile spill,
say these two conditions, or if you want to include, if we have a detailed histology report which is talking of grade of differentiation, lymphovascular invasion and all those things. So poor predictors of outcome, one option could be that you give neoadjuvant treatment, the protocol which Dr. Milind Javle showed.
High risk, GB predicted risk.
Yeah, high risk for recurrence, then probably we should. So we will have to see how we frame the statement, and then as during the tea time also many of us discussed that for each question the first authors will have to generate a brief statement which will then be circulated to all the experts to have a Delphi kind of a consensus.
As such, we don't have the results of randomized trial, so the consent statement will be to be considered, should be considered sort of thing.
How do we define locally advanced cancer in the publication? I think we have to really go through, okay. Many of the publication beyond cystic node is considered as locally advanced, beyond T1 or very early disease is considered locally advanced. So we have to take in that context. These are resectable disease. So even if the title changes by neoadjuvant therapy in resectable disease, we can't tell that these are unresectable disease. Okay. I think in Tata publication also, portal lymph nodes are considered as locally advanced. Correct?
Any second stage is locally advanced.
No, yeah. So these are unresectable cancers. So there is a huge difference when we make somebody to understand locally advanced and giving neoadjuvant therapy in otherwise resectable cancer. So a significant number of patients in these publications are otherwise surgically resectable cancers and not gone beyond the at least the second basin of lymph nodes. So that point has to be very, very clear before we tell the locally advanced.
Only difference is that here we don't know what stage it might be now, since it's not a virgin tumor.
So now what I'm trying to tell is, can we produce a R0 margin in the T front majority very well? Can we go to the next echelon of lymph nodes and produce a negativity in the lymph node basin very well? So majority of the patient, we can do it. So this is different from CA rectum, where CA rectum, we have a standardized lymphadenectomy protocol, go to the IMA, completely cylindrical excision, then we are talking about neoadjuvant therapy. Here this is a different discussion also. So simply putting a locally advanced and neoadjuvant probably a little bit problematic, I feel.
But I don't see any harm or anything which would be within inverted comma unethical, because in so many other malignancies which are primarily resectable but based on biological parameters, we are saying that we would give neoadjuvant treatment to assess the biology. It has become an established method of treatment in so many other cancers. So there is no harm in saying that in high risk incidental gallbladder cancer, where chances of dissemination are high, instead of offering surgery and having a poor outcome, you give neoadjuvant treatment for 3 months, see the course of the disease, and those who still remain non-metastatic, then you offer surgery.
That I agree, sir. That is what exactly I'm telling. So even in resectable, so there is a significant, that we have to, that point has to really come out that these are resectable group, we are trying neoadjuvant therapy because of the biological agreement. That's it.
So because you are not in consensus with the timing, that is one thing. Second thing, referrals are different. So in the terms of trials as such, if not as such, the statement that you have to form is for IGBC and not as a locally advanced and all. So for IGBC predominantly, not all will be actually locally advanced. A lot of them will be actually, but another problem which you have to see is the presence of residual disease, which we say is the poor predictor. So 4 or 5 criteria we will have to formulate. These are the patients which will probably benefit, then look them as a prospective trial vis-a-vis upfront surgery versus a neoadjuvant, and then formulate. So the statement should be something like that, because it can still be only in terms of trials only. We don't have any evidence, even for neoadjuvant in general GBC, the data is huge, but most of them are observational studies. You cannot have a level 1 evidence in those cases also.
So all first authors, please make a note that you have to generate a statement for your question, and you have to suggest
future clinical trials related to that question.
As a convener of multi-specialty tumor board at State Cancer Institute, I have seen our medical oncologist colleagues are giving immunotherapy, and I have seen complete response in locally advanced gallbladder cancer. Will you throw light on that?
I think that is very important tool, like the immunotherapy is now approved in almost 13, 14 types of cancers. Gallbladder yet has not been well explored, but the NCCN suggests durvalumab is an immunotherapy which is approved in high-risk patient, and without in fact PD-L1 testing also this is approved, and occasionally we are seeing patients who show a complete response also. Yes, so occasionally, but yet the biomarker exactly to identify which subset of patient will be showing response to immunotherapy is yet not very clear. So PD-L1 is one testing, tumor mutation burden is another testing, and other than that tumor infiltrating lymphocytes in the pathology specimen, that remains one important factor. Neutrophil lymphocyte ratio in the blood also remains one factor, but yet not the very good predictor for response of immunotherapy is not available.
And the role of immunotherapy in gallbladder carcinoma, it is in a metastatic setting. It's not like in a neoadjuvant setting right now. So in this setting, when we are talking about neoadjuvant chemotherapy, we don't have any role of immunotherapy as such. That is totally different scenario.
So the debate is still going on. So actually the tumor progression on the chemotherapy is still that is there, and the chemotherapy drugs, new drugs should improve that recovery, like response rate. If it's very high, then obviously it will come into the picture. Otherwise, still on the trial basis we should proceed with. I think so. Everyone should include in a clinical trial for these kind of patients, and then proceed.
I think the major fear factor for surgeons is that the disease may progress while patient is receiving chemotherapy in a resectable disease. But in fact, if we see that if the patient who is on chemotherapy, operable disease, if that person progresses on chemotherapy, which is like 30% of chances, then this person will show the progression of disease immediately after surgery also. So the disease biology is bad, so we get an opportunity to know the biology of disease also by giving them neoadjuvant chemotherapy. There are various other markers, molecular markers like FGFR, HER2, EGFR, RAS mutation, all those are there, and now neoadjuvant immunotherapy based on the molecular profile of the specimen is being tested. So tomorrow, in fact, in next few meetings, we may see neoadjuvant immunotherapy also coming in a big way, which will give probably better answer, better results. Yes, sir. In Topaz, it was collegial.
Yeah, they had few proportion. Like, so we've recently published a study, which is a phase 2 trial on the use of trastuzumab in HER2 positive, but this is again metastatic biliary tract cancer, and 96% of the patients have been gallbladder cancer, which have shown survival advantage. But again, if we have to extrapolate that to neoadjuvant, we cannot do it without a trial setting.
Since we have a couple of medical oncologists here, Dr. Javle has been asking me for a long time that you should make it, because the role of HER2 receptor in gallbladder cancer, there are enough publications, and it would not be difficult to get ethics committee approval that you do an immunohistochemistry for HER2, and if it is positive, give HER2 blockade along with chemotherapy, and if you have enough numbers, randomize them, one group chemotherapy alone, other chemotherapy with HER2, and in fact there are few publications now on clinical.
This is recently published, JCO publication just last month on, it's called the TAB2 study.
So I think some of you probably should take that. That is very good suggestion about the HER2 and EGFR both. In fact, HER2, like other than breast also we are using in the colon and sometimes in stomach also. So again, same model, and it's very good suggestion. Thank you, sir.
Actually, we have data on trastuzumab, and FESGO's study is also there, my pathway, which is a basket trial. And then there is also data on trastuzumab deruxtecan on this HER2. So like we have a patient who was operated, then adjuvant chemotherapy was given, and then he metastasized and HER2 positive was there, and we have started on trastuzumab. So it's a new setup, we are coming up with these patients now.
In fact, most of the drugs, they start like that, only coming initial in the metastatic setting, and gradually they come in neoadjuvant.
Thank you for a nice session.
Thank you everyone. Thank you Kapoor sir for the opportunity, and thank you all the participants. Thank you.
Thank you, chairpersons and dignitaries. Now we will be addressing question number 17, that is minimal invasive surgery for incidental gallbladder cancer. Dr. Rajesh Bhagwani sir will be chairing the session online. He is a senior consultant and head of gastrosurgical department at Santokh Badulabji Memorial Hospital. I would also request Dr. Shivendra Singh sir to be a chairperson. He is professor in surgical oncology department at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Welcome, sir.
Good morning. I'd like to invite lead presenters. Dr. Selva Kumar is here. Okay, Dr. Selva will be presenting for minimal invasive surgery in incidental gallbladder cancer.
A very good afternoon to everyone. Today we'll be discussing about the evidence available for minimally invasive surgery in incidental gallbladder cancer. The conventional teaching has been that whenever you suspect a gallbladder cancer during lap chole, you need to convert and do an open chole. And even in preoperatively diagnosed cases of CAGB, it is always advised to open and proceed after staging laparoscopy if there is no metastasis. So the rationale for this is sound. It is because we can better assess the disease extent in open, and we can avoid a GB perforation or bile spill, and we can protect the critical structures of the liver hilum while doing lymphadenectomy, and we can also better control the liver transaction. We can do a Pringle, we can apply pressure if there is a bleed. So this was the rationale. Then why are we having this talk? Because over the last 2 decades with advances in minimally invasive technology, there are a lot of papers getting published of minimally invasive radical surgery done for gallbladder cancer, and both laparoscopic and robotic approaches are seen, and papers are there on both. So what we will be discussing in this short presentation is when to do minimally invasive radical surgery in gallbladder cancer or incidental gallbladder cancer, how to achieve optimal oncological outcomes, what is the evidence available, and when it is indicated, how do we choose whether to go for a laparoscopic or a robotic approach when cost is not an issue. So what we won't be discussing is the role of staging laparoscopy in incidental gallbladder cancer, the prognosis of incidental gallbladder cancer after a primary laparoscopic or open cholecystectomy, and outcomes of incidental gallbladder cancer treated by simple chole versus extended chole. So this is just a recap of the AJCC staging. T1 is tumor which is confined to the gallbladder but not reaching the outer perimuscular connective tissue. It is divided into T1A and T1B. Then T2 is, again it is confined to the gallbladder but it is reaching the perimuscular tissue, and it is divided into T2A if it is the hepatic side, and T2B it is the peritoneal side. Then T3 is the tumor has reached outside the gallbladder, so if it reaches towards the liver infiltration, or it is reaching the surrounding organs if it is in the peritoneal side. But only either one of it should be there. If both are there, there are more than one organ infiltration, or if there are vascular infiltration, then it is T4. And lymph nodes, the original level 1 and level 2 lymph nodes, and now the metastatic lymph nodes. In the AJCC 8, they have changed it to the number of lymph nodes as 3 or more than 3 for N1 and N2. So when we think of radical surgery for gallbladder cancer, there are 2 types of gallbladder cancer. One is the early or operable gallbladder cancer. Clearly it is operable in the imaging. So we just go for IAC sampling. We do a cystic duct margin frozen. We do a wedge or segment 4B5 resection, and we do lymph node dissection along these stations. And this is differentiated from a locally advanced gallbladder cancer where there is a need for multivessel resection or vascular resection or major hepatectomy. So when we talk of minimally invasive, probably this first group is more suited for minimally invasive than the second group. What are the advantages of minimally invasive surgery in today's era? There is magnified vision, HD cameras have become common now, 4K technology has come. There is advanced vessel sealing technology, up to 7 mm vessels can be sealed. And pneumoperitoneum has a hemostatic effect on the liver transaction plane, because usually the pneumoperitoneum pressure is more than the CVP. And the trauma to the abdomen wall is minimal. We need to give at least a 15 centimeter incision, subcostal incision, to achieve adequate exposure in open surgery. In this, probably a 4 to 5 centimeter incision in the fan and steel area is enough for specimen extraction. So the trauma to the abdomen wall is less. Indocyanine green is another exciting technology which has come up. It helps in visualization of deranged biliary anatomy and vascular anatomy during minimally invasive resection, and it helps in anatomical 4B5 resection also. And we can check at the end of the surgery for hemostasis and biliostasis using this technology. And robot has further have more advantages than lab in the aspects of better dexterity of movements, tremor filtration, and 3D vision. The disadvantages of minimally invasive surgery are it needs a learning curve, it needs mentoring and advanced skills to perform lymphadenectomy. There are chances of inadequate lymphadenectomy, especially in the posterior stations like station 13 and 12P. There are chances of bleed from hepatic artery and portal vein, and this bleed is going to be a massive bleed. And there's lack of tactile feedback, and in the, especially in case of IGBC, there may be adhesions in the right upper quadrant due to previous surgery, omental or duodenal adhesions. So how to evaluate the efficacy of this technique in GBC? So this technique should be safe and it should be feasible. Whatever cases we select, we should be able to do the complete procedure in those cases, or majority of the cases. We should have acceptable intra-op blood loss comparable to open surgery, and you should have acceptable post-op morbidity and mortality. Then we can conclude that it is safe and feasible. And then it should have equivalent oncological outcomes compared to open surgery, both in the short term in the form of R0 resection rate and lymph node yield, and in the long term in the form of pattern of recurrence, OS and DFS. Only then we can recommend MAS technique for radical surgery in gallbladder cancer. So what is the evidence we have? So evidence, when you look for evidence, we find that there are not much high quality evidence. There are 5 meta-analyses, all are lab versus open, and most of the studies are retrospective case series or comparative studies. There is no study which has separately reported on IGBC among these 5 meta-analyses. And there is only one detailed review on robotic surgery in gallbladder cancer. So this is a brief about the meta-analysis. The latest is by Ahmed et al. In 2023. They had a total of 4,988 patients, both gallbladder cancer and incidental gallbladder cancer were included, but the breakup was not mentioned. 2,284 patients were operated by lab, and 2,704 patients were operated by open. Majority of the patients had underwent segment 4B5 or wedge resection with hilar lymph node dissection. Most of these papers don't mention about retropancreatic lymph node dissection, IAC sampling, or cystic duct margin excision or frozen. They just mention wedge with hilar lymph node dissection. And they have not reported about conversion rates. They have concluded as operative time is similar. The blood loss in the lab was lower than open, and perioperative outcomes, the hospital stay was lesser in the lab group, morbidity was lower, and 90-day mortality was lower. Histopathological outcomes, R0, they concluded as lab has a better R0 rate, and almost all the cases were T1 to T3. There were no patients of T4, and lymph node yield was lower in the lab compared to open. And in the long-term outcomes, T1 to T2, the overall survival was similar between lab and open group, and T3 the survival was worse in the lab group, and lab group had higher percentage of recurrences in the port site compared to the tumor bed or the distant recurrences. And other meta-analyses have lesser number of cases, but their conclusions are also similar. So the OT time is variable. concluding the evidence, the OT time is variable, probably because of the variable learning curve of the group which is performing the laparoscopic surgery. There is uniform reporting of lower blood loss in the lab group. The hospital stay is lower, similar or lower morbidity and mortality. Probably the advantage of a smaller wound and less wound pain, leading to earlier ambulation and earlier resumption of diet. And R0 is reported as similar, and lymph node is similar in some studies and lower in other studies. And T1 to T2 has similar OS and DFS, and T3 has lower OS. There is almost no data on T4. And this is the biggest meta-analysis which has concluded that LAP is non-inferior to open in aspects of intraoperative, perioperative, and postoperative oncological outcomes. So I just went through the studies, and 3 studies. These are the tables from this, where the intraoperative blood loss was around 120 ml less in the lab group. The drainage tube was removed on an average of 1.5 days earlier. The diet was resumed on an average of 2 days earlier, and the post-op hospital stay was on an average 3.5 days lesser in the lab group compared to the open group. And post-operative complications were similar, around 9.8% in the lab and 16.8% in the open. They are not given a breakup of severe complications or mild complications in this. And they have reported on intraoperative gallbladder violations, that is gallbladder perforation during surgery. So it was a little bit higher in the lab group, 23% versus 18%. However, it was not significant statistically. R0 resection rate was around 80%, 77%. Port site recurrence was double that of open. This is a wound site recurrence, 6.8% in lab and 3.2% in open. And 90-day mortality was similar. And overall survival, the T3 group had an inferior survival in the lab group. So I just had a look at the studies, and 3 studies influenced the numbers significantly in this meta-analysis. This is the first study. It has 837 patients, and this study is from the German IGBC cancer registry. And when we look into this study, this is actually not a study comparing the laparoscopic and open radical resection for IGBC. It is a study comparing the outcomes of IGBC after index surgery of lap, open and lap conversion. And out of these, only 330 patients underwent a radical re-resection, and 490 patients did not undergo radical re-resection. They only underwent a simple chole and were followed up for survival. And out of these patients who did not undergo radical re-resection, there were 209 T2, 124 of T3 and 54 of T4. So to include this as a comparison of lab versus open in this meta-analysis, I think probably is not appropriate. Second, this study is another big study from the US. It is 680 patients. It is from National Cancer Database from the USA. And they have 445 open extended cholecystectomy patients versus 235 minimally invasive extended cholecystectomy patients. Because it's data from a database, they have no data on T-stage, extent of the extended cholecystectomy, whether it is wedge or a segment 4B5, or what is the extent of lymphadenectomy. They don't have any data on the center volumes. But this 680 patients were taken from 337 centers across USA. So probably the center, there are centers which may be doing only 1 or 2 cases. And the stage wise also, the open group had more of T3 disease and lab group had more of T2 disease and T1 disease. So there has been a bias towards operating lesser stage patients in lab and more higher stage patients in open. And with this type of background, they have concluded that there is a better OS in minimally invasive surgery, and there is similar R0 in lymph node yield. So they have not adjusted it according to the stage. Third, this is another study again from USA. This has 2,000 patients and 1,141 open and 873 minimally invasive surgery. There was 95% laparoscopy in the minimally invasive group. So in this study also, 45% of the open group had T3 and 25% of the lab group had T3. And in this study, surprisingly, only 72% patients underwent a lymph node dissection as a part of radical surgery, and the median lymph node yield was only 3. 6 lymph nodes which is advised by the AGCC, it was achieved only in 25% of the patients. And they have also concluded that if the patient underwent minimally invasive surgery, there is chance that there is a lower chance the patient may undergo adequate lymphadenectomy, 69% versus 76%. So these 3 studies combined, they contribute around 3,500 patients to that 4,500 patient meta-analysis. So I think we should not take the conclusions of that meta-analysis at face value. There is very few centers from India which have reported. One is the GBPUN group. This is the first study in 2015 where they published 24 lab radical cholecystectomy versus 46 matched open radical cholecystectomy. The selection criteria was that tumor should have minimal or no liver and no other organ infiltration. So this means that probably it is T1 or T2 only. And the lab group had longer OT time, less blood loss, and similar hospital stay and morbidity, and 100% R0, and lymph node yield was good, it was 10. There's another study from the same group in 2021 where they had published their experience of laparoscopic bisegmentectomy, segment 4B5 resection, and the conclusions are similar OS, RFS, and recurrence. Then there is a study from GEM group. There is just a case series of 14 cases where they have chosen patients with no bile duct or liver involvement and no bulky nodes on CT. And the hospital stay was 5 days, morbidity was 14%, and R0 resection was 100%, with median lymph node of 8, and 92% of this were T2. So when we look at MIS and IGBC, we see that there is not much data because most of the studies don't report IGBC data separately from GBC data. They just mention as a line that 20% of this population was IGBC, but all the tables, they report the outcomes for the whole population. They don't report the IGBC outcome separately. But probably IGBC has a lower T stage, it is T1 to T3, and probably it has no adjacent organ invasion or vascular invasion, that's why they were able to complete a cholecystectomy. And probably it has N0 less bulky lymph nodes. So I feel that IGBC has a lower stage than GBC, and probably IGBC is more suited for MIS than preoperatively diagnosed GBC. So there are only 4 studies on reporting exclusively on IGBC, and 3 of them are from China. The conclusions are similar to the meta-analysis. Total of 612 patients only available in literature, of which 357 are from China. There is a conversion rate of 0 to 29% in IGBC. There is a variable OT time and lower blood loss, lower hospital stay and similar or lower morbidity, similar R0 and lymph node yield, and majority of data is from T1B and T2. The OS and RFS is inferior in T3 in IGBC also, and there is almost no data on T4. So now coming to the debate of when we choose to do MIS, whether to do a lap or robot. So MIS liverization took up it started in a big way after the International Laparoscopic Liver Surgery Consensus Conference, which established the IVATE criteria for HCC. So this liver resection part for gallbladder, because it involves beds of segment 4B and 5, it will be probably a low risk resection, and the score will be 3 or 4. So this part is easy in MIS. But the parts which are difficult are cauterization, IAC sampling, and lymph node dissection, especially in the deep posterior sessions like 13, 12P, 8P, and 9, which are behind the critical vascular structures. So there is no scoring system to assess the difficulty of this and choose or select cases. So that is a problem in radical chole. And there is only one review. In the literature, only 113 patients of robotic radical chole are there till 2021, and it had 32 IGBCs, 70 GBCs, and 11 patients the data is not known. And predominantly there was liver wedge and liver hilar lymph node dissection. One thing we can see is the conversion rate is lower. It is 3.5% despite the experience being early. The conversion rate is lower than lab. OT time was on average over 4 hours. Blood loss was 260 ml. Hospital stay was around 4.8 days. Major morbidity occurred only in 4.4% of the patients, and there was no mortality. And R0 was achievable in 91% of the cases. The cases selected were only T1 to T3, and lymph node yield was better, it was 8. There are no long-term outcomes reported. So the conclusions about robotic radical surgery in GBC, there is less data compared to lab. Conversion rates are lower. Similar perioperative outcomes in hospital stay as compared to lab. Similar R0 and probably a better lymph node yield, which is equal to open, and long-term survival is not available. From India, there are a few studies. This is the Tata group, which published in 2019. They chose patients of gallbladder cancer with minimal liver infiltration or IGBC with no residual disease on imaging, and suspected GBC on imaging like thick wall GB on imaging. Only these patients they included. They did 27 robotic and 70 open cases which were matched to these criteria, and in their comparative analysis, the robotic cases had a longer OT time and lower blood loss. They had a shorter hospital stay and lower morbidity. The R0 and lymph node yield was similar, and again the T3 was less in the robotic compared to the open. About 1/3 in the open group was T3, whereas only 14% in the robotic arm was T3. There is another small case series from JAIPUR, where they published on 5 cases in robotic radical surgery for gallbladder cancer, of which the 1 case was T4, 3 were T3 and 1 was T2, and they had done extended resections in 2 of the patients. 1 patient underwent extended chole with Whipple's and 1 patient underwent extended chole with Whipple's with colectomy. However, they have not reported on detail about perioperative outcomes. In AIMS Jodhpur, we have done 3 robotic radical cholecystectomy, 1 with extrahepatic biliary excision, and it is unpublished data. So lab versus robot, I feel the advantages of lab are it is more widely available, it is familiar now, and it is easy to convert in case of a mishap. And the disadvantages are the instruments are straight, the vision is only 2D vision, and the movements are restricted around the hilum. And robot, the advantages are 3D vision, the endorist movements, they give superior dexterity for lymphadenectomy especially, and the camera and the first assistant are in the control of the surgeon. And the disadvantages I feel are the cost, the availability, the training, and in case of an intra-op mishap, it takes more time to convert. So probably that patient may have more complication. So this is just to show the superior, some pictures about robotic. So this is the 4th arm which is retracting the duodenum with a gauze piece, and the intravertical lymph node sampling has been done. Then this is station 12P. Again, the endorist movements helps in doing this dissection without the cautery touching the critical structures. This is station 8P. The CHA has been looped. And this is the station 13, where again the endorist movements helps in removing the lymph node without injuring the pancreas. And the left arm being a bipolar, in case there is a bleed, we can immediately cauterize without having to change the instrument. And this is the type of lymphadenectomy we can achieve with a robotic radical chole. I feel it is almost equal in quality to open radical chole. And there is also the ICG technology we are talking about in MIS. So we can check for biliostasis in MIS using the ICG. So first we take a long shot where we check the contour of the bile ducts, the right anterior, left and right, and there is no pooling of ICG. And if you do adequate wedge, this branching should be seen well in ICG. Otherwise, it means that we are probably coned down and we have not taken a good wedge near the hilum. And then we go for a closer shot to the wedge, first the 4B, then towards the hilum, then the 5, and there should be no pooling of ICG. So in conclusion, the problems in literature, most of the studies are retrospective analysis of successfully completed MAS cases versus matched open cases. There are no data on unsuccessful MAS cases or cases which were converted, what happened to them, and there are no RCTs. Retrospective studies are prone for selection and reporting bias. IGBC outcomes are rarely reported separately. Studies in the methods, they don't mention about station 13 lymphadenectomy, IAC sampling, or cystic stump frozen re-excision. And predominant data is about T1B and T2 tumors with N minus on imaging. And minimal data is there on T3. And N plus on imaging is exclusion criteria in many of the studies to exclude the cases for MIS. And another thing is, over the last 20 years, papers are coming recurrently from the same centers. The dissemination of like in other procedures, papers are coming from many centers. In this, probably it is a technically challenging operation. So the only some centers which have the skill or the volumes, they are again and again reporting on MIS. So it is problematic to draw conclusions and generalize the results for the for advising others. So the take-home message is MAS radical surgery in GBC or IGBC is not contraindicated anymore. The case selection, probably we should choose MIS approach only for T1B, T2 with N0 on imaging, and it should be preferably done at centers with experience in advanced MIS and HPB surgeries. We should avoid MIS in T3, T4 or bulky nodes on imaging, or those needing extra surgery other than liver wedge and lymphadenectomy. And robot versus lab, probably lymphadenectomy is easier in robot if cost is not a concern, but needs more data. And at the end of the day, the patient safety and the oncological radicality should take a priority over cosmesis or MIS approach. And if we do a good job in MIS regarding patient safety and oncological radicality, then the general advantages of MIS regarding the wound pain and wound infection that over open are a bonus for the patient. Thank you.
Thank you, Dr. Selva, for covering the topic excellently. So I'll start. So next talk will be process either, and on the laparoscopic minimal invasive gallbladder resection.
At the outset, I would like to thank Dr. Kapoor for the kind invitation and on a very interesting topic. And so from what I gleaned from the same, I mean, I'm not going to go through the whole literature. Thanks to Dr. Selva for doing it. So it makes the job easier for the subsequent speakers. So as I was sitting down, I was cutting down the slides. So the lacunae, I mean, when you look at these meta-analysis, what we see is there is no clear definition. And when there is heterogeneity, most of these meta-analyses have not explained the heterogeneity. Other aspects, when I look at a checklist of 10 items on the quality of meta-analysis, there are very few who fulfill multiple criteria. So whatever results are there based on retrospective studies should be taken with caution. So what we glean in summary is that it is feasible and slightly better perioperative outcomes on the published data. Laparoscopic surgery doesn't affect survival if definitive oncological resection is performed. And in the situation of acute cholecystitis, it is a completely different ballgame. So we can leave that out because we still don't have answers what to do in this subgroup of patients. So there is no clear definition of incidental GBC when we look at the retrospective data. There's a lot of studies which have included non-incidental gallbladder cancer. Most have included T1B, T2, some have included T3, but if you look at studies which have included T3 also, the proportion of T3 is lower. Ioto cable sampling is not done or reported. IOUS is also not done or reported uniformly. Conversion is not reported uniformly. And most studies don't include hepaticojejunostomy, if bile duct resection. And most don't define whether they are doing a wedge or a segment 4B and 5. For HPB surgeons, it is clear what is what. But a lot of times when we say segment 4B, 5, they actually are doing just a small wedge. So if you follow that the decision making in minimally invasive should be the same as open surgery, then we need to have certain operative steps that are recommended. And the skill set that is needed for minimally invasive should include a skill set of laparoscopic ultrasound, a skill set of liver resection, a skill set of doing iotocaval node sampling, unless Dr. Agrawal's group will change the paradigm with the new studies on EUS guided FNA. Lymphadenectomy in the hilar area, and hepatic vaginostomy. So these are the different skill sets. And what is the learning curve for liver resection? It's about at least 40 cases. What is the learning curve for pancreatoduodenectomy? Because apart from the reconstruction of the pancreatoduodenostomy, the skill sets of lymph node clearance is similar, I would say. So again, that needs about 40 to 60. So it is very hard to get that kind of numbers to do a RCT. Now I did a simulation of how much numbers are needed. If we, let's say, I want to detect a 10% difference in complication rates with a very, the standard criteria of a type 1 error of 0.05 and a type 2 error of 20%, assuming a standard deviation which is luxurious at 10%, it's about 190 patients in each arm. So that is not possible. So, but even if we do a multi-center RCT, there will be still strong internal validity, but external validity will be difficult. Of course, there's high cost, and by the time you plan a RCT, execute, the technology and its adoption may change. So we need to live with what we have. So there are some lessons we can take from the pancreatoduodenectomy RCTs. So the first one came from Coimbatore, showed better short-term outcomes. The PADULAB trial, which is again a single center trial from Spain, showed better short-term outcomes. Most of the systematic review, just like what we see in gallbladder cancer, showed that there is either non-inferiority or better short-term outcomes. But what happened when the multi-center trials came? The Leopard 2 stopped prematurely. In China, when they did the multi-center trial, the entry criteria for the surgeons was 100 over cases with lap before they can even enroll, which is difficult to match in the rest of the world. And the median length of stay was 1 day shorter. So is it clinically meaningful? Not really. So if we extrapolate what we see in retrospective data and meta-analysis and systematic review and learn the lessons from pancreatoduodenectomy and adopt it for gallbladder cancer, then we need to take MIS with caution. But there will be drivers of change. It is industry, which we don't talk about. We don't talk about drivers of change, social media, patient demands, peer pressure, health economics. And then again, private versus public sector, health economics funding, training and retraining for mid-career surgeons. So all these will impact change. So, but at some point in the technology adoption curve, then what happens is searching for evidence becomes pointless. And what I mean to say is how MIS keeps getting adopted, and after a while it becomes the norm that searching for evidence then doesn't make that much sense. So for robotic radical cholecystectomy, there's no significant differences in terms of hospital stay, blood loss, post-operative morbidity and surgical margins, but they tend to have longer operative time, higher cost and lower conversion. So if you look at the adoption, so probably for MIS, we are, again, this is not based on any worldwide surveys, just based on literature. We are somewhere here between early adopters and early majority. But with robotics, probably in a stage between innovators and early adopters. But if you look at the trajectory of what may happen, is there is an innovation trigger. There will be a phase when there is a peak of inflated expectations. Then will be a trough of disillusion. This is when the health economists will come into the game and say, prove to me, I mean, that's what is happening in Singapore. Prove to me that robotic surgery is better. And we can't prove it. And if you can't prove it, why are you spending $8,000 more? And that's what it costs there. And that's the real cost. And then after that, there is a slow slope of enlightenment and then a plateau of productivity. So for laparoscopic, I think we are at a stage where it is acceptable for certain subgroups. But for robotic, a lot of other factors will come into play. So can minimally invasive surgery be done for gallbladder cancer, incidental gallbladder cancer? Yes. But the question is not whether it can be done. The question is, how do you do it? What are the minimum standards for surgery? How do you select the cases, which is a part of this question. And who should do it? What should be the resources? And what should be the learning curve? So these are the questions which we need to answer as sub-questions. And if you select what are the cases, again, T1B, T2, T3 with liver-only infiltration, lymph nodes not very bulky, doesn't need a hepatocoagulopathy, at least in the early part of the experience, unless you have a robot, and no previous open surgery. So I think these are probably the cases that we should select. Port side, there is another talk, so we'll skip that. So I would say the laparoscopic resections are at best evolving, and robotic, at least we know it is not inferior. There is, in terms of whatever limited publications are there, there is no clear data. But despite the lack of data, as surgeons do, we will be driven by surgeon preference, resources, training, insurance, and funding. So with that, I thank you all for your kind attention and discuss further.
Thank you, Professor Iyer. Now I will invite Professor Agrawal, who is the pioneer in radical choline for laparoscopic.
Good afternoon, and at the outset, thank you, Dr. Vinay, for this opportunity, for this great meeting. And so my brief is again to comment on the minimal access surgery. There's no debate about the staging laparoscopy, as was already talked about, and I think there is another talk after this. But just to highlight what Sridhar was talking about, that intra-aortic lymph node biopsy also, which becomes a kind of, initially when we started in all cases, that would become a part of the standard laparoscopic radical cholecystectomy. However, in some cases now that is obviated in the light of endoscopic ultrasound assessment. And so the main issue is about the minimal access radical cholecystectomy, which was being talked about. And there were papers, and people used to extrapolate the data from incidental gallbladder cancer to say that there's a port side recurrence. But however, that was not really a sound data, because that was an inappropriate surgery done. Gallbladder was grasped from wherever you could. And so I think to suggest that laparoscopic is the way forward, we needed to address these issues, whether it is feasible, which it was, whether it is safe, technical issues, port side metastasis, and early and late outcomes in terms of survival. And this, Professor Hahn was the one, I think, who convinced the world with this paper in 2010, and including us, we, after this paper, which talked about with a median follow-up of 27 months, that there was no port side recurrence. And I think that was very well highlighted. This was, I think, the taste of the pudding, but I think it was based on the thing that you are going through the liver bed, and so you are not transgressing the cystic plate or holding the gallbladder from the tumor area, bringing it out in a bag. So all these things translated into, and this is what convinced. In 2011, we started doing laparoscopic radical cholecystectomy, and at the, one of the papers that was alluded to, we also showed in that there was no port side recurrence, though of course we followed the master, that is Professor Hahn and his group. And in 2016, on the sidelines of IASGO, or as part of the IASGO, sorry, in fact, most of the surgeons who had done more than 10 laparoscopic radical cholecystectomies were there in that, barring one or two, and they came out with this consensus statement, and they showed that now there is a case and there is a post-operative and survival outcomes. At that time, a selected group of patients were comparable, and so this was the way forward. And also they had the the consensus meeting. So I think we know that technically you can do the same as segment 4B5 resection, lymphadenectomy, and the oncological outcome is what we are concerned with. We know that the cosmetic result will be better in terms of laparoscopy, early return to work, and I think you don't have a open radical cholecystectomy, obese patient standing up by the bedside on the next day, and our longest survivor now is 12 years of laparoscopic radical cholecystectomy. So if you did all that akin to, because again which has been highlighted by Selva and subsequently by Sridhar, that you have to do exactly the same that you would have done in an open radical cholecystectomy. And then the results are comparable. And this was the early series comparing various series talking about the lymph node yield and the results. And there are now very heartening to see that in the last 5 to 10 years or 5-7 years, there have been several series of 30 to 100 patients talking about various things that either non-inferiority, early return to work, or survival, which was being comparable. I've just put it in a, it's a busy slide, but these are variable studies, and some would talk about that lymphadenectomy is comparable, some would talk about the survival is comparable. And this Professor Hahn group again had shown with their long time experience also, and they, in fact, in the second paper onwards, they included also the T3 patients, which again Sridhar was alluding to, that now in series, there are several series talking about T3. And I would just allude to this, which was a very nice meta-analysis by Feng et al., in which there are of course some selected limited series, but they talked about operative time, no clinical significant difference, operative outcome, blood loss, no significant difference, retrieved lymph nodes again was comparable, and this was our paper again with a median of 10 lymph nodes, and the recurrence rate, no difference overall or in each subgroup, and this again overall survival was comparable. So now there in the literature a lot of studies which convince, and this is some time ago we had presented this in one of the meetings, and we compared with this 235 as a multicentric series, and we found that most of the series reported pretty good results. And this was just at that time. This now we have updated this series to about 200 plus cases, and we have sent that abstract for the IHPBA in Cape Town. And this was Mahesh Goel Tata Group paper, which talked about robotic, and I think to my knowledge, this is the largest series which is reported in the world for robotic. And now coming to about, again, Sridhar, as you were talking about, that as now people are pushing the envelope, now even adjacent viscera can be resected with this. So there were initially some of these series by Gomes et al., Shirobe and Navarro, and we this is some of the pictures of some of our patients in which we have either done a bile duct excision, segmental distal gastrectomy, duodenal resection, or colectomy, and this right extreme lower part is the one with CBD with biliary obstruction, and this we recently started doing, because as you said again, Sridhar, because as we go along with the experience built up, this is a paper we published. At this time it was 11 patients, now we have about 20 patients or so in which we have done resected the adjacent viscera with reasonably good results. And this was a very nice paper by Kalai Rasan group. Biju is there, Biju and Kalai, in which they talked about laparoscopic hepatopancreatic duodenectomy. So eventually it is developing in the same way as you did in open, as long as you follow the oncological principle of doing all the procedure and just laparoscopic as the approach. This Professor Hahn in one of the recent meetings talked about that it's equivalent to open surgery in oncological, and I would not go into the details, just to summarize that now it can be done for limited or extensive involvement, as long as you can do an R0 resection without tumor handling, and you can have a non-inferiority, because eventually, like as again you were saying, to convince the administrator at times, because what you are needing to prove is a non-inferiority together with the other advantages of minimal access surgery, including early return to work, cosmesis, and also starting the adjuvant treatment early. So I think that is what I would just conclude by saying, that now there is a way forward for doing a minimal access surgery. Thank you.
Thank you, sir. So now we will have 2 videos. First is by Professor Hahn. Yes.
I just say, because I think the issue was also incidental, so some data was analyzed some time ago, and we've again prepared that abstract, that about 60 patients of incidental gallbladder cancer, in which more of them were laparoscopic, but some with open and various stages. Professor Hahn, is he online, Professor Hahn? No, video.
Good afternoon, dear friends and colleagues. It is a great honor for me to be a speaker at the third Jaipur Surgical Festival. I appreciate Apros Kapu for inviting me to this congress. Actually, I'm very sorry that I cannot attend as offline myself in the Jaipur. But I'm so glad that even in online, I can meet many friends and colleagues. I appreciate that. Today, my title is the session is Minimum-Based Surgery for Infantile Gallbladder Cancer. I appreciate Chairperson Rajesh Bojwani for chairing this session, and also Dr. Selva Kumar for his excellent presentation. Which, although I didn't have a chance to listen in the auditorium. And also the commentator is my best close friend, Professor Agarwal, and I'm so glad to comment as online with Nicholas Zarofek-Cassis. Actually, the minimum research for instant gallbladder cancer may be very similar to the surgery for early gallbladder cancer. Actually, in our group, we have started a prospect study for the minimum surgery for early gallbladder cancer 2004. And in 2010, we have reported that minimum surgery for gallbladder cancer is a safe procedure. And in 2014, after 10 years later, about prospect study, we reported about our result of 10-year experience. In this study, we have found that the survival of minimally invasive surgery for gallbladder cancer is more than 90%. We had a very excellent outcome with the minimally invasive surgery. So actually, this Jaipur Surgical Festival is about infantile gallbladder cancer. I think the principle is similar. For infantile gallbladder cancer, I think minimally invasive surgery has a good role. So if when you encounter infantile gallbladder cancer, when you operate on the gallbladder, I think we have to prepare minimally invasive surgery. So minimally surgery actually include whole layer of gallbladder wall, and also lymph node dissection is necessary. So I think many of our colleagues is very good at lymph node dissection. So anyway, if we are suspicious of malignancy, then we can open the gallbladder specimen, and after frozen biopsy, it is gallbladder cancer. We have to proceed to the minimally invasive surgery. But when you think about gallbladder cancer, we may do a whole layer of gallbladder. But if we do not perform whole, we do not think about the gallbladder cancer, sometimes there may be spillage. So if there's some spillage, I think we have to very irrigation, profuse irrigation may be necessary for it. But anyway, recently we don't usually perforate the gallbladder cancer. I think whole wall thickness, gallbladder removal and the lymph node dissection may be very good. But if the stage is more than stage 2, I think sometimes wedge dissection may be necessary. Anyway, my point is that minimally invasive surgery is good for the early gallbladder cancer, and even in T2 gallbladder cancer and in infantile gallbladder cancer. I hope that you have a good discussion of this topic. Thank you very much again, Pros Kapu. Congratulations for this excellent meeting.
Thank you, Professor Han. Next video is from Professor Nicholas from Chile.
Hello everyone, I'm
Nicolás Jarufe. I'm professor of surgery at the Universidad Católica de Chile, and I am a HPV and transplant surgeon. So in the next 5 minutes, I'm going to comment in this video about the utility and advantages of minimal invasive surgery for incidental gallbladder carcinoma. So we all know what are the advantages of minimal laparoscopic surgery or the open procedure in terms of less hospitality stay, better recovery, less pain, better aesthetic results, and also faster recovery from the patient to be able to receive adjuvant treatment. Watching this video that I'm going to show you now, I would like to comment based on the literature why minimally invasive surgery is a very good indication for incidental gallbladder carcinoma. So those are the position of the trocars, and you will see in the video that the minimal invasive approach is very similar to what we do when we do this procedure in a standard fashion or in open approach. We mobilize with the duodenum in order to reach all the lymph nodes of the intercalaortic space. You see how we can retrieve easily those lymph nodes, and all the procedures run very similar to the open surgery. We continue the lymph node dissection in the pedicle, in the hepatic artery, until we reach the celiac trunk. So after we complete all the lymph node dissection, we go to the liver resection, which is a wedge resection, because based on the current literature, we don't need to do big or bigger hepatic resection for incidental gallbladder carcinoma. It's enough to do a wedge resection of part of the segment 4B and 5, plus the resection of the cystic duct and all the lymph nodes, as I said before. All those procedures can be done, as you see in the video, by lab with a better view comparing with open surgery, very safe, with all the advantages of laparoscopic surgery in liver resection. We know with the literature that we have today that liver resection done by lab surgery, we get less bleeding, better recovery, less transfusions, and a similar morbidity and mortality. And in terms of oncologic results, they are also similar compared with open surgery. R0 section are the same, lymph node retrieval or harvesting are the same, survival are also the same, and we have nowadays meta-analysis and very important papers that confirm what I'm saying. It's true that we don't have randomized studies yet, but with the recent evidence that we have nowadays, we can say that minimally invasive surgery is as safe as open surgery for incidental gallbladder carcinoma, with the advantages of the minimally invasive approach. Robotic surgery will be even better when we have to resect the bile duct, for example, in cases of bile duct invasion, and when we have to recontract the bile duct with a whole Y loop, probably robotic surgery will be more easier for surgeon and with better manipulation of tissues and safer anesthetic. So that is my comments in terms of minimally invasive surgery for incidental gallbladder carcinoma, and the surgery can be indicated as in open surgery for T1B, T2 cases, T2A and T2B, and only some very selected T3 cases. Thank you very much, and hope to see you soon. Bye.
Thank you, Professor Nicholas. Dr. Bhojwani. Dr. Bhojwani is online.
Good afternoon, Dr. Shivan. Can you hear me?
Yeah, we are able to hear.
Okay, so thank you very much. I enjoyed the entire session and the talks by all the renowned speakers on this. Can we go ahead with the questions, or should we start with the questions as per your decision?
Any comments from your side, and then we'll open the house.
Yeah, I think I like the comment from comment from Dr. Sridhar, who did mention that we are now getting to see the publications from the centers which have been doing it, and not many new centers are coming in this field, and that's perhaps the reason why we don't have more data or the required data. I think those who do it are convinced that it provides good short surgical outcome, but those who are not yet into it still feel inhibited for one or the other reason. This is the time when perhaps India should also gather some centers together and come up with some multicentric data to prove the point. And then, as has been done for the laparoscopic liver dissections, I think there is a need from the surgical community around the gallbladder cancer to devise or kind of standardize this particular procedure into various steps so that the learning curves can be kind of assessed and achieved. Gallbladder cancer for T1, T2 at least, or incidental gallbladder cancer at least, can be devised, and later maybe we can go down to multivessel resections and other major hepatic resections also for gallbladder cancer. But as far as the laparoscopic radical cholecystectomy is concerned, for IGBC and T1, T2 tumors, there is perhaps a need for standardizing the laparoscopic and the robotic techniques, and then take it forward with the help of multiple centers. Thank you.
Thank you, Professor Bhojwani. Any questions from the meta-analysis that Dr. Selva presented, that created a lot of controversies. There was the data was lymph node yield was less, T3 has worse overall survival. So what is your opinion, sir, Dr. Sridhar and Dr. Agarwal? Any comments on the meta-analysis that gives more GB perforation in lap or robotic group, higher perforations, higher lymph node yield was less?
So no, I don't think there's data on higher perforations. And
that meta-analysis showed that there was a higher incidence of GB perforations.
For the indexed cholecystectomy?
No, during because this was not the incidental. Most of the series have included both the incidental as well as
yeah, that's right.
Sir, actually in the table it is higher. It is 29% versus 15%. But they have shown it as non-significant. So in the conclusion, they have concluded as non-inferior.
So again, most of them are including T1B and T2. And oncologic outcomes, no difference. For T3, there is caution advised. And the biggest meta-analysis shows that for T3 tumors, lap is inferior.
And even the lymph node yield, they have shown that was less.
Yeah, that's true.
So that because of the data of the meta-analysis was not good.
Yes, sir. I personally feel those 3 big studies have skewed the conclusions of the meta-analysis. The other studies are good, but the numbers are small. The other 20 odd studies, they contribute to 1,000 cases. But these 3 studies, they contribute to 3,500 cases. And probably that one study where the lymph node was only 3. So it has probably skewed the whole conclusion of the meta-analysis.
Any comments?
Your analysis is as good as your raw data is, and I think as you rightly pointed out that in the 3 studies which were included, and in fact I think one of the study was from 2000 onwards till, you know, and there were very few centers who were doing laparoscopic or minimal access radical surgery at that time in the initial maybe 2000 to 2010. I think there were very few centers. So I think it depends, and in fact we have seen even in the open data, there were a lot of centers which would talk about lymph node yield being much less than this thing. But in fact, in the recent past, some of the studies that I quoted, the lymph node yield has been comparable in all the recent studies that compare or coming from centers which are doing a minimal access surgery. Because whenever you compare minimal access with open from a center, the study which is published, one of the issues is that if the center is doing laparoscopic, then it's fine, because if they are not doing that, because lymphadenectomy is the more challenging part. Yes. So probably if you're not routinely doing it, your lymph node yield in the initial part of your series might be lesser. But now I think from the centers which are routinely doing, there are comparable results. Yes. And I mean, as I showed you that Chang et al. Series also. So I think it's comparable in that regard. And the gallbladder perforation, I'm not so sure, because I think most of the series nowadays, because in fact that is one of the advantages.
So main problem, sir, comes because this is a huge meta-analysis of 3,000 patients published in American Journal of Surgery. So that will create a lot of confusion in the minds.
That is where the confusion, because it is similar to like, when you talk about analyzing the incidental gallbladder cancer data. Now, truly incidental, Dr. Vinay Kapoor, as he always talks about, that technically incidental gallbladder cancer, there should hardly be any which is T3, because what should have been obvious, which is I think either because on the ultrasound you missed or on the CT you missed, and even if you said the ultrasound CT was done by an expert, probably you did not examine the gallbladder, because like I think we sometimes talk about, Shiven, you did that study about not all being truly incidental where you were with us, and I think 50% were not truly incidental, and one of the patients it was, they said in the gross finding 12 millimeter polyp. Now obviously that was not sent for frozen, otherwise that would not be, and that should have been picked up on ultrasound, that should have been picked up on other imaging modality, and at worst on frozen section. So I think that those would be some.
Any comments? Or Selva should write letter to editor for this. If there is so much
one more
confusion is there, and you have analyzed the data. Because you have analyzed the data, then you.
So some of the studies actually mention some complications which actually we don't see in open. I think we must read the fine print also. So if we say it is recommended as a blanket without having the necessary caveats of who should do and what steps, it's dangerous. Because there are some things like bowel injuries which are not recognized, massive bleeding, bile leaks. Some of them we don't see commonly in open surgery. And so we should, if it is going to be a consensus statement, then it should include what should be the parameters by which we should say we should
conclude.
MIS.
The largest study on robotic from Tata Group, in the robotic arm there was one jejunal perforation. Again, jejunal perforation we will never see in radical chole if done by open. So that is probably a thermal injury or instrument holding injury.
I would suggest we should not say it is recommended, because if we say it is recommended, then open surgery is something which is not recommended. I think if the group agrees, we can maximum say there is no contraindication.
It be done if the results are equivalent.
Yeah.
The dilution from the raw surface of the liver versus gallbladder, I think that is significant. It should mention bile leak from the liver raw surface versus the gallbladder bile leak.
Yeah, I think it was a bile spillage from the gallbladder was higher.
They had mentioned as
GB
the percentage of GB violation during surgery.
No, sir, actually problem is it includes all IGBC as well as.
So when you're going to give a recommendation, it should not then extrapolate from that. It should be.
But when you say recommended, I mean that is true for even open procedures that we were doing. I mean,
do you recommend that anybody who's not trained should do a Whipple's? Anybody who's not trained should do a radical cholecystectomy? So here the issue, and some of the complications that you're talking about, we know in laparoscopic, we know that there are trapar injuries also which can occur. So which will be only tuned to this kind of procedure. So I mean, those are the things, but we have to look at that, what is the percentage of those and where do they fit in terms of the overall scenario, because we cannot say that for one complication which have been reported, which has not been reported in open, because a lot of times there are so many complications which are reported in open. So I think you have to take a balanced view. No, that is okay, but what the bottom line is, because a lot of times if you are skeptical about a minimal access approach, a lot of times the question asked is like what Sridhar was talking about, to convince the administrators that, oh, what is the advantage? Now some of the advantages are there and you have to show non-inferiority. How do you expect that oncologically, I mean, there might be some benefits which may accrue because of early institution of adjuvant treatment, etc. But otherwise the survival is going to be stage for stage. Yeah.
And
I mean, the thing would be, it is an option. If you are doing those advanced laparoscopic procedures, if we can do with the same radicality and safety, you can go ahead and do it.
And we should also mention that aortocaval, retropancreatic, all should be taken, because you told me most of the studies. Yeah.
Yes, sir. Most of the studies just.
We'll close. Thank you, sir.
No, sir. I just wanted to say most of the studies just mention the methods that as a part of radical operation they have done wedge plus hilar lymphadenectomy. They are not mentioned about retropancreatic or IAC or frozen of the cystic stump.
No.
Check.
Good afternoon, everyone. I would like to welcome you all back for this intriguing session in the afternoon post-lunch. For this session, I would like to welcome Professor N.R. Das. He is Senior Professor Surgical Gastroenterology from AIIMS, New Delhi.
Very good afternoon after a very nice lunch. I welcome you to this session on the role of staging laparoscopy in managing the incidental gallbladder cancer. We have already discussed that the incidence of metastasis in the cancer in incidental cholecystectomies are about less than 1%. To be precise, about 0.35% at an average per article. The dissemination rate in these patients are to the tune of 2 to 10%. And the local advance status of the disease at the time of re-exploration is a little bit higher than that. This may be around the tune of 20%. The available imaging modalities which we are having, we know that they are not so capable of picking up this dissemination or locally advanced nature of the disease, and the sensitivity and specificity is very limited. So only thing left for us in the armamentarium is the diagnostic laparoscopy. So to discuss about it, I would like to invite Dr. Saurav. He is a colleague of mine, and he's associate professor in gastrointestinal surgery in AIIMS New Delhi. So Dr. Saurav, please.
So at the outset, I really want to thank all the organizers and my mentor, Professor V.K. Kapoor, for giving me this opportunity. Staging laparoscopy in incidental carcinoma gallbladder. We all know the incidence is around 0.2 to 1.1% of all cholecystectomies, with various studies quoting that. Re-resection can depend upon the stage of the disease, the patient factors, and we know that the unresectable disease can be there at the tune of about 20%, but this includes both the locally advanced as well as the metastatic disease. Staging laparoscopy basically is employed to initially find out the metastatic disease. There's a need for an extensive preoperative workup in these patients because we do not want to subject them to another unnecessary laparotomy. So we can do various investigations like markers. We can do all the imaging armamentarium that is we have, that is multi-MDCT we can use CE, MRI, we can use FDG PET. And one question is, what is the role of staging laparoscopy in the era of minimal invasive surgery? That is, now we are propagating that we can actually do the minimal invasive surgery in the incidental carcinoma itself. So, but still there are many centers where actually this expertise will not be available, and still open surgery holds true, and probably a staging laparoscopy can at least rule out those who have disseminated disease at the outset. What is the question at hand? Is the staging laparoscopy actually required when we are subjecting these patients to surgery? Is there any specific target subset which we can formulate where actually we will propagate that these patients should undergo laparoscopy? And what is the evidence in the literature? Before going on to that, can actually FDG EVID supplant laparoscopy? So there were 3-4 studies which actually studied the role of PET-CT in incidental gallbladder cancer. This one's by the American group, and there were 32 patients in which 19 had positive PET and 13 had actually negative PET, but out of those 13 also, we found that about 25% that only 4 underwent surgery, 9 actually refused surgery, but of those 4 also 1 had a metastatic disease. On the other hand, those positive,
Actually, they had included both the locally advanced as well as metastatic disease for the positives. So they underwent a re-resection, and there also they found that 4 patients had a metastatic disease. So which means that FDG PET may not be able to pick up all the disease that is there at the time of surgery, that prior to surgery. Similarly, another publication in 2014 had 100 patients, out of which 63 were actually incidentally gallbladder cancer. They actually did CT scan, MD-CT and a PET-CT, and then they compared the two, and they found out what was the concordance of MD-CT with PET-CT. 20 patients out of the 63 had actually metastasis. There is 30%, more than 30% had this. But those who actually underwent resection, 30% of those also had metastasis at the time of surgery, which means that the false negative rate of PET scan was still very high. And I think very recently a paper by Shivendra Singh sir is also there, that although there is change in management in patients, but there are patients where actually the PET can miss disseminated disease. So maybe staging laparoscopy does have a role. Looking at the technical aspects initially, what are the areas we usually inspect? So those are liver, gastrohepatic ligament, the whole of the peritoneum if possible, porta hepatis and pelvis. We put in additional ports. So we can see we can initially put a primary port. Sometimes it can be away from the umbilicus also, because if the patient is coming to you later on, you can suspect adhesions at the umbilical port which was initially used. And additional ports can be in the anterior axillary line or in the epigastrium, so that you can take a biopsy, or if required, some amount of adhesiolysis if possible. And whenever it is possible, we can do a use of a laparoscopic ultrasound, and any suspicious lesion should be biopsied. And some of the, I would say these are some of the pictures which usually you get peritoneal metastasis. Large metastasis usually, if this big a metastasis usually will be when the patient has presented very late to you. So what is the evidence for staging laparoscopy? So initially in 2002, Weber et al. Had a study for gallbladder as well as high local angiocarcinoma. Total 100 patients were there, out of which 44 were gallbladder cancer. And they found out that on the staging laparoscopy, 21 patients had metastasis. But the subset of incidental gallbladder cancer was very small. Only 10 patients of gallbladder cancer had incidental gallbladder cancer. And you see that the pickup rate of staging laparoscopy was much lower in incidental gallbladder cancer, to the tune of about 20%, as compared to when it was a primary gallbladder cancer, which was about 56%. But this is probably because this could be early disease that the patient had come, and already these patients who undergo laparoscopic cholecystectomy, half of the examination has already been done if they are coming early to you. Then there was a multicentric study which was published in 2007 by Pollock et al. 6 centers were there, out of which IGBC was for 148 patients. For the study, they included only 115 patients who underwent resurgery, that is 78% of the cohort. And the time to resurgery was about 52 days. But they found out was about 16% patients who had undergone a staging laparoscopy were actually inoperable due to liver or peritoneal metastasis. So a big chunk of patients we could avoid exploratory laparotomy, and this is as early as 2007, that is 16 years from now. Then in 2011 came one of the studies which has been used in probably all the papers if you go across for staging laparoscopy. That is a study by Jarnagin et al. Where 136 patients of incidental gallbladder cancer over a period of about 11 years were taken. And they found out that the disseminated disease in their cohort was actually very small initially. That the 46 patients who actually went for surgery, only 2 had disseminated disease at the time of staging laparoscopy. But out of those, when the 44 patients were then further subjected to exploratory laparotomy, 7 more were there who actually had metastasis, which was initially missed on the staging laparoscopy part. Actually, this was because they had done some sort of a staged procedure. They hadn't done it as a primary procedure and then went on to the exploratory laparotomy, but rather as a staged procedure. But they postulated few factors for where actually they postulated that there was higher chance of having metastatic disease, and these was higher T stage, that is T3 and above, any positive margin R1 or R2 resection at the time of index surgery, and the poor tumor differentiation. So these three have been postulated, and if you will go across, as I'll show in future slides, all the consensus statements eventually include these three subset of patients for staging laparoscopy. Then came a big study from India, Agarwal et al., 409 patients of carcinoma gallbladder for across 6 years. Total 773 patients of gallbladder cancer, out of which 507 were operable and 98 was incidental gallbladder cancer and 409 were primary gallbladder cancer. The biggest takeaway from this study, actually, total 95 patients has a disseminated disease at the outset itself, but even in the primarily resectable disease, there was 18% of patients who had actually missed disseminated disease. But there was, the findings were that the unresectable disease the accuracy of staging laparoscopy was only 55%. That is 45% were actually missed even after staging laparoscopy. But the specificity, that is the accuracy for the disseminated disease, if they postulated it is disseminated, then it is there, is 94%. And so one thing you have to look at is that the analysis actually excluded the incidental gallbladder cancer from the the patients those were analyzed were actually not IGBC, but only primary gallbladder cancers. So I tried to look at the early GBC, and we found that even these patients, which could actually be closer to the incidental gallbladder cancer, even they had about 9% of disseminated disease, which was picked up of staging laparoscopy. So which could be actually extrapolated to our subset of patients, that staging laparoscopy actually does help in these patients. Then came the first consensus statement in 2015, and it postulates that staging laparoscopy is recommended in patients of IGBC, and predictors are, as I initially postulated, initially elaborated T3 and above stage, poorly differentiated carcinoma, R1 and R2 resection in the index surgery. Then after this, so these three, then came a position paper from ICMR, and all the stalwarts are actually part of this group, and the recommendation was the staging laparoscopy is recommended in all patients undergoing primary surgery with intention to resect and may be of use in patients with the diagnosis of incidental CAGB prior to going ahead with radical surgery. Although FDG PET is not routinely recommended, it may be used if available prior to the radical surgery. So this was a consensus statement given in the position paper of ICMR in 2015. And recently in 2020, a Brazilian consensus was there, which was from the HPB only. Similarly, it also recommended that any patient of T1B and above should undergo a staging laparoscopy before the gallbladder cancer reoperation, and potential of detecting the metastasis may be higher due to delayed presentation and risk factors such as bile spillage and presence of positive margin as well as high-grade tumors. And as you can see, the agreement is at to the tune of 97%. That is, most of the experts actually agreed to this statement. Then there was this paper from SGPGI, which we were previously discussing for the timing of referral. They also had total patients of 91 patients of IGBC, and where they found that even different times of presentation did not actually influence the presence of metastasis. As again you can see, although they recommended that intermediate group is the one where actually surgery is recommended, that is 4 to 12 weeks. But there was higher incidence of metastasis also in these patients. It was all the number as compared to early group. So this is one thing which could be actually contradictory to what they are recommended as far as the timing of the reoperation is concerned. Because when more metastasis is there, is less likely that you're going to actually do a better job. Then this is the National Cancer Group draft guidelines from 2021. And this is for the incidental gallbladder cancer also. Only thing I wanted to highlight was that diagnostic laparoscopy, if presenting after 4 weeks prior to the definitive surgery, should be taken into consideration. Finally, this is the very recent paper by the Netherlands group, and they have taken 107 patients, out of which only 7 patients underwent staging laparoscopy, but there also one patient was found to be unresectable. But Unfortunately, the 6 patients which were found to be resectable at laparoscopy, 2 were still found to be unresectable. So although staging laparoscopy does pick up disseminated disease, there are fallacies in staging laparoscopy, probably sometimes because we are not able to do a complete job. We are not able to see all the areas of the abdomen where the disseminated disease might be there. But still, at least some of the patients, we can avoid negative laparotomy per se and send them to for the palliative chemotherapy if possible. This is finally, this is a small study from AIMS actually. This I kept in end because this is, although it is just a retrospective study and studied 54 patients, did not undergo staging laparoscopy. Only thing I wanted to highlight was that the operability rate was only 65%. The 35% patients actually did not undergo surgery. So they must have undergone a negative laparotomy, which could, some proportion of which could have been avoided if a staging laparoscopy was employed at that time. So my take home from all these evidence is that staging laparoscopy should be done in patients undergoing resurgery for incidental carcinoma gallbladder. We can use additional ports if required so that we can do a better job. Biopsy any suspicious lesion, and laparoscopic ultrasounds, if available, should be used so that we do not miss an intraparenchymal hepatic metastasis which might be there. Thank you.
Thank you, Saurabh. Comments from Dr. Sivendra Singh, please.
Good afternoon, everybody. I think Saurabh has covered most of the top points, and I will be focusing more on the technique part. As you can see, all the laparoscopy, staging laparoscopy studies have included both the overt gallbladder cancer and incidental gallbladder cancer. And incidental gallbladder cancer studies Saurabh has covered. So how we should do the staging laparoscopy, I will be using. At least you can use a 5 mm, 10 mm, 30 degree laparoscope. Better to use at least 2 to 3 ports, not a single laparoscope, single port laparoscopy. And preferably to place the ports in the line of future incisions so that you can excise them later on. And always look for peritoneal omental deposits, liver mets, if they are present, do the frozen sections. Always look for, in the incidental gallbladder, look for evidence of spillage like the spilled stones, because they might be indicator of spillage. If ascitic fluid is there, then you should do a cytology. Usually these are the two common incisions that are being used. If you are doing a umbilical port laparoscopy, then one should place the ports along this incision. That is preferable. This is standard recommendation for all staging laparoscopy if you are doing for peritoneal disease, in diseases which are prone to develop peritoneal mist because they have chances of tumor spreading. So the incision should be, the port should be along the incision line. So this is one of our patients. You can see this is the laparoscopy. This is not the incidental, just to show the, once you do, look for the gross where all the disease is there, all the quadrants. After seeing that, you should always look for the omentum, and pelvis also one should look. Go deeper into the right suffragette space, because these are usually the missed areas which can usually miss if you don't do carefully these areas. Look for mets in these areas. Always never miss even a pelvis, because sometimes a small fluid might be there or small deposits might be there. And once you have done seen all areas or quadrants of the disease, then one should again focus to look for the right upper quadrant. That is the most commonest site, and this needs usually put another scope so that few areas in the liver are hidden. Those is segment 7 and 8. These are usually not easily accessible on these single laparoscopy ports, and also the inferior aspect. So one should put another post must, just to see that like this there is some small suspicious you feel whether some nodularity is there, whether no surface irregularity is there. If there is something is there, then one should biopsy it. And that is why you press this and try to look as much segment 7 and 8 as far as possible, and also the right dome of diaphragm you can see. Once you press the lever down. And this should be done in all cases. Once you have seen this, then one should look for the inferior aspect, lift it, because these are also the inferior in segment 7, you can see the inferior part. Also the segment 2 is also the commonest side to miss, so one should lift the left lobe, so seek for segment 2. This is another patient, you can see this is a post-PTBD CAGB with jaundice, and we have placed another 2 ports, and in this once you see doesn't appear to be any disease as such, and if you don't do it, if press it, there is some suspicious, and once you press it, then you will appreciate. So this is the disease, you can see once you press it, they will find your peritoneal disease. So these areas are usually hidden, so one should always do either 2 port or at least 3 ports laparoscopy, no single port laparoscopy should be done. So this is important to always look for right subphrenic behind segment 8-7 lesion, parenchymal, inferior segments of segment 2, or the deposits over the gerotas. Many times when post-cholecystectomy, there might be evidence of spillage or deposits in the gerotas. But other problem is if it is a post-open chole, sometimes you will not be able to access whole of the quadrant unless you do adhesion. So always we do a peritoneal lavage cytology. If we find that the disease has breached the serosa, one should do a peritoneal lavage also, send it for frozen. Look for previous port sites also, because there might be small deposits, or these, if you are a believer in ports are excision, that will help how to excise these ports. Lab intraoperative ultrasound can help you in identifying intraparenchymal liver mets. If you can do an intra-aortic lymph node biopsy also laparoscopically. This is the landmark paper from JAIPUR by Professor Agrawal, and this showed that it avoids unnecessary laparotomy in 23% of patients. Only thing is this is the pre-PET era, so most staging was only done by CT scan of chest and abdomen. So this we published our experience of PET, how it changes the staging, and it showed that it changes the management in around, additional findings are seen around 30.9% and changes in management around 23% of patients. More so in the locally advanced gallbladder cancer as compared to upfront resectable. But in upfront resectable also it changes management around 12%. And false negative was 15 patient, that is around 12% patient still you will miss, and that will be detected on laparoscopy even after doing a PET scan. So this was the breakup. And this is now we have analyzed our experience after January 20 to 23. 142 GBC were taken off for surgery. 117 were underwent radical cholecystectomy, no mets with a resectability rate of around 82%. Inoperable was only 25, that is around 17%. And out of which the peritoneal mets were in 16. And out of which 14 were diagnosed laparoscopy, 2 were still missed, and they were detected on laparotomy. 4 liver mets were seen, and 1 was diagnosed laparoscopically, and 3 were on laparotomy only, and 5 was locally unresectable. So if you see the yield of laparoscopy in earlier stage was around 38 to 62%, in GB stage it was around 23%. So the yield is less if you do aggressively in pre-operative investigation by using laparoscopy, but still it is relevant. And this high resectability rate could be used because of use of PET in all patients, or because of use of NSCT and aggressive surgical approach, and staging lab prior to NSCT in all patients in our center. This is for a staging laparoscopy for locally advanced patients who are undergoing neoadjuvant chemotherapy. What is the finding? So we took up around 42 patients in last 3 years. There was no mets in 31, 9 were peritoneal mets which were diagnosed on laparoscopy patients. Instead of single port laparoscopy, multi-port staging laparoscopy should be done, and always look for the hidden areas. Peritoneal lavage cytology might be helpful, or laparoscopic intraoperative ultrasound might add value to the staging laparoscopy. Thank you.
Good afternoon, ladies and gentlemen.
He
Today
is
we
there
delve
online
into the
also. I
intricate
welcome.
role of gallbladder cancer, condition that possess a unique challenge in diagnosis and treatment. Our focus in the indispensable role of laparoscopic staging and the presence of positive lymph node infestation, the celiac, the SMA, and the orthocava, to help to navigate this complexity of this disease and optimizing patient outcome. So building on this foundation, a recent review by Mohammed Saidi strongly recommend staging laparoscopy before resection, especially in all cases, with emphasis in patients with specific characteristics like including T3 tumor, polydifferentiated adenocarcinoma in incidental cases and non-incidental gallbladder cancer. On one hand, laparoscopy, 19 were found to have disseminated disease preoperatively. He does make the difference between non-incidental and poor prognosis, as it is, for example, acute cholecystitis, perforation, the role of laparoscopic staging in gallbladder cancer. Beyond its diagnostic utility, staging laparoscopy significantly impacts treatment decision and prognosis. The results indicate that the yield of staging laparoscopy in incidental gallbladder cancer, specifically, and the entire population is relatively low, and the case with incidental gallbladder cancer. Consideration of staging laparoscopy is most appropriate in patients with non-incidental gallbladder cancer and incidental gallbladder cancer with disruption of the gallbladder wall during cholecystectomy, as acute cholecystitis, T3, positive resection, polydifferentiated tumor, lymphovascular and perineal invasion, because this factor has been associated with increased risk of disseminated disease. Ultimately, staging laparoscopy is not necessary in every patient with incidental gallbladder cancer before resection. At least this is what the literature can tell us. But carefully analysis the risk and benefit of the procedure and also incidence of the gallbladder cancer is very important. Staging laparoscopy in countries where the incidence of gallbladder cancer is high could avoid a cost-benefit situation. I do believe that with the advancement of minimal invasive gallbladder cancer surgery, you can actually avoid this discussion to have all patients having a staging laparoscopy and then resection by the same approach. However, I do think that staging laparoscopy is necessary. It's necessary for the risk factor we have already mentioned, and it's necessary in patients who had advanced gallbladder cancer, and you can actually see the mass of the tumor before surgery. Next, should enlarged celiac, a supramesenteric and paraortic lymph node should be biopsy? And if they're positive, should we stop the surgery? Well, addressing the question of paraortic lymph node involvement, Dr. Argwal compared regional lymph node positive patients with those positive with paraortic lymph node. The data show a significant difference of overall and disease-free survival favoring regional lymph node positive patients. I know, and that's the literature I follow, is that from Professor Nagoya University about biliary tract cancer. They did found this seminal article of biliary, not only gallbladder cancer, but biliary tract cancer who had paraortic lymph node positive. The prognosis was dismal, maybe futile, underscoring the importance of frozen section analysis influencing surgical decision. As we conclude, the evidence present highlight the complexity of surrounding decision biopsy in a large lymph node in gallbladder cancer surgery. By a study done by our group, we know that the hazard ratio of positive lymph node beyond the patoduodenal ligament is approximately 13 with a p-value of 0.001. Although the presence of possibility of skip metastasis range from 6 to 13% in gallbladder cancer. However, this is unlikely to find as an isolated distant lymph node metastasis. And positive lymph node in a distant disease can be used as a surrogate of multiple lymph nodes involved with non-dismal prognosis. The choice to abandon curative resection based on positive findings is multifaceted. In the realm of gallbladder cancer surgery, the decision to avoid the procedure seems to this point aligned with the prognosis of advanced metastatic lymph node disease and should be avoided any effort that will preclude other therapeutic effort. Thank you so much. I will want to thank Dr. Vicky Kapoor and all of you colleagues from India. I've been very impressed by the organization of the conference, and I hope to see you soon.
Thank you, Dr. Eduardo, for being online, although I know it's very early morning for you. So we will have some discussion, but in case you want to make some additional comments, please come in.
Okay, thanks so much.
So your comments, please, first.
Mine?
Yes. Have you been listening to the discussions till now?
I mean, in case you want to add anything before we have the House to discuss.
Yeah, I think one of the points is very specific that we haven't mentioned because of most of the study that we provide are coming from countries who don't have a high incidence of gallbladder cancer. I would say in countries when we have high incidence of gallbladder cancer, maybe the staging laparoscopy does have a role, and also there is also a specific role to avoid unnecessary diagnostic instrument, and I think staging laparoscopy in the context of taking the patient to surgery is one of the steps, and I shouldn't add as much as we think it could be add to the cost of the healthcare to have a PET-CT in every patient. So we do have to understand that there are countries who the PET-CT is not widely available, and the recommendation should appraise all those situations.
Thank you, sir. Dr. Saurabh, you aptly discussed almost all the literatures regarding in this subject, but I'm not sure whether I missed the article published in 2023 by the Netherlands groups.
Yeah, Van Duren group. That's what I was discussing.
Discussed. So
total 107 patients.
When the yield of getting a malignancy on laparoscopy is so low, it's about 2 in 47 patients, and when you open, you can detect further 7 patients. So is it prudent to do a laparoscopy in these patients, or we are looking at 2 subsets of patients, one where we are suspecting dissemination on imaging, suspecting, not confirmatory or very clear, and second where we are not at all suspecting? Can there be 2 groups and we can discuss separately?
Yes, there can be 2 groups actually.
Second, the PET scan, my PET scan colleagues say that it is only positive when the tumor size is more than 1 centimeter. And what about those cases where it is less than 1 centimeter? And do you think a patient who was operated laparoscopically a month or 15 days back for a laparoscopy will have liver metastasis within 15 days, and on laparoscopy you will find them?
So, addressing the first question actually, staging laparoscopy as of now has actually become a part of the surgery itself. So it kind of forms the first part of the surgery, the first part being staging laparoscopy. So if there are 2 patients in which only on staging laparoscopy you found out the metastatic disease, those 2 patients you will avoid laparotomy. That does not mean that these patients cannot be subjected to laparotomy afterwards. The negative patients, the patients who actually turn negative on laparoscopy, are actually patients who are going to be resected, or you are going to try to resect. So in those further, if 7 more patients come out to be disseminated, so at least those 2 patients would benefit by avoiding the negative laparotomy. So that is the subset 1. Second, the Van Duren paper actually takes care of few factors like bile spillage. Actually, Van Duren paper itself says that our negativity or limitation is that the patients usually landed with them after about 70 to 75 days. So which was very long waiting period, and somehow, I don't know why they did not find this much of metastasis per se in laparoscopy. But the second thing is biology. So, so the second question was for? What was the second question?
I said, is it prudent to do a laparoscopy in a patient who was undergone laparoscopy 15 days back or 20 days back? You have seen everything.
And as Dr. Shivendra Singh pointed out, that you may apparently not see metastasis, but there could be metastasis at the hidden areas, 1. Second, if you employ modalities like a laparoscopic ultrasound and all, there also you will be able to pick up some degree, some metastasis. Even Van Duren himself postulated that we should use LabUS if possible wherever it is available. So our main focus should be to rule out a disseminated disease at the outset itself, so that the patient is not subjected to an unnecessary surgery.
So what is the chance of getting a dissemination when there is no suspicion of dissemination on imaging at all, even if you do a PET scan?
Even if you do a PET scan, still, again, quoting Shivendra Singh Sir's paper, 10 to 15% patients will still have dissemination. So these, and this is across the table, like even the studies that I quoted, they also found out that even after negative PET scan, at least 5 to 10% patients will eventually turn out to be metastatic. Yeah. So they will be the patients which will be actually benefited by staging laparoscopy. And actually, the PET colleagues of ours are now actually advocating the FAPI PET as the different modality that they are going to employ. So they say that probably they are getting better results, but as of now, no studies are there for that.
So the second factor is the locally advanced nature of the disease, the resectability. So that is also one factor you can see in diagnostic laparoscopy. Yes, Dr. Vega, please.
Yeah, Dr. Eduardo, you want to say something?
Yeah, thanks so much. I don't know if you have the same experience or you have the same experience, but some of the conversation that we have about whether we do staging laparoscopy is really driven by whether we have some bile spillage or do we have a bad cholecystectomy with multiple perforation during the cholecystectomy. I found in my own experience that the operative report that I got from the surgery is actually not describing as would it happen the surgery itself. And I certainly, if we're gonna take a decision whether we're gonna do or not staging laparoscopy due to an operative report, I don't think it's reasonable that we have enough trustful evidence to say that first hasn't done any spillage and second hasn't done any perforation during the surgery. I understand that the subgroup analysis of the poorly differentiated pathologic risk factor is important, and I think I do agree that those are the patients who do have the most to gain with the staging laparoscopy, but that doesn't mean that we are not going to find significant different from what we were expecting in an early gallbladder cancer than what we found in the surgery. And the second question about why would you do a staging laparoscopy if you just did a cholecystectomy? Well, because the cholecystectomy, at least in United States or in Chile, are done by general surgeon. They're not done by a hepatobiliary surgeon. They're not done also by people who are used to see micrometastasis in the liver or a small carcinomatosis, and they usually pass that without any finding. So I wouldn't trust the decision making of the acute cholecystitis because for some reason that I could not explain, we usually focus ourselves in only the gallbladder we're gonna take out.
Yeah, I was going to say the same thing. Let us put a hand on our heart and say how many cholecystectomies I have turned the telescope all around the peritoneal cavity and looked for a metastasis in a patient with gallstone disease. Even we don't do it. How do we expect our general surgeon who's doing 5, 10, 15 cholecystectomies in a day to do that? So I don't think that argument should be used. My question is to Shiven. You said you do a staging laparoscopy before you put the patient on neoadjuvant therapy, but then that means you repeat it when you take the patient for surgery? Yeah. So that point again, the group which is Saurabh, you have to make a note that if the patient is receiving neoadjuvant treatment, the patient will need 2 staging laparoscopies.
Since we're looking for advanced disease, should we be talking about tumor markers like CA125,
Yeah.
CA99?
Exactly what I talked in the first slide, that initially requires actually a extensive workup in a neoadjuvant patient in terms of CA99, FDG PET, all kinds of imaging. Yeah. Actually, I am doing a study on CA125, 15.3 and all in CA gallbladder, and we are finding that they also predict CA gallbladder.
So Saurav, the evidence is obviously not very high level, and at present we can say that these two are complementary, the diagnostic laparoscopy and the ancillary investigations. So this much we can say. We will discuss all the points later on during our dinner or something. So we will move on to the next step, please, sir.
Thank you.
Thank you, Dr. Eduardo. Thank you very much for sending the video and joining online also very early in the morning. Thank you very much, and hope to see you in Jaipur next year.
Will do.
Thank you.
Bye-bye.
I would like to thank all the participants of the last session for such an insightful time. Next up, we'll move on to the next session, which will discuss the extent of re-resection. For chairing this session, I would like to invite Dr. Anand Mohan, who is Assistant Professor in Surgical Oncology at our center here in Jaipur, Mahatma Gandhi, and also Dr. Sandeep Jain, who is a Senior Consultant Surgical Gastroenterology from Fortis Hospital.
Before the chairpersons take over, I would like to welcome Dr. Masaru Miyazaki from Chiba. He is online, although he has sent his video in advance. Welcome, Dr. Miyazaki. Dr. Miyazaki is very fond of India. He is very fond of SGPGI, and that is why he is very fond of me. But because he very recently came to India, he said it would be difficult for him to come back again to Jaipur. So that is why this time he is participating online, but I'm sure next year he will be here.
So for this session, I welcome Dr. Shashwat Sari for his presentation on extent of re-resection in incidental CAGV.
Good afternoon. First of all, thank you to Professor Kapoor for having me over. This is my old working place. I'm an alumni technically of here. So thank you for having me. The task that's been given to me is to define the extent of re-resection for incidental gallbladder cancer. I'll just review the literature in two main parts actually. So the controversies regarding gallbladder cancer and resection will hinge about whether we need to resect for T2A or T2B, whether a segmental resection is enough, whether a wedge resection is enough, or we need to proceed with a segmental resection, and the extent of lymphadenectomy. So we'll start first. So the principle, of course, is that we do the liver resection in incidental gallbladder cancer because one, you want a negative margin, so you remove the direct invasion, you remove the micrometastasis, and you'd want to remove an en-bloc resection of the Glisonian sheath, which has implications for invasion, lymphatic invasion into the HDL. And the problem that we've faced even in regular gallbladder cancer, in all gallbladder cancer, not just incidental, is that there's no standardized way in which people have reported as an anatomical resection or a large wedge. A large wedge of 3 centimeters or so will also have the same 4B5 pedicles that an anatomical resection will encounter. And very few papers have actually addressed that clearly. Some from the East have, and we'll go through them. So I'll just cover briefly now the first, whether we require a section for T2A or T2B. Now there's two meta-analyses that have come out. The first meta-analysis is about 9 studies or so, and that came out in 2021. And they showed obviously that there is an impact of resection, liver resection on survival. But interestingly, it said that only in patients who had hepatic disease, which is T2B disease, that was there actually a difference. So subgroup analysis revealed no significant benefit for T2A and for T2B. And this was reinforced by a larger meta-analysis that was published I think last year, about 15 studies or so, which did not show any purported benefit of offering resection in T2A as compared to T2B. Now, with regard to whether a wedge or a hepatic resection is an anatomical resection is suitable, there are numerous studies. This one comes out of GB Pant, wherein they did a propensity matched analysis of about 35 patients each who underwent resection for gallbladder cancer. And they found that there was no statistical difference between those who underwent a wedge or those who underwent a bisegmentectomy. When they compared their outcomes, they realized, they found out that there was a lower blood loss and a lower complication rate in the segmental group. This is in comparison to other studies which have shown that there is a lower incidence of complications with regard to when patients undergo wedge resection, but the GB Punt study shows that it's actually true that their study had complications in the bisegmentectomy. This was a study group from France which was formulated in 2009 and came out in 2011 with their findings. So this is one of the few studies that purely looks at incidental gallbladder cancer and not incidental as a part of the whole cohort. So they had about 148 patients who had incidental gallbladder cancer, about 67 in the T2 and 60 in the T3 group. And when they compared their results, they could see that there was no difference noted in the survival, 5-year overall survival, between those patients who underwent just a resection of the liver bed as compared to those who underwent a bisegmentectomy. This was also true when they compared the results for patients who had T3 disease, where regardless of the extent of the hepatectomy, the survival was more or less the same. So when they did their analysis for the prognosis, they found it was predominantly a stage which was the driver of the survival, and possibly they found that the bile duct clearance also had an impact, though it wasn't statistically significant. This was a very large study from 14 international centers of about 930 patients, out of which most of these patients we can see are actually from Asia. 850 patients are from Asia, with about 15% of them, about 129 of them, 132 of them having incidental gallbladder cancer and then undergoing extended cholecystectomy. And while extended cholecystectomy does offer a benefit that we can see here, it does give you a survival advantage, what the surgery was, whether it was a wedge or a bisegmentectomy, was not really important and did not determine survival. So they showed that in the recurrence that does come back, it's about 70% are distant. They did not mention the intrahepatic incidence of where the metastasis has happened in this study. Now this is a propensity match study, a large study from China which came out, about 100 plus patients in each group, segmental and wedge. And once they had matched their propensities, both the cohorts, they found no difference in the overall survival. Interestingly, however, in the disease-free survival, segmental resection shows some benefit. When we delve deeper into it, they do an analysis where they see the incidence of intrahepatic recurrence. And this, from their study, it says that there is a decrease in the incidence of intrahepatic recurrence for those patients who underwent a segmental resection as compared to a wedge resection. This, however, comes at a cost of increased postoperative complications, increased length of stay, and increased bile leakage. This was a questionnaire study from Japan, about a 10-year study of about almost 100 plus institutes, where they compared their surgical practice and the results of about 485 patients, 290 or T2 and 190 patients were T3. And when they compared their cohorts, they found that there was no difference again noted in what surgery, in the type of surgery having an impact on the outcomes. Now this study goes a little bit more in detail and actually mentions the recurrence that happens in patients depending on where the lesion is. So both for lesions in the hepatic side, where you traditionally think that a deeper liver resection would be helpful, or on the peritoneal side, there was no difference that they noted statistically between the incidence of recurrence or where the metastasis or the recurrence actually happened. This was another Korean study which of about 90 patients or so, which did not show any incidence, any difference between the segmental and the wedge resection group. When they compared their morbidity data, they found there was a higher morbidity. This is in contrast to the Punt group, where they had a higher morbidity in the 4B5 group, but there was no difference in the pattern of recurrence. The next part is the extent of the lymphadenectomy. There are three pathways I'm sure we've all discussed. It can go through the mesenteric pathway, the retroperitoneal pathway, or the celiac pathway, the lymphatic spread. There is a discrepancy as to what constitutes lymph nodal clearance. there is no specific data on lymph nodal clearance in incidental gallbladder cancer, and all of this data has been extrapolated from routine practice for gallbladder cancer, and this will be open for discussion today as to whether there should be a difference in the lymphatic clearance. What has become clear from the Asian side is that we need to clear the numbers 8, 12, and 13 lymph node. Now 8 and 12 are traditionally the local lymph node which we usually clear. We've discussed and now it's clear that there is an aortocaval lymph node which is only sampled and doesn't have any prognostic significance. What's interesting now and what I will discuss is the superior pancreatico-duodenal lymph node group, which is the lymph node 13 group. And we'll discuss this. And when we see how much is actually being cleared, this is an NCCN data from 2021, which shows that only about 58% of patients actually underwent lymphatic clearance, and only about 20% of them actually had more than 6 lymph nodes removed. Again, this is not for incidental gallbladder cancer only, this is for the whole cohort. This study which came out tried to differentiate and categorize the lymph node groups. It divided the lymph nodes around the liver and the gallbladder into 3 groups. The region A was common bile duct and the hepatic artery, B was the pancreatic head, and C was along the celiac axis. And when these groups were compared, they saw that the survival for patients who had retropancreatic lymph node disease was actually very similar to those who had local lymph node disease or lymph nodes along the hilum or the porta, which was significantly different from patients who had NC disease or disease along the celiac axis. This was again reinforced by a second paper which came out where they discussed the dissection of the same lymph node group. As we can see here, so this is basically giving an idea of the incidence of each of the lymph node stations, how much or how many of them are positive. And when you find out that the posterior superior pancreatico-duodenal group are about 13% positivity, the 5-year survival for them is actually very good. It's about 30%, which is significantly better than compared to those who have a celiac or an SMA involvement. And this they saw in their cohort as well. When they did combine the lymph node groups together, so they included the posterior superior pancreatico-duodenal group along with the hilar group, there was much better stratified the liver disease, the prognosis, and it was more statistically significant then. So I'll just end here. So the role of liver resection is much more in T2B as compared to T2A disease. There's no added benefit that I could find of segmental resection of a ravine A lymph node should also be considered a regional lymph node. Thank you.
Next, I would like to call Dr. Biju, sir, who is senior professor. Stage on histopathology, but making guidelines based upon will be not so much perfect because we don't have a preoperative imaging to see that. So what we are discussing about incidental gallbladder, these are final sub-millimeter issues, but we don't have imaging, but making guidelines will be little bit problematic. Second, lymph node assumption. Most of the studies we have seen, we have threadbare all day we are discussing about lymph nodes, okay. So we never shifted from D1 lymphadenectomy, D2 lymphadenectomy in gastric cancer, not based upon studies. How we have shifted, because everybody simply started doing, okay. That's what Dr. Sridhar was telling, everybody became more comfortable celiac axis, everybody became more comfortable porta. That's the reason. It's not the evidence which made us to proceed from D1 to D2. So the carcinoma gallbladder is probably going to the same phenomenon, okay. So in the absence of a qualitative lymph node data or lymphatic studies, how are you making guidelines? So this is a problem in the, so we actually, what we need is, we actually need the evidence of the lymph node from the specimen. That's what we need. We can't work on things, because the area where the gallbladder cancer is spreading, these are the areas it is spreading. It's not expected that the 6 lymph nodes are the yield from these areas. So it's not okay. Now we are talking about all the numbers, how these numbers came. These numbers came from carcinoma stomach, okay. But if you see, from gallbladder is situated somewhere, and stomach is in the anterior plane, gallbladder and porta in the next plane, and retroperitoneum in the third plane, okay. We are talking about some stations where the which is not at all applicable in another disease. This is a different disease and neither the malignancies, okay. So this is another problem we have to really tackle. Somebody has to come out with a real stations. Then only we can actually talk about what extent of lymphadenectomy we need, okay. There is first echelon, second, all this described, but what we don't use it actually in the operative. We'll still switch on to carcinoma stomach side, okay. Now, why this is important, because this is the exact fallacy we are getting. AJCC is jumping from one station to another every 5 years. We faced all these problems. Our data got corrupted or manipulated because of their staging systems. We actually can study this, okay. So there are those who meddle with this area really know that there are anatomical structures. Probably somewhere down the line we have to name that these lymph nodes are actually related to these anatomical structures. So there is a local, there is a regional, extended regional metastatic lymph node basin is there. It is there in the lymphatic system, but we do not follow that, okay. Coming to paraortic area, we consider entire paraortic area single bulk. This is not going to help in the, at least in the carcinoma gallbladder, because as we discussed earlier, the lymphatic flow comes to the intra. More techniques on paraortic lymph node sampling. We started doing more sampling. This is not based upon any evidence. This is because of the comfort in this area. We are trying to extend our resection in this area. So this is, I don't agree with the assumption that this entire lymph nodes are simply metastatic disease. So we have something called regions within the paraortic node also. So all these regions are there. We can very well dissect it, and that is how we make more lymph nodes to the literature. That's how we want to, how it actually this disease spreads to the world. We have to tell we need more lymph nodes rather than working on 3 to 6 lymph nodes. Okay. So there are skip metastasis happens to this area. Intraarticular lymph nodes are very famous for skip metastasis. All series are reported direct skip metastasis there, and ultimately probably that is the destination. So as we have discussed, left side of aorta and right side of aorta, the lymph node stations and its implications on carcinoma gallbladder are really different. Left side, maybe we can put it as a metastatic disease. So these are the what so-called standard extended. So I don't know what is the standard really based upon what evidence we are telling this is the standard lymphadenectomy in carcinoma gallbladder. We just take out the portal lymph nodes and tell it as standard. But probably if you look at the really into the lymphatic study, probably this should be the standard. So this is one paper we addressed about a uniform approach, because we have problem in T staging and also we have problem in lymph node staging. So somewhere down the line, in at least in early cancers, we need a uniform approach. Then only we'll get a adequate lymph node need. Now another added problem, this this fact is very well known in intrahepatic cholangiocarcinoma on the left liver. Now we started resecting the lymph nodes on the left side and the left gastric artery area. This is an area well known for aberration. So when we recommend, at least we can say 33% of the arteries are all that aberrant here. Their destiny is somewhat different. Some may be in the left gastric and all that. So when somebody reports telling them that I have done a standard lymphadenectomy second tier lymph node in this area, we are probably not following the arterial philosophy of lymphatics. So some patients, you might really go and clear the left. So what I'm trying to tell is, these anatomical aberrations really affects our lymph node count, our lymph node data as well, okay. Now the quality of lymphadenectomy, which former speaker pointed out. When we do lymphadenectomy is not just taking out the lymph nodes, okay. It will satisfy a number station on paper, but that's not what we want. This area, especially gallbladder, we know that this is a stuck plane. There are which might be really stuck. So how to make it a standardized surgical procedure in lymphadenectomy, we have to really depend on perivascular plane. Okay. So all these areas to be thoroughly clean resected. Rather than counting on the lymph node, probably it is the better way is what is left out on the field. You do only bile duct, perfused bile duct, portal vein, its branches, and the hepatic. Remaining any tissue, whether it is yellow, white, or whatever you see, probably we have to tell our colleagues that, okay, we have to do more in the surgical quality front. Okay, so that is a very important criteria when we do lymphadenectomy. So this is something called a perinodal lymphadenectomy. So the lymph nodes are resected. lymph nodes are anterior. So if you look from the anterior, everything is very clear. But as we know that at least in carcinoma of gallbladder, the entire remaining bulk of the nodes are also in the posterior. Okay. So this anterior bias in lymphadenectomy, all of us keep it. We show beautiful pictures from the anterior side, but at the posterior side, there may be which plane we are actually going ahead. Okay. We do again we see beautiful videos. So this again you can see the lymph node, you can see a perinodal plane as well as a perivascular plane. So if you just take out the lymph node, what is going to happen is the entire channels of the lymphatics along the perivascular plane are going to stay there. Okay. This can have a recurrence. Even in we have studies where post-op people have demonstrated the lymphatic channels are still intact. So simply by picking up the nodes, again it will actually bias our data. So what we need is some pictures like this where we have a completely arteries are exposed, pulsating artery, red arteries and only adventitia left behind. Even the paratic nodes, the situation will be similar. Okay. We mobilize the duodenum, we see the IVC. Once we started seeing the structures, we think
T2 gallbladder cancer usually present without any symptom. It is usually found by abdominal US or CD. EUS could more clearly identify gallbladder tumor and diagnose the depth of wall invasion. T2 and T3 tumors were clearly identified enhanced CD and EUS as shown in the slide. The diagnostic accuracy of preoperative MDCT for pathological T-stage of gallbladder cancer is usually high as 81%, but not completely perfect. However, in T2 gallbladder cancer, its accuracy is not so high as 65%. Preoperative CT usually diagnoses over and under T2 stage. This case was diagnosed as having T2 on CD and the US, and the patient underwent whole layer cholecystectomy. Intraoperative fresh frozen section revealed the depth of the tumor as mucosal M cancer. Therefore, more additional surgical procedure were not required to this patient. Our recent series of acceptability of stage of T2, T3, T4. As to hepatic resection, various surgical pedectomy procedure could be chosen for gallbladder cancer after obtaining pathological finding, especially the depth of the gallbladder wall invasion of cancer and the location site of the tumor. For example, gallbladder bed, segment 4B and 5, extended right, and right trisectionectomy. As to hepatic spread of gallbladder cancer, several fine pathological studies have been investigated previously. In 1962, Mayo region in most cases. The usual mode of liver spread is by direct extension and lymphatic vessel, not by vascular venous spread. Localized spread of the liver in the venous primary region is usual finding. Our investigation further reveals root of hepatic metastasis of gallbladder cancer histologically. 32% of cases had hepatic metastatic region microscopically. Most regions were located within portal tract or accompanied by invasion into the portal tract. The most important route of hepatic metastasis is along the portal tract after direct invasion to the liver in the gallbladder cancer. So, and also existence of occult micrometastasis in the liver surgical specimen located around the gallbladder bed, namely hepatic segment 4B and 5. We identify that these occult micrometastasis exist in especially segment 5 and 4B. around the gallbladder bed in 73% of 11 cases of hepatic micrometastasis. This investigation was undergone by using surgical spacing of overexpanded hepatectomy. Professor Terasawa investigated experimentally lymphatic spreading route into the liver by using animal experiment. Carbon particle suspension injected to the gallbladder wall, spread into the liver nearby the gallbladder bed, running off to the hepatic hilus toward the hepatoduodenal ligament. This route was confirmed by lipidal drainage into the right median lobe of the liver, equivalent to the segment 5 and 4B in humans. They advocated the direct spread into segment 5 and 4B of the liver should be considered in surgical treatment of gallbladder cancer with liver invasion. Recent clinical study by Professor Chen reported that patients with incidental gallbladder cancer, stage 2B, negative lymph node status, were associated with improved disease-free survival after segment 5 and 4B resection, but not in wedge resection, significantly by propensity score matched study of 224 patients. In our experienced case of T2 gallbladder cancer, hepatic segment 5 and 4B resection group showed better overall survival than hepatic wedge resection, but statistically not significantly in these number of patients. The Vega analyzed recurrence pattern after curative intent resection for more than T1B gallbladder cancer. In their series, the liver was the most common site of recurrence in 45% of patients, and followed by calciumatosis, 37%, lymph node mets, 25%. The other investigation by Professor Morgonis showed recurrent pattern after curative intent resection for gallbladder cancer by multicenter analysis. They also revealed that among patients who developed the recurrence, liver was the most common site of recurrence, 29%. But they classified the liver recurrence to be one of the distant recurrent patterns. Professor Pollock, Ohio, said for T2 incidental diagnosis disease, majority of residual disease found at the time of lead dissection is in lymph node. Residual disease in hepatic parenchyma is found in minority of patients. Furthermore, they told the incidence of extrahepatic recurrence was no difference between two groups of wedge and segment 4 and 5, 4B and 5 resections. However, I thought that in most clinical studies like this report, pathological finding had been undergone by ordinary clinical pathological method, not by research level pathological finding with meticulous centralized section. Professor Chen reported the survival of the recurrence pattern between tumor location and surgical method after curative resection for T2 gallbladder cancer patients. Among 88 patients, gallbladder bed recurrence and liver recurrence were relatively rare, occurring in patients with liver side tumor. They concluded extended cholecystectomy is the most appropriate treatment for T2 gallbladder cancer, and that simple cholecystectomy may be appropriate for patients with cirrhosis side of tumor. Professor Blasakeran did meta-analysis of hepatectomy and non-hepatectomy in patients with T2 gallbladder cancer by 18 studies with 4,587 patients. There was no significant difference between two groups in terms of overall morbidity and mortality. And these disease-free survival and overall survival were also comparable between two groups. They concluded that hepatectomy may be not required in T2 gallbladder cancer if the preoperative evaluation confirms the depth of the tumor, intraoperative frozen section confirm microscopic negative surgical margin. Herein, we would like to consider the clinical implication of regional lymph node dissection recommended in most gastrointestinal cancer. Despite instance of lymph node metastasis, 10 to 20% lymph node dissection is strongly recommended to be aided with primary tumor resection. EMR and ESD therapies are restricted to only early cancer with very low incidence of lymph node metastasis, such as less than 5%. Gastrectomy with regional lymph node dissection and colorectal resection with regional lymph node dissection are generally recommended. Also, DFS and overall survival benefits have not been confirmed by regional lymph node dissection in early stage these gastrointestinal cancer. Regional lymph node dissection is recommended for making a correct staging of patients. I think that surgeons should offer the patient an oncologic resection with negative surgical margin. This point of view, hepatic microscopic metastasis around the gallbladder bed should be considered regional metastasis of gallbladder cancer invading the liver parenchyma. However, the time and time again, we have seen when counting for adverse tumor biology, even negative surgical margin fail to improve long-term outcome. Biology is king. Surgery is not king in facing a tumor with remarkable aggressive tumor behavior. Very piteous surgery. So I'd like to conclude my talk on basis of the reliable pathological finding of the depth of the gallbladder wall in gallbladder cancer. Gallbladder cancer invading OVSS of the wall should be required for hepatic resection of segment 4B and 5, especially the hepatic side of the gallbladder cancer, although there is no definite evidence showing survival benefit by these hepatic resection. Gallbladder cancer invading OVSS invasion of the wall in cellulosal site is not always required of any kind of hepatic resection. Gallbladder cancer invading M and PM of the wall is not required of any kind of extended resection, such as hepatic resection, lymph node dissection, over whole layer cystectomy. So I would like to appreciate Professor Kapoor for your kind invitation to this meeting, but I'm sorry to attend here online. Thank you for your kind attention. Thank you.
Thank you very much, Dr. Miyazaki. Although I would say that both in your presentation as well as in the earlier presentation, there were few statements which I am sure would be debated and discussed by some of us here. For example, this recent meta-analysis which you posted, which says that in T2, no hepatic resection is required, and also whether segment 4B and 5 should be a routine in all extended cholecystectomies. So I think those points will come up for discussion. Thank you for projecting that photograph with my colleagues when you were here. Thank you very much. Would you like to add anything in addition to your presentation since you are there online? Dr. Miyazaki को screen पे ले लें. Dr. Miyazaki को screen इधर. Dr. Miyazaki?
Yes?
Would you like to add anything other than your presentation? We've already played your video.
No, no, thank you. Thank you very much.
Okay, thank you. Chairpersons, please.
Now the House is open for discussion.
Points both on lymph node dissection and 4B and 5 wedge.
Yeah.
So what everybody 4B, 5 were propagating is based on a lymphatic study, pathological study performed probably around 25 years back. After that, no study has ever been performed. And we are basing all our thing about 4B and 5 resection only on those 1 or 2 studies. Understanding has evolved. I would say now we understand oncology much better. So the epicenter of tumor is gallbladder, not liver. And over years, how oncology has developed, it's become more organ preservation, which is being practiced, and it's just about margin. So even in colorectal liver mets, the margins of resection are shrinking to even 1 millimeter. Probably when the wide resection was required, chemotherapy was not into play now. Even Professor Miyazaki said about biology being king. So with the biology will not respect boundaries of segment 4B and 5 glyconian pedicle only. We know that the lymphatic spread will be probably more beyond that, and intrahepatic lymphatic spread along glyconian sheath will not restrict only to 4B and 5. So probably wedge resection should be the norm. That is one. And what Dr. Beju has talked about lymph node dissection, I think time has definitely come to renumber the staging system for lymph node for gallbladder separately. And we can have a middle path going little bit more than what we are doing to probably include celiac axis, which will be just adjacent to common hepatic artery lymph node. And yes, station 13 comes in, and I would also go one step further to add probably portocaval lymph node, which are sitting just on IVC, not staying probably to the right of para-aortic, as one which can be part of an extended lymph node resection, but we need to label and name them separately for gallbladder, not a general part of stomach lymph nodal stations.
So just 2 points. I think Shashwat, the literature you reviewed, I don't think that there is any evidence to say that 4B and 5 and wedge there is any difference. And taking along what Mahesh said, as I mentioned yesterday, why 2 centimeter? Why not 1? And there is a recent publication which I mentioned yesterday where it is said 1.5 centimeter is equally good and is less morbid. So probably it has been a convention which has been going on in our minds and in our textbooks. But probably just a clear margin is good enough, like in other so many other malignancies. The second is about lymph nodes. I think Dr. Yoji Kishi's article, which Biju showed, this difference of perception between the Japanese surgeons and the Western surgeons, and we fortunately follow the Japanese philosophy, both we and SCPGI and GB Pant, that we don't consider the retroduodenal or retropancreatic nodes as distant nodes. We consider them as regional nodes. So we do not say that they are a contraindication for resection. Whether that boundary now needs to be extended to the celiac nodes, the superior mesenteric nodes, I am not sure. But that answer can only come when you do an extended retroperitoneal lymphadenectomy and show good results. But I must caution, Nagoya used to do that earlier, and they stopped doing it because they didn't find any benefit and the morbidity was high.
Sir, in a way, just one comment, in a way the lymph node and the liver are the same. We want to do more, even, but we're not, the clinical literature doesn't suggest otherwise. When we went through it, There were three aims that we try to do when we do a liver resection, which is basically get a negative margin, prevent micrometastasis, and try to disrupt the lymph nodal pathways. So and the only thing we're able to demonstrate is the negative margin is working. The other two we're still not able to clearly demonstrate after time and time again multiple studies that actually has any benefit.
So, there are two things which many times I am clueless to answer myself. One is how to maintain the uniformity of whatever centimeter of margin we are talking about, maybe 1 or 2 or 3 centimeter all around the GB bed. I think that is something which is still unanswered, and that may be the reason that wider the margin, because even if you suppose you take 3 centimeter margin, so the posterior most margin would most of the times become thinner than what we intend to take it. So ultimately it ends up maybe 1 centimeter or 2 centimeters. And secondly, how to make the margin status, whether negative or positive histopathologically, of the liver. How, I mean, it is such a wide surface of GB bed. How we ensure that we are actually representing the whole margin of the liver bed to label it as a negative margin or a positive. Of course, it is okay.
How many sections you make from the cut surface of the liver?
Actually, it depends on the specimen. If the specimen is larger, then we take 2 or 3 sections, but we take the whole resection margin. It depends in whatever like cassettes we have embedded, how many blocks. We don't that time take that into consideration, take any thing it has to be embedded all. The resection margin has to be embedded. Whatever blocks or whatever slides we have to take that time. Whole of the margin will be included that time, depending upon the size of the specimen.
I think the issue about wedge versus the segment 45. I think when you talk about wedge, I think the question that you were talking about 1 centimeter, 2 centimeter. I think conceptually it is either you do a wedge or you do a segment 45. Segment 4b5, Mahesh, I think it is more to do with a micrometastasis of a venous drainage rather than lymphatics will go all places. But I think what the Japanese study and some of the ones they talked about, they said in addition to good clearance, you are looking at theoretically micrometastasis. However, having said that, most of the studies have not shown that wedge segment 4b5 is better than wedge. So I think conventionally various centers would adopt, and one of the things is that probably segment 4b5, if you standardize that, and that depending on whether there is liver involvement or not liver involvement, because I think some of the people talk about when there is no liver involvement, you do not need to go to that even micrometastasis, because then it is the liver infiltration which will lead to dissemination into the thing. The second thing about the wedge, I think we talk about 1 centimeter, 2 centimeter, whatever. I think conceptually the thing is you don't want to breach the cystic plate, and one of the important things is that you do not want bile spillage. So basically it is important that you remove the entire gallbladder, more so in those cases in which there is no liver infiltration with the part of the liver, because the issue about, because unlike some of the other tumors, it is not that into the liver, the tumor invades deeper than what is visible. So I think mostly it is that margin would come out all right, because whether you take 1 centimeter, 1.5 or 2 or whatever, I think that is different and different. Shiven, you wanted to say something?
So suppose I propose that for fundal growth, a wedge resection is good, but for a neck growth, 4b5, because as we go deeper, as what you're mentioning, the margin goes down in the region of the neck to the liver, and the distance between the pedicle and the liver bed is much less. So maybe depending on the location of the tumor, you may suggest different types of hepatectomy, and maybe for the neck tumor, a 4b5 may be a more appropriate therapeutic option.
So one point on this, even even if you plan for CHGB neck, even with 4B5, once you come down to the hilum, the margin is not more than 1 centimeter. Even if you do 4B5 also. 4B5 also, if CHGB neck, you will not get a margin with 4B5 also. If CHGB neck is there, then either do extended right or otherwise it will not get a margin. And second thing is, the spread is there, the pathology studies that are shown, they were based on angiolymphatic invasion. So they have shown that is a discontinuous meds are there, but clinically till now not much literature has been shown. So that is the one study only that pathology, they have shown that it is spread angiolymphatic invasion along the portal tracts, so the spread is discontinuous and it can be up to 2 centimeter, more than 2 centimeter discontinuous on their study. That is on pathological study. And second was venous drainage concept, but I think clinically we have not shown any benefit except for that Chinese study which shows that the disease-free survival is better because the intrahepatic recurrence is less in anatomical 4B5. So that goes in favor. It might be there are micromets are there which are taken care of 4B5, but that is only one Chinese study.
Just one brief comment about, I think Shiven, this debate has always been there since the time you were with us. You always said that you do an extended right, and we would think that in some selected cases you can also do a segment 4B5, because I think the neck tumor, whether it is infiltrating into the liver, versus I think when we are talking about neck or body or any tumor in which you are talking about the margin being clear. So I think that is the distinction one needs to make, that probably if it is infiltrating into the liver so that you think the pedicle, it is reaching close to the pedicle, so then probably you need an extended right hepatectomy. But in some of the ones, I mean, I wish I could show you that when it is more the neck tumor infiltrating into the adjacent bile duct, and so then it is more as a local clearance in that region. And once you get the CBD margin above it, you may be okay. But that is an ongoing debate, and that depends on the philosophy, because I think because Nagino group and the Kondo, they had published about extended right hepatectomy in most of these patients. However, the Rejimbo group and what we had also published, that even with biliary obstruction or neck tumors, you can get away and have a reasonable results with segment 4B5.
Sir, I think the standardization of definition of wedge resection, because like we say 2 centimeter margin, we say from the gallbladder bed where it starts. If there is some infiltration, maybe the distance from the extent of invasion, and then.
So taking forward from what Dr. Anil has said, I think since this is about incidental gallbladder cancer, we were looking only at probably T1 and T2. It would be safer or valid to say that wedge resection would suffice for incidental. Let's not talk about liver invasion, which will be T3 onwards, which won't come in incidental.
Thank you so much for excellent. Okay.
Since we are saying that it works, it may not work, and you all have such big numbers, I mean, can't we ask the pathology and see that how deep it is going? And once you have objective evidence of that, then you can be absolutely sure, instead of speculating that by that theory it spreads in that manner or not. No, but how much it is going in, or do we get anything or not?
So we have asked one pathologist to study those. Only 2 patients we found a discontinuous angiolymphatic invasion. That is the problem. The Japanese have shown that it is quite, but in our either we are not able to appreciate those things. We are our pathologists in our only 2 patients.
But incidental will be actually post surgery.
Yes.
We have to problem treatment, right?
Thank you, chairpersons. Thank you, Dr. Miyazaki. There are a lot of friends, Indian friends here who say their regards to you. Thank you very much for sending the video and for joining online. Thank you.
Thank you.
Thank you everyone for the in-depth discussion. Moving ahead, we will be debating on preventive cholecystectomy for asymptomatic gallstones. For chairing the session, I would like to welcome Dr. Ajay Sharma, Professor in HOD, Department of Surgical Gastroenterology at Mahatma Gandhi, Jaipur, and Dr. B.A. Saraswat, Professor and Head of Department of Hepatology, Mahatma Gandhi Medical College.
Okay, I think to chair this session, I have, it's a difficult, and I think we'll have a lot of controversy, discussions beyond this debate, beyond this table also. So let's get alarmed and started with this session, in which we have two eminent personalities. One is Dr. Usha Datta, and she's professor and head of the department gastroenterology at PGI Chandigarh, a medical colleague amongst the surgeons. And we have a surgeon of who has always been a loved one during the conferences, Dr. Puneet Dhar, because who takes active participation into all such discussions, and the topic is definitely hot. And the topic is on, should we do a prophylactic cholecystectomy, preventive cholecystectomy? Yeah. So can, who will be presenting first? Ma'am will be presenting first. Okay, Dr. Usha Datta, madam. I would request Dr. Puneet Dhar to please come. He can take the place over here, because at the end they have to fight and we have to support. So.
It's the chairperson is making my task even more tough, as it is the topic is highly hot and controversial, and on top of that I have a surgical opponent and he has a lot of surgical colleagues to support him, so I'm the lone gastroenterologist here.
No, ma'am, actually, you're supporting the surgeons and I'm supporting the gastroenterologists. So it's, I think, a sign of maturity in such a conference that we are actually doing the reverse.
Very nice. So preventive cholecystectomy for asymptomatic gallstones. The word preventive was a term coined by Dr. Anu Bihari and Dr. Kapoor to indicate prevention of gallbladder cancer, but however in literature the word prophylactic cholecystectomy is the more dominant one, and I'll touch upon both the components. So the stones which we see in the gallbladder are not just stones on the roadside which we can ignore. They're inside a living human being, inside a gallbladder, which is a vulnerable organ, and we can see that the gallbladder is just 2 or 3 millimeters in its thickness. So any pathology which is going to be there is going to create a lot of havoc around it. So asymptomatic gallstones may be silent, but can be also symptomatic. It can cause gallbladder cancer, acute cholecystitis, CBD stone, cholangitis, pancreatitis, and we manage this end of the spectrum, cholangitis, CBD stone, pancreatitis, and believe me, they are in our ICUs, and especially when these patients are pregnant, it is even more difficult to manage them and manage 2 lives at the same time. The relationship between gallbladder and gallstone is a 2-way unhealthy relationship. A healthy gallbladder does not have gallstones, and gallstones cause the gallbladder mucosa as well as the gallbladder itself to become unhealthy over a period of time. It's a cumulative chronic inflammation of the gallbladder which is set up in a stage of patients who are having gallstones. So asymptomatic gallstone is a misnomer. It does not mean absence of disease, it just means absence of symptom. And we all know biliary colic can be of varying severity. Patients may have some ajwain, somf and various spices at home and some household remedies, and may just ignore this episode of pain as an acid peptic disease. So whole discussion is about whether the patient had one episode of pain lasting for about half an hour at any point of time, which the patient managed herself or went to the hospital. So that creates a problem. However, let us understand that all asymptomatic gallstones does not mean absence of disease. It reflects disease in the human being in the form of metabolic syndrome, hemolysis, and several other pathologies which are associated with stones. It reflects a gallbladder which is static, has a bacterial nidus. It reflects a bile which has imbalance in it. It reflects a bile which may be possibly infected. It reflects a gut which may be static and dysbiotic and inflamed. stones have bacterial colonies sitting on that. This is what our scanning electron microscopy in our patients with gallstones showed, especially cholesterol gallstones, which is the dominant stone in northern India, has a lot of these bacterial colonies sitting on them. 50% of these stones, when cultured, were infected. So in a study on 220 patients, one of our students just completed the study, 50% stones are culture positive. So these are not just innocuous stones sitting there, it is gram negative as well as gram positive bacteria sitting there. Second is the mucosa. 80% of the gallbladder mucosa in patients with routine gallstones undergoing cholecystectomy on culture. We put the tissue in the operation theater in Robertson Cook meat media and found 80% are culture positive. So it is not just a gallbladder which is just mildly inflamed with chronic cholecystitis. The stones also cause mechanical injury to the gallbladder. Large stones, heavy stones, rougher stones, harder stones, denser stones cause more inflammation and more likely to have metaplasia and dysplasia over a period of time. So we found metaplasia was detected also in only those through inflammation. So that means our gallbladder cancer goes through this pathway of chronic inflammation, metaplasia, dysplasia. So gallstones cause chronic cumulative mucosal injury to the gallbladder. It doesn't happen in one day, but happens over 20 to 30 years period of time. And it causes mechanical injury, bacterial injury, and chemical injury to the gallbladder, thereby setting up a stage of chronic inflammation, proliferation, metaplasia, and carcinogenesis. We also found when we looked at these 220 patients with gallstones and compared it with non-gallstone gallbladders which were resected during transplantation, gallbladders which were resected as a part of choledochal cysts, gallbladders which were resected as part of routine Whipples. Here we found that the gallbladders in gallstone patients were more often metaplastic, hyperplastic, and more often had inflammation compared to the non-gallstone counterpart. So these stones in the gallbladder, even if asymptomatic, are not innocuous. Occasionally cause dysplasia also. So patients with gallstones have bacteria around it, cause bacterial infection of the gallbladder wall, and sets up a stage for metaplasia, dysplasia, and hyperplasia. We also in another study in 422 patients and compared it with non-gallstone controls, and we found that 37% of the gallbladders are static. That means they have ejection fraction of less than 40% to a fatty meal. 74% are sluggish. That means the response to a meal is after 1 hour. And the static gallbladders more often had metaplasia. Thus, these gallbladders are also dysfunctional. Gallbladder emptying is poor, so the role in digestion is inadequate. This may be the cause of dyspepsia in many of these patients. But the surgeons have a very simple solution to it. They have laparoscopic cholecystectomy, which removes this whole thing in entirety. It's a game changer for gallbladder diseases. It has lower morbidity, more patient friendly. And all our surgeons in institutions as well as who are senior in practice are well beyond the learning curve. And they have established that it's a reasonably safe procedure. So most of our guidelines have been made about 10 or 20 or 30 years behind time previously when laparoscopy was still emerging. And now there are set protocols and the cost is affordable and also comes under Ayushman Bharat for the patient who can't afford. Early laparoscopic cholecystectomy has been found to be more cost effective than a delayed laparoscopic cholecystectomy. Another study in India has shown it's easier to do cholecystectomy in asymptomatic gallstone, less technically demanding, less conversion, and less complications. So the economics are also in our favor, telling us that it is cost effective. So who benefits? The patient benefits, the gastroenterologist benefits, the radiologist benefits, the surgeon benefits, and the healthcare system benefits by prophylactic and preventive cholecystectomy. In the patient, it reduces anxiety, reduces risk. For the gastroenterologist, it reduces unnecessary ERCPs and ICU care. For radiologists, it becomes very easy to handle give us a diagnosis, is it gallbladder cancer or no. And for the surgeon, it's a cakewalk, and for the healthcare system, reduces the burden on emergency and follow-up. But what is the risk? This is a very commonly talked about risk, that is bile duct injury. But actually speaking, in a safe cholecystectomy, once the surgeons have done their job well, the chances of bile duct injury is very, very small in the present day. And you create controlled pain for a day or two after lap chole patient is home. It can rarely cause dysbiosis and the theoretical risk of increased colonic cancer. And for the gastroenterologist, the risk is it reduces income, no more EUS and no more ERCPs. For the radiologist, no more specialized investigations. And for the surgeons, no more heroic surgeries to take out gallbladder cancer. And for the healthcare system, actually increases the safe routine procedures. In India, this is very important because India is the gallbladder cancer capital of the world, and there's rising incidence of gallstones, and most of the studies have come from the Western countries. There are no Indian guidelines, no large cohort study from India. So India being the gallbladder cancer capital, Chile adopted the policy of prophylactic cholecystectomy. India likes to follow the North America and the Europe, so we are not doing service to our own patients. So north, south and east, west is a divide. This is a high incidence area and you have a low incidence area, which is the west and the southern part of India. And gallbladder cancer is better prevented rather than treated. All of you have been treating gallbladder cancer and know it's far more easy to do a cholecystectomy and come out in gallstones than to go in with a CA gallbladder. And also it's poor chemoradiosensitive, poor surgical candidate, dismal prognosis, aggressive behavior and a late presentation. 80% of the gallbladder cancer in India have gallstones and 80% of these gallstones are asymptomatic. So thus, this is a very important topic we should address. There is sufficient evidence by Bradford Hill criteria that gallstone is a risk factor for gallbladder cancer. I don't have time to go into all that. And it goes through this metaplasia pathway. In India, compared to the West, we have higher incidence of gallbladder cancer in patients with gallstones, possibly because we have a lot of cofactors, they are acting in an additive manner, and there are multiple risk factors. So that is why our equation is pushing us forward towards gallbladder cancer. And we have identified several risk factors like heavy metals, typhoid carriers, H. pylori, smoking, mustard oil, aflatoxin, and low socioeconomic status is somehow intervening into all of these components, and we have gallbladder stasis and genetic factors pushing the equation to the right. So in asymptomatic gallstones, we have an option of close follow-up. Definitely these patients, once they come into us, they should be on close follow-up or preventive cholecystectomy. I have no doubt about that. In contrast to smokers where you can't remove the lung, minimum you can remove the gallbladders and let the patient still survive a longer time. And we want to prevent clinical complications. The problem is we don't know which patient, when, how will develop a complication, and what will be the status of the patient when the patient develops a complication. Can we mitigate it at that time? So the best is to do a safe cholecystectomy at a time when the patient presents to you, when the patient is fit for it. The cumulative incidence of complications rises over a period of time, and we have about 12% incidence of gallstones in a patient in a 20-year-old Danish cohort study. Over a period of 20 years, 12% will develop gallstones. And what are the risk factors? Who will develop symptoms? Multiple stones, stones more than 1 centimeter, females, younger age because they have a longer duration to live on this earth, and older stones. All these are independent risk factors. A recent cohort from Cleveland showed that 10% develop symptoms by 5 years, 20% by 10 years, and 30% by 15 years. So this is the figure I would like to leave you with. Preventing gallstones is a problem because in the Western studies there are very, very low incidence. But in India we do not know. We are doing an all India stone disease which is carrying on asymptomatic gallstone cohort, and I wish all of you can also enroll your patients into it. And preventing bile duct injury, as you see, is a very small incidence, and in safe hands like our surgeons, I don't see any problem. And there is ways to minimize and mitigate bile duct injury. Dr. Sadiq, Dr. Kapoor, all of them have been working very closely on these things, how to ensure reduction of bile duct injury in our country. So asymptomatic gallstones, I would think that anybody who has a stone which is more than 1 centimeter, stone volume more than 6 ml, stone duration more than 20 years, or is likely to live another 20 years, if there is associated polyp, porcine gallbladder, typhoid carrier, the host has a family history of gallbladder cancer, certain genetic mutations, hemolytic anemia or comorbidities, living in a high incidence area, pesticides, insecticides, contaminated environment, anomalous pancreaticobiliary junction, those who are having remote areas. Patients in PJ come from Himachal, they have to travel about a whole day to reach you. a patient in low socioeconomic status, astronaut, travelers to isolated locations. If it is there, no doubt cholecystectomy. If not, minimum a yearly follow-up of the radiology, looking at the gallbladder wall. Very important, the radiologists look at the stone, but they don't look at the wall. So wall is the very important thing, and also to assess the functional status. So preventing cholecystic gallbladder cancer in India, gallstone is the target urgents to take on. So these are actually mini time bombs. They are not just little stones sitting there. And you may not feel like James Bond to, you know, when you take
decade, but let us see if that bears out or not. It is in fact as ridiculous a premise as a fascist one that many terrorists belong to a certain ethnic group, you know, Hitler believed that, hence that ethnic group must be radically eradicated. So do you really feel it should be as surgeons we should be as fascist? Is gallbladder cancer proportional to stones? Western population has shown that stones are extremely common environmental factors. Yesterday our friend from Bethesda actually pointed out that it's interesting that on two sides of the Andes, the Mapuche, same Mapuche ancestry actually, so there's definitely some evidence of environment as well. On the Peru side, it's very low, the same ancestry. On the Chile side, it's much higher. Likewise from the Bolivia and Chile side. So bile from Chileans was found to have a higher mutagenic activity. So are we really looking at the stones or the entire bed and other factors which cause it? And finally, we come to if this is the cause of the whole theory rests on this chronic inflammation business. So we must be like in colon cancer. When we are looking at it, we do see all phases of low-grade dysplasia, high-grade dysplasia. All of you have read biopsy reports of gallbladder. How many times have you seen that? It's only when, you know, some very hi-fi studies actually have done studies, and most of those studies are adjacent to the cancer itself, where they've shown all those changes, not in native gallstones alone. So no multivariate analysis could prove that size, number, patient age, all these are direct risk factors, although univariate showed them. And in the multivariate is only symptoms. So asymptomatic, whether we need to attack it like the enemy. Another study shows that many of these metaplastic changes actually are seen in microlithiasis, just like pancreatitis. You may not see macro stones there, the whole biliary sludge concept. We don't know whether, it's and because of this, we're actually attacking the macroliths, which we are seeing on the ultrasound. Likewise, in the tumors, in early tumors, late tumors, you find a whole range of these changes, the microsatellite instability, all the other immunohistochemical alterations. They were found in early cancers, late cancers, and in the area adjacent to that. But none were found in the chronic cholecystitis group alone, without any of these changes. In addition, many of these studies have shown from Japan that the period required to progress from dysplasia to advanced cancer would be around 10 to 15 years. So we must be seeing in that duration some evidence of that change which we fail to see. So a dose-response relationship with increased risk, with increased length of residence was shown in this. Thank you, Shraddha, for pointing out this article from the Tata, the epidemiology department. And the risk persisted even when they migrated to a low-risk region, but it was still high. So definite role for environmental genetic factors rather than just the presence of stones. It's very interesting that all these epidemiological data are actually, there is no good raw data from India. Each one is actually, there are three main articles which are being quoted. Madam in her review has actually quoted this article, which is based on a single patient who died of a adenocarcinoma. This whole Grepco experience was based on one guy who had a cancer, and he was also symptomatic. So we could wait for the patient to be symptomatic. So this is actually, you quickly flashed it, this particular article. This is, clearly addressing the problem that we have, whether it should be prophylactic expectant or surgery. It's a decision analysis, Ransohoff. and clearly showed that prophylactic cholecystectomy actually slightly decreased survival. So we don't have that evidence. So is removing gallbladders with stones just a convenient scapegoat? You know, we have this famous adage that when a surgeon is faced with an unfamiliar situation, he ends up doing what he's most familiar with. And I'm reminded of this time and again in various situations. If we didn't have any commercial advantage like the improved quality of life of all the people that you showed, so there is a conflict of interest. Are we meeting targets? Are we improving the surgeon's quality of life? So the interesting thing is the entire target population you showed was the lower socioeconomic status, and we are targeting the easier, not at risk TPA patient who merely because he has the insurance cover. So argument against prophylactic cholecystectomy for asymptomatic, the natural history of asymptomatic stones show a low lifetime risk of turning symptomatic. Forget about the cancer itself. That is the rate of complications. Most do not present with complications for the first time, and they present with minor complications, pain and all first. Surgery can be done when the moment they get symptomatic. It's just like scaring every hernia into saying you're going to die of strangulation. And none, in all these cohort studies, nobody died of gallstone-related issues. So what are the downsides of removing a gallbladder? The overall mortality risk, this is from Strasbourg, overall mortality risk of cholecystectomy is actually 0.14 to 0.5%. There's a definite concern of inducing, forget about the biliary injury, of inducing post-surgical symptoms in some actually, increasing GERD, increased diarrhea, especially in IBS patients. There's a concern of right-sided colon cancer and other cancers after several years after cholecystectomy. The financial implications are staggering. Ma'am, it is not 10,000. It is, the cost estimated is 4 times that of conservative treatment. In the UK, the estimate was £4 million for 10,000 asymptomatic patients. Even in Chile, they're doing it as an effort, concerted effort to try and get the problem down with such a high proven incidence of high gallbladder cancer. So complications are serious in 2.6%, and biliary injuries, we like to quote the figure of 0.2 to 0.3, but the latest guidelines from the Emergency Surgery Society a couple of years back actually still shows it at 0.4 to 1.5%. So are there any, if we could actually take it out, we always say try to take it out without bile spillage. Nobody does it intentionally. It's as high. This is from Annals. It's a Canadian paper. So I actually looked at several papers from Pakistan, India, and I found a very high incidence, which I thought it's probably overstated. But I found several registry data, which is probably the truth, with so many 115,000 cholecystectomies, 82 incidental gallbladder cancers, 67% bile spillage. So here is a model which is possibly the only place where equipoise could have been achieved, because only target is incidental. We are not sure whether you can prevent future cancers, but this is the only place where you can prevent an incidental cancer. And in more than half of them, you're going to actually, we heard since morning what could happen if there is a spillage. So there's an independent predictor of short disease-free survival. So a systematic review has shown there's increased risk of cholangiocarcinoma, if you do extrahepatic cholangiocarcinoma with cholecystectomy, increased risk of pancreatic cancer, increased risk of colorectal cancer, particularly right-sided colorectal cancer, colonic cancer, increased risk of prostate cancer. So if we're doing it only for preventing one cancer which we are not even sure of, I think we should be clear that a whole host, so it's not as innocuous. Removing the gallbladder can change the gut microbiota. What actual changes that could have in us, we don't really know. I mean, since all of you wax eloquent on the microbiota, I wanted you to leave you with that. So I've heard this emotional statement from a lot of people, including the first iteration of the Jaipur Surgical Festival. If you've seen the number of patients I've seen with advanced cancer gallbladder, I had one patient whom I advised against surgery, but he later came to me with cancer gallbladder. Isn't it remarkable that there are very few of us who've seen a gallbladder cancer in someone who's had stones earlier, but every single member in this room, all have seen innumerable biliary injuries. When I was doing my MCH dissertation, I collected 100 cases of
biliary injuries in a single year, and that's documented. So, I mean, we need to worry about this versus, putative. I agree, en passant, cholecystectomy may be acceptable. It has some potential benefits. This is if you're doing surgery for any other reasons, because there could be post-op symptoms of cholecystitis or something else which might cause a confusion, and there's likely a very small incremental risk from the gallbladder itself. Provided even in this case, the risk should still be explained and not trivialized, and definitely a hysterectomy had asymptomatic gallstones. I sent her to my own friend, and the guy is telling me that she's got symptomatic. So, I mean, I know that she's asymptomatic, but he's convincing me that it's symptomatic. So, it is a disease that we have, we look at retrospectively. PGI used to have autopsy data. In the oral cholecystograph era, we never did a single asymptomatic. So we can compare the incidence of gallbladder in the autopsies then and after the introduction of ultrasound. I know now we've done away with autopsy, but we still would have that data with the pathology department. In addition to being prospective and retrospective, we need to be introspective. Would I like my own gallbladder removed if I had asymptomatic stone, even by a specialist and certainly not by any run-of-the-mill surgeon? So let us start with all habits, hand on heart. How many of you put on a seatbelt when you came here to this venue? I've seen every single person not put on a seatbelt when you're seated at the back because it's not legally required, even though we know it's going to be fatal. It's been shown to be fatal. How many of us have told, more than 10 people that not to smoke, which has been shown to have so many things? But we are ready to, advise a cholecystectomy. So let's first start with things which are proven before we do this. This was a book which one of the first medical thrillers I read the moment I joined medical school, Coma and this one. This is about a gynecologist who's called, hotshot guy called Goldfingers, where he's got the best results for gynae oncologist in ovarian tumors, because any doubt of a malignancy, even a borderline report on frozen, he just removes the ovary. And I won't reveal because I think it's an interesting one. So how the whole thing changes, and I hope we're not making the same error of judgment here. I thank you for patient listening.
After two senior people talking on the controversial discussion, since we are all surgeons, I think can we just have a raise hands at how many will like to operate a asymptomatic gallbladder for prophylactic cholecystectomy? Those who would like to operate may raise your hand.
For prophylaxis of cancer, you mean?
For prophylactic of cancer. For prophylaxis of cancer only. Prophylactic cholecystectomy, asymptomatic gallstone. So we have 1, 2, 3. And how many will not operate? Oh, so we have a majority towards not operate. So ma'am, you still have a less number with you, but you are strong associate. So what we can do is
she gets a rebuttal for.
Yeah, I think I should get a rebuttal before you put it to vote. So I agree with a lot of things which you have said. However, in India, the scenario is very different. In India, for the number of gallstones that we see more gallbladder cancer. So we cannot take Western data. We don't have a decent cohort study in India to advise us what is right and wrong.
So possibly it's not the stones, ma'am?
No. Stones are the thing which set the stage. All the cofactors are actors. In the West, the stage is empty. It is just the stones. In India, we have the stones which have set the stage, and on top of that, we have aflatoxins, we have S. typhi, we have H. pylori, we have bacteria, we have stasis, and a lot of things. So I think Indian gallstones are different. The second thing is this adage that pain will happen before the patient becomes symptomatic is based on one study by Grepko, which showed a few patients which developed symptoms and they had pain. So I don't think that is true for gallbladder cancer, because we see a lot of asymptomatic gallstones along with gallbladder cancer. And the third point is that UK, you're saying that the cost of cholecystectomy is higher, but they have a free health care for other things. All our patients are coming with out-of-pocket expenditure from wherever they're coming for a follow-up, and all these patients, you would agree, definitely require a follow-up. So coming back and forth itself is an expensive thing. And again we come to this bile duct injury. Bile duct injury in asymptomatic stone is very, very low. In symptomatic complicated stone, yes, I agree. But again, this is in the surgeon's domain that you have to ensure that you can do a safe cholecystectomy for these patients. So that I leave it for the surgeons to ensure safe cholecystectomy. And bile spill, I don't think has a important role in asymptomatic stone, definitely in incidental gallbladder cancer. And the pathologists often don't report it because not all pathologists diligently look at it. They take a small piece and they say chronic cholecystitis, mild or moderate, and close the story. But if a diligent pathologist is looking at it, we are finding 47% are having metaplasia. This mean age is 40, 45 years. So in this age group, if we are already having metaplasia, we are already marching in that direction. So I would think that if your mind doesn't know, your eyes will not see. Decent pathology of the whole strip from fundus to neck and carefully doing PAS, Alcian blue staining will pick up more metaplasia. So we are in a high risk region. We have to risk stratify. We cannot just go out saying that, asymptomatic gallstones, go home and sleep. That's my
No, not at all. So they need to know, but the moment they get symptomatic, so all the studies have shown that it's the symptomatic ones which get the cancer at least. I agree with you that there might be an odd asymptomatic one which can present with pancreatitis or cholangitis alone, but to present with cancer straight away is very rare. Even though with the Grepco thing, it is only a single patient.
Yeah, I will not go further. I'll just leave it on that.
Yeah, I think both the proponents and the antagonists and the protagonist have done a very thorough job and a complete review. And I think we've already had a show of hands, so there's very little else left to be done by the hall. Except to say that I think much of the arguments that have been put forward are in the absence of any data. Whenever we talk of data, we say we don't have this information, we don't have that information. 80%, you said there are plenty of studies that say only 60 to 70% of cancers have associated gallstones. So 30% or more of gallbladders without calculi develop cancer, which again, whether you'd use it as an argument for or removal of every single gallstone, one doesn't really know. So I think possibly this is one situation which is ripe for something that we could do a mathematical modeling of the benefits and the risks. We know cholecystectomy rates. What is the NNT? How many numbers of gallbladders need to be removed to prevent one gallbladder cancer? The number needed to treat. Those numbers can be calculated. The complications of cholecystectomy have already been alluded to. And possibly in our country where this is a utopian thought that data will emerge in the last 40 years since I've entered the field of gastroenterology, this is an ongoing debate and no data really have emerged which can, on the basis of which you can strongly argue for or against. So maybe in the way you said, Usha and Puneet, you guys can do a kind of a modeling study at least to tell us what the numbers say, what would be the risks of this approach vis-a-vis the other. I think I see Professor Kapoor is standing on the mic.
So I would again request my young colleagues here, things which we haven't done, as Dr. Saraswat said in last 40 years, you can do. Some information is very easy to get. All patients with gallbladder cancer, you know whether there are stones or there are no stones. The only thing you have to ask them is whether you have had history of biliary colic in the past or not. That will tell us that out of 100 patients with gallbladder cancer, how many have stones and how many of these were symptomatic stones and how many of these were asymptomatic stones. Simple clinical data. Second, the point which Usha made, we all are doing cholecystectomies for asymptomatic gallstones for one reason or the other. All these gallbladders which are truly asymptomatic, when cholecystectomy is done, they need to be pooled, a detailed pathological study. If a significant number, we can define what will be a significant number. In my opinion, even 5 would be a good number. If even 5 out of 100 show pre-neoplastic changes, I think cholecystectomy would be justified.
Yes, just to invite the whole audience here, let everybody know that we are doing an India stone disease cohort. This is on asymptomatic gallstone. It's an ICMR funded study in which we will be enrolling 3,000 asymptomatic gallstones in the next 1 year and following them up for a 10-year period. So this will be the basis of the cohort study. It's already started over 13 centers, and I'm also getting now an ISG task force on this so that everybody can use this website and put in their asymptomatic gallstone, and then Dr. Kapoor's dream will be fulfilled of having a cohort of asymptomatic gallstones, and anybody who's operating an asymptomatic or a symptomatic gallstone in that sense can put in their data in, and we will have a online web-based calculator to tell us what's the risk for a patient.
I have another proposal which I've discussed with Professor Vinay and Piyush as well earlier, is that some of these asymptomatic gallstones, what I do is I get a HIDA done. If the patient insists on getting surgery, if I'm not sure of the symptoms, it's atypical symptoms, I get an endoscopy done. If that's clear, I get a HIDA done. If the emptying is abnormal, for the atypical patients, I do the cholecystectomy, and actually all of them have had improvement in the symptoms. For the asymptomatic ones, if it is abnormal, I tell them they have the option of doing it, but if they are not doing it, I'd like to prospectively enter them into a database. And the ones which are normal, it's possible that we might actually, so the entire cohort of post-cholecystectomy syndrome, my feeling is happens in people where we remove a functioning gallbladder. If it's already non-functioning, probably it's not, we don't know I'm aware there's no data, that's why I didn't put it in my slides. I can see Vivek shaking his head vigorously, but it's just a proposal, because I don't think we look enough at functional studies. We are hell-bent only on anatomy, only on looking at shadows. So
we did a study on 422 gallstones, and we found that more than 50% are static gallbladders, and these static gallbladders more often have metaplasia.
They're more likely to have, so that's my theory, that they're more likely to have, so it's probably these should be removed, if we have to choose from within them. And then we'll know whether, for Chile also, that's a good thought.
Also, as I said, for incidental, we need to really define what is asymptomatic gallstones. So a lot of it is underreported. So there's no strict criteria to tell what really is asymptomatic, like Dr. Datta has said. Another thing you also mentioned that when they become symptomatic, the causal relationship is much more to develop gallbladder. But I think it's a whole process of time period from asymptomatic to what we perceive as symptomatic and then proceeding to this thing. In Tata, when we operate upfront gallbladders, I would say in almost 50 to 60% we do find stones, definitely. And fourthly, I got my gallbladder operated for asymptomatic.
That's why you raised your hand, actually. So I have polyps, and I'm not getting it done because we've collected 100 polyps and we published as well. 100 polyps. So polyp is ultrasound detected polyps, and not a single one turned out to be malignant. Most of them turned out to be actually stones, the ones who operated.
Sir, have we defined the CHGB data? We don't have a defined CHGB data because we ourselves know that 80% are actually not operated, which means out of the 80%, the attrition to which the data will not be available will be more than 50% of them. Because
so I like Mahesh said, he's only 50%. So I know the literature data is 80%. All the gallbladder cancers, I probably have the least experience from all of you in CHGB in this room. All the ones I've done, most 80% didn't have a stone. So I don't know. So even Shiven is saying, and after I've told this to a lot of my colleagues, they've started telling me, yes, now they actually didn't find. So I don't know where this 80% stone has come. So I really challenged that. And he's saying 50%, so he's,
Sir, my concern is less about the 80% association of stone and more about not having complete data on the gallbladder cancer itself, because advanced stage malignancy comes to each and one of us. And this is something which we are treating, we are on tertiary level. But many of them will be sent back immediately once they are found to have a...
So you're saying a registry, we should have a registry, yes.
So first we have to have a gallbladder cancer data.
Dr. wanted a registry for biliary injuries and...
this discussion will go on. Let's stop that, Dr. Puneet and Dr. But I think Dr. Vinay Kapoor needs to plan a full half-day session for prophylactic cholecystectomy in the next Jaipur surgical week. There are just too many views and too strong thoughts, but probably the bottom line is what Usha has started, the India Stone study, and probably other centers should pull in. Objective, characterized, identified data need to be gathered, and then the debate becomes meaningful. Otherwise, it's more opinions and views and thoughts being debated rather than published data. Thank you very much for a very exciting session. Thank you both.
only concluding remark will be that both have done an extensive work to present, to support their statement, and I think most of the audience was not having all this data. Matlab, whatever we have read, something was lacking or the other. I think we have learned a lot from both of these presentations. Thank you. Thanks a lot.
Thank you, chairpersons, presenters, and participants for this fervent discussion. Moving ahead, we would like to start the next session on port site metastasis and port site excision. To chair this session, I would like to invite Dr. Dinesh Yadav, Senior Professor in Department of Surgical Oncology, Mahatma Gandhi Medical College. Sir, please kindly.
So, good afternoon. For this topic, I invite Dr. Vikram Chaudhary, sir, for his talk.
Thank you, Professor Kapoor, for this opportunity. And the topic given to me was port site metastasis and role of port site excision. There is very little prospective evidence. There are hardly 20 studies on this topic in the literature. Many of the studies which quote the incidence are not dedicated to this topic. Computer is restarting. Just give us a minute.
Until then, I would request Sumita Jain ma'am, HOD Department of General Surgery, SMS Hospitals, to kindly, if she could just chair over this session. Thank you, ma'am.
So the topic given to me was port site metastasis and the role of port site excision in gallbladder cancer, particularly the incidental gallbladder cancer. Excuse me. Yeah, okay. Simple mode rakho. Okay. So the port site metastasis happens because of the tumor cell implantation at the trocar site, and these patients tend to form a palpable mass in the anteroabdominal wall at or near the site of the prior port or incision, and it can be a source of significant intractable symptoms in quite a few patients when they develop. In few patients they can be small masses which can cause pain, and in some patients it can even form a large fungating mass where if you offer surgery it can even require a major flap like this. They can be divided into either isolated or disseminated port site metastasis. Most, in fact 80 to 90% of the port site metastases are associated with disseminated peritoneal disease and systemic disease. They can occur either at extraction site or non-extraction site, and 80 to 90% of the port site metastases occur at the specimen extraction site. The actual incidence of port site metastasis is debatable. Most of the literature quotes the incidence between 2 to 14%. However, I came across a systematic review from a Canadian study where they reviewed the 20th century studies for around 15 years and the 21st century 12-year studies, that the 21st century incidence is around 10%. Previously, it was reported in around 18%. So somewhat the incidence is reducing, and the literature is clearly showing that trend that the incidence of port site mets has gone down in last 2 decades. Gallbladder cancer is notorious to develop port site metastasis. As compared to other GI malignancies, the incidence of port site metastasis is higher with gallbladder cancer. In few patients with incidental gallbladder cancer, the primary is usually missed. So in cases of missed gallbladder cancer, port site mets can present after a long period of time with a long DFI. And port site mets occurrence after a lap cholecystectomy is slightly higher as compared to open cholecystectomy in the literature. So that's the introduction of this topic. It's a rapid process. It frequently diagnosed 1 to 6 months after index cholecystectomy. Most patients with port site mets die of the disease recurrence and frequently present with associated peritoneal and systematic metastatic disease. So there are possible mechanisms which have been hypothesized and which have been studied in the literature. The mechanisms are either procedure related, which are related, the etiology can be pneumoperitoneal related, and finally it can be patient related factors. So the procedure related factors mainly deal with an improper tumor handling or a tissue handling, the bile leak during the surgery, and the specimen extraction without a specimen bag. The pneumoperitoneum is known to cause a chimney effect. Sudden evacuation of air causes the chimney effect, and it is supposed to cause the implantation of the tumor cells into the port sites and resultant tumor metastasis in the port site. And the aerosolization of the tumor cells is also hypothesized to cause the port site metastasis. The patient related factors is the surgery related inflammatory response, decreased cellular immunity, blood osmosis, and the possible aggressive nature of the tumor and the hematogenous spread are the possible mechanisms which are patient related. So it is a multifactorial mechanism. It is difficult to know in a particular patient what exactly has resulted in port site metastasis, and therefore sheerly targeting the port site and excising them prophylactically may not be a good idea. However, there can be some strategies which you can do during surgery. So primary is to avoid the bile spill, the careful and delicate specimen handling, maintaining the oncological planes, use of extraction bags as a protocol, incision protection if you are extracting the specimen, and routine examination of the specimen after extraction and frozen section analysis in case of a doubt are few of the things which you can do to reduce the port site incidence of port site metastasis. Now coming to the role of prophylactic port site excision. The initial study was from, I think, MSKCC group, which suggested that the port site excision during completion extended cholecystectomy for incidental gallbladder cancer is not recommended. It's not a standard recommendation. It does not reduce the recurrence and with rising evidence suggesting its futility, the practice of routine prophylactic port site excision, philosophical thing whether it is a systemic or a local disease. So if there is an absence of coexistent metastatic disease at any other site, and if there is no clarity whether you can consider a delayed metachronous port site metastasis site as a port site met. This study, I think, is from the AIMS group. It is a very interesting study. It points towards the fact that the isolated port site metastasis probably may be a different entity, and it may be in few patients represents a local recurrence rather than a systemic metastatic disease, because isolated port site metastasis in that study particularly, they seem to have a high level. The time to disease progression after intervention in these patients was higher as compared to the patients who had a diffuse metastatic disease. The mean survival in this subgroup is higher as compared to other patients, and the isolated peritoneal metastasis patients represent probably from the port site mets presenting as per systematic recurrence. So in the isolated port site metastasis subgroup, in few patients you probably can treat and consider them with curative intent and consider them as local recurrence is what the literature is suggesting. Dr. Shraddha, isolated port site metastasis at TMH. There were total 13 patients, all had undergone laparoscopic cholecystectomy. Interestingly, none of the previous centers had administered any systemic therapy in them. These patients were administered systemic therapy. 11 of these patients were operable. 2 of these patients received neoadjuvant radiation as the response to chemotherapy was not great. And you can see that after curative intent resection, the median follow-up of 2 years in these patients, the overall survival was around 3 years, and disease-free survival was around 20. How to approach the patients with isolated port site metastasis? So it is important to decide the intent we are starting the treatment, and therefore FDG PET and the staging laparoscopy are the two modalities which probably need to be utilized in subgroup, because this is the group where 80 to 90% patients are likely to have peritoneal disease or metastatic disease. Dr. Shraddha and Dr. Goel published this paper, studied the patients with oligometastatic disease who were treated with curative surgery, and in this subgroup you can see that the port site metastasis is the subgroup which has the highest survival of around 23 months as compared to all other sites of oligometastatic disease. So this is a subgroup where if you have a patient who doesn't have a metastatic disease at other site, it should be treated with curative intent and aggressively. To conclude, routine prophylactic port site excision should not be performed. It does not reduce the recurrence rates and has no survival advantage. The literature is unclear whether isolated port site metastasis represents a local recurrence or metastatic disease. Isolated port site metastasis patients with metachronous presentation may represent a different biology. Patients with isolated PSM should be treated with systemic therapy with neoadjuvant intent, and patients demonstrating disease response or stability should be operated for port site excision. Thank you.
Thank you, Vikram. Just one question. Is there any study like correlating it with the T stage? Like in which T stage port site metastasis is more like?
So frankly, I reviewed the literature to write the review, which Professor Kapoor had asked me. There is no specific study which looks at a stage and correlation of development of port site metastasis. I at least have not come forward. If
a figure of 7% for open, how many have you seen?
Very few. So, in the study which in which Dr. Shraddha and Dr. Goel had published, 13 like in those all 13 patients were after lap chole, and in our OPDs most of the patients have incidental GBC history, and yes, so most of them are.
So you take it as oligometastasis or you take it as locally advanced gallbladder cancer?
So that's what I said, that it is unclear. So if the patient is coming back after a long DFI with a solitary lesion or a solitary port site met, and if there is no metastatic disease elsewhere, whether to consider it as a local recurrence or a systemic metastatic disease is not clear. But because there is no other site of metastasis, most of these patients can be treated with curative intent is what I was trying to suggest. And that's what the literature is also suggesting.
You're suggesting new adjuvant for that and then resection. Why not the other way? Resect and then adjuvant?
So you want to know how they are going to behave.
So one reason for this is to know biology, because we've had a couple of patients where we resected one, and then after a further interval, it's come at another.
Another argument is if you, many of these patients have large tumors. If you can achieve certain tumor volume response in them, the size of the defect, managing them, knowing the disease biology, everything makes a difference. Otherwise, anything. Thank you.
Next speaker is Dr. VG Sherit from Singapore. Is it online or? Oh, sorry. I didn't know about it. Sorry. Welcome, Dr. Sherit.
Thank you very much. Good afternoon, everyone. I think I have not much to add since the topic has not much scientific data within the literature itself. But I might just enrich a little bit of what has been spoken on the theme. I think when we will eventually publish this as a consensus document rather than a guideline, maybe we should borrow some ideas from our upper GI, lower GI, and the Urogyne colleagues, because port site metastasis is a problem for everybody, not only for HPB surgeons. And there is a fair bit of literature, though it's not belonging to the HPB domain, but there is a fair bit of literature surrounding the theme itself. So that's one aspect. I think two decades ago, it was already published and reported widely that since Lep coli can lead to port site mets, that's why all CAGB or suspected CAGB should be operated by an open procedure. And I think we have moved on from that philosophical era, and I would not say that we should always do an open coli for a suspected or a confirmed CAGB case. Definitely laparoscopic or even robotic minimal access has a role. So my talk will partly overlap with what has been said, but I'll just share some ideas and comments, which is what I've been asked by Prof. Kapoor and team. So first of all, in our consensus, we need to be very clear what is the definition of port site mets. And there has been substantial literature defining what it means, but if you dig down deep, there are certain literature reports showing different pathology already. As for example, this case here. So primary should match with the port site, and that should be the sacrosanct definition of port site. Second would be drain site. There are some reports on drain site, and they drain, and these are only sporadic reports, and drain could be inserted as a part of lap procedure, could be through the 5 mm port, could be put ad hoc through a separate stab incision. And when we put our consensus, we probably ought to give some clarity to this drain site met saga. And I would agree that we should probably categorize port site into an isolated port site where there is no evidence of disease elsewhere except the port, and patients where there is evidence of disease elsewhere in the body like liver, lung, peritoneum, etc. So moving on with the definition and clarity, then we need to understand why these port site mets happen, and I think the earlier speaker has already commented. But we need to know that there are certain factors which are non-modifiable. For example, though there is no much strong evidence of T1, 2, 3, 4 in gallbladder, there is a substantial data from urogyne malignancy, that advanced tumor stage is one of the predictor of port site mets, whether that's related to stage or whether that's related to difficult tumor handling and thereby mechanical spread being more likely, or that's because of tumor rupture or because of just non-gentle tissue handling by virtue of sheer size. We don't know. But definitely there are certain factors which will be non-modifiable factors, and those factors which are modifiable, I think our consensus probably ought to shed light on that, and in view of lack of evidence, we probably can take some brave steps to give some logical proposals for reducing the burden on port site mets or prevention. For example, there is substantial data of pneumoperitoneum, the higher intra-abdominal pressures, the prolonged time of the surgery, and that could lead to dissemination. So we could give some guidance on the pneumoperitoneal pressures. Say, for example, I think spillage has been talked and discussed widely, and most of us agree that spillage is not an act of convenience or an act of choice. It just happens because of technical difficulty. A lot of people have spoken about endo bags, but the problem is after difficult operation, we tend to irrigate the peritoneal cavity, and this irrigation fluid bathes the external part of the endo bag. So endo bag would not prevent the port site problems because the outer side of the endo bag is now being exposed to the intraperitoneal content where potential tumor seeding has already happened during the procedure, and irrigation might even make it worse. And that's why endo bag is not really an Achilles heel to prevent the port site mets, though it may serve to reduce a little bit. There's minimal talk about port site air leaks. We generally don't document the use of CO2 during the lap chole. We document uptime, we document blood loss, we document many other things which we believe are important, but we hardly document how much carbon dioxide is being used, and that is directly proportionate to the air leaks, changes of instrumentation, etc., and a little bit of it is related to technique. And that could actually aid in terms of identifying the risk factor for port site, which is possibly mentioned here. The immune and inflammatory response is, the literature is debated and both sides have been reported. Some people say that immune reduction or immune suppression leads to port site mets. There is some literature which suggests that immune enhancement or normal immune competency actually paradoxically serves inflammatory oncotoxins and thereby leads to mechanical mets to the port site. So this immune inflammation concept in the literature itself has some paradoxical things which probably we ought to discuss in our consensus statements. And I think we need to, once we know the identifiable risk factors, we probably also should talk a little bit about precautions and how this could be reduced or prevented. I think just saying gentle manipulation, avoiding perforation, which is all reported, or using bag, is not sufficient because nobody does a hard manipulation, nobody does a deliberate perforation. So such loose statements in our consensus should be avoided because it doesn't serve any meaningful value for ground level implementation for people to change their practice or even the consensus to remain some credible piece of document to resort to. I think once we are clear how to prevent it, well, I've added some slides here which are mostly coming from non-gallbladder, from urogyne era. I've never irrigated anybody with 5-fluorouracil, but these things are reported in oncological literature to reduce the burden of potential port site, and we could consider giving a soft recommendations without much evidence or given, in our consensus. We can take a liberty to write such things with the intention for people to see if they want to adapt, of course, after informed consent of the patient. More importantly, I'm not here to guide the technique. I've done less than 5 port sites to answer some of the questions. I have seen less than 10 patients, and most of those things I have done is belonging to my senior consultants and professors who were in charge. So we have removed some port sites, and I've been always taught when you remove a port site, please go from skin down all the way, take an adequate margin. The previous incision must be completely excised. And it's definitely not considered a locally advanced disease, but it could be either a isolated mass, a part of systemic saga, which is unsure. I would probably say that literature has these various words. One is a tumorectomy, one is called hook wire localization, and again cherry picking or tumorectomy. And again, what's the margin, 2 cm, 1 cm? I would say oncological negative margin, at least for the sake of a consensus statement. When should we do? If there is a systemic disease, patient actually needs systemic therapy, and not to overtly promise long survival gains. Cautiously, discussion with the patient with potential survival gains has been shown by the Tata paper. With maybe the right approach that a multidisciplinary may encourage a resection would be, we have to make it clear that patient must be in agreement that resection of port site is not the treatment itself, as far as it's combined with the chemotherapy, either before or after, doesn't matter. So patient willingness to take the entire package of the treatment along with the port site excision, the willingness for taking some form of adjuvant or palliative intent chemotherapy would be my suggestion for the consensus document, that patient can't just say I'll take surgery, but I prefer not to take chemotherapy part of the treatment. Some patients may not have willingness to go for surgery for various reasons, and if they still have an isolated port site, we could actually offer some form of external beam radiation, or there are some data with brachytherapy with implanted seeds as well, and that probably could be discussed in our consensus statement as well. With regard to whether this is a systemic disease or this considered a solitary local recurrence, I think there is no data, or there is no at least scientific proof I could dig out from the literature and say is anyone's guess. But I would say that we should probably consider it as a systemic disease, though we can
is selective, which cases port-site excision should be included as part of the completion extended cholecystectomy for ciliated gallbladder cancer. However, this is not practiced uniformly in the current literature. Hence, it can be performed selectively for that question, though extracting the gallbladder, if performed during CEC for ciliated gallbladder carcinoma. It is because the etiology for the occurrence of port-site metastasis is multifactorial, including direct contamination of the port site during extraction of gallbladder, tumor cell seedling due to pneumoperitoneum, gallbladder perforation, and bile spillage causing contamination of all ports. Hence, PSM can occur at the gallbladder extraction and non-extraction port sites. The extent of the port site excision has to be wide enough, 1 centimeter around the scar, as the ports are usually placed in an oblique fashion. Further, full thickness tissue from the skin down to the peritoneum should be excised. Another issue is delayed metachronous port-site metastasis after index cholecystectomy, where no reoperation was done. Is it a local or metastatic disease? In the absence of coexistent metastatic disease at other sites, there is no clarity on whether delayed metachronous PSM after index cholecystectomy should be considered a local or systemic metastatic recurrence. A proportion of such patients may have disease solely due to local seedling. However, it is difficult to identify these two groups separately. In that case, 18F FDG PET-CT plays a very important role in the diagnosis, staging, and management of these patients presenting with late post-site metastasis. Staging laparoscopy is a standard practice in gallbladder cancer. However, there is no recommendation on the role of staging laparoscopy in post-site metastasis to rule out coexistent peritoneal disease, as this clinical situation remains uncommon. Considering the higher incidence of associated peritoneal disease in post-site metastatic patients, staging laparoscopy is likely to have a higher yield and may facilitate better counseling of the patients about the treatment intent before initiating systemic therapy. What about the isolated post-site metastatic with no other disease on PET scan? What should we do? The literature is unclear whether isolated post-site metastasis represents a local recurrence or metastatic disease. After carefully excluding the presence of coexistent metastatic disease, these patients should be treated with chemotherapy with neoadjuvant intent. Patients demonstrating disease response or stability should be operated for post-site excision. Systemic therapy may provide an in vivo indicator of disease biology and help select patients in whom post-site excision may be performed later to provide possible survival advantage. This approach is likely to provide survival benefit in this select group of patients. Thank you very much.
So, thank you, Dr. Salat. Thank you, Dr. Bikram Chaudhary, sir, and thank you, Dr. Mint. And, sir, any question?
Good evening, myself T.D. Yadav from PGI. So two important things in our experience are I could not find in the presentation. One is duration between the gallbladder surgery and appearance of the port metastasis. And I think this is very important because we are thinking that is it like an incidental gallbladder cancer. So if it is what we follow, if it is as Bikram said, we do PET scan, we do a staging lab, but it is also very important. After 2 years it is coming, within 1 year it is coming, or it is coming more than that. All type of spectrum patients are coming. So I think it's very important whether we treat them like remove the port metastasis after neoadjuvant, we regularly follow, and then are you going to do completion extended cholecystectomy at the same time if patient is coming early, or you are only removing the gallbladder port site metastasis, taking all the margins clear. I think I have seen 12 years after the gallbladder surgery, laparoscopic surgery, one gentleman from Punjab, but repeatedly incision was being done and his wound was being drained, and he went on increasing and it became 12 centimeter. We give chemotherapy as you said. So these are, I think, some issues which still have to be thought about. Thank you.
This is the only one study, that AIMS study, Chauhan et al., that showed that as the interval between the index surgery and the port site met increases, the survival is the better. So that is there in the literature, but that's the only study which actually focused on that part of analysis, that if the DFI is longer, those patients will do well. Agreed, yes,
So
agree.
Yeah, I agree. I mean, once you have a port site met, even if the time of presentation is important, the later it presents means a better tumor biology per se. But it's still a metastatic disease. Just a question to all surgeons actually. We are talking about port site mets. I was just thinking, if we have an open cholecystectomy for a difficult gallbladder and we have to go in, do scar or just going through the same scar? No, I wanted to ask whether we go through the same. No, we have an open scar of a difficult gallbladder surgery, and we have to go. Now we have we have to do a revision. So do we excise the full scar, or we just go through the same scar? Yeah, incidental. Yeah. ahead, sir. No, that's a thought which came to my mind, sir.
Only just a little bit of the scar, just for that, so that the joke
The recurrence is happening arbitrarily after 6 months. So these are the different patients probably. In those patients, if at
Yes, then we go CT scan, again suggestion is persisting, and then we go ahead and do. But based on the radiology alone, if we have done it, I think I thought I will emphasize the point. We have done CT scan advise, are they right that advise FNAC? So is there any Dr. Naimis, can you take it that how we suspect gallbladder, any changes of malignancy on ultrasound?
So thickening of the gallbladder is what they see. Second is the lesion if they see, or if a polyp which is more than 10 millimeter, again they try to find out if it is.
So I still want to get back to port site metastasis. Dr. Selath and Dr. Vikram clearly showed that there is no benefit in resecting port sites in all patients, right? You said you resect the site which you know should be resected, or where the gallbladder has been extracted. So at the end of the day, what is the recommendation? Do we excise ports? At one stage, Dr. Kapoor, if you can also participate, we used to say all port sites to be excised because the deposits causes are multifactorial ports, extraction port. So what is the recommendation?
Sir, if I say recommendation, it is just, we have 12 patients of port site excisions where we have done. What we follow, we are seeing that mostly these patients are having only epigastric port metastasis. I am not finding any patient having umbilical port metastasis. I am coming to that. I'm coming to that, sir. Based on that, and we are seeing that most of our people don't use bag. And when you are taking the gallbladder out and our pneumoperitoneum goes down, so sudden gush of the carbon dioxide brings more and more aerosols and all the, if there are some cells which are in the peritoneum to that particular port. So that's why we thought we will excise this port, and it is not going to do much disadvantage to the person when we are doing. Sometimes when earlier we used to do umbilical port, every port excision, then hernia incision were common, but only one port excision doesn't produce much. So based on that particular thing, we are excising one port which has been excised. If we are not able to get any message from the index operation, then we excise the epigastric port based on what our people are doing. Mostly everybody is taking from the epigastric port. Yes. So yes, sir.
CBGI at some stage we were doing and we were recommending excision of all four, that it probably is of no use except that site metastasis with PET scan showing no other disease. Then you may excise, but as both the speakers said, with great caution and counseling of the patient that most probably there will be recurrence.
Sir, we have found tumor deposit. We have not found in any of the patient. This is very clear. In one our patient, we found some insignificant thing, but they tried to say we can see some cells. Otherwise, we have not found any patient having tumor deposits on the port site metastasis. So probably incidental gallbladder cancer, that is happening if there is no residual gallbladder. So most of the patient we are not finding any tumor at that time when you are doing completion extended cholecystectomy. So that logic might be working. When patients are coming in advanced stage and we are giving all these adjuvant and all, those are the different. When patients are coming in appropriate timing and you are doing completion extended cholecystectomy, so we are not finding residual tumor. We are doing based on the T stage.
Preemptively excising port is now we have all moved away. We have moved away from that.
You should say that it is not mandatory to excise on resurgery
port. You are not
ports when
for the redo surgery to a specialized HPB center
What is
rather than doing
specialized surgeon now?
rather than doing
They are
it.
also beginners, many of them, they are all, they
No.
have just completed their
The message should be that, please listen, the message should be that, don't thrust opinion. The message should be that you excise the port, when you are taking gallbladder out, please use proper bag, so that all bile spill and all those things which occur at the time of extraction should not occur. That message you can, if you use this with a caveat, or else what this consensus meeting sir is making, whatever you find, take a consensus and do it, but that is what is, that's all I am saying. That is what is the based on the what we are seeing the people coming, and that same logic we are trying to this thing. Everything doesn't require RCT. There are something you see by the experience also.
And use of bag is even I would recommend, because though Chelad pointed out that you don't need to mention that, but even in smaller nursing homes, so many times we get patients who have the gallbladder have been extracted without use of an endo bag. So every center or every smaller nursing home is not using a bag as for an extraction. They just remove the gallbladder. It is not for infection part.
Metastasis.
Correct.
So my point was not against the use of bag. I routinely use it. I advocate it. I was just mentioning it's not a panacea to reduce your port site meds, because it's not the one variable only. There are many other actors in this port site meds. And I request Prof. Kapoor to consider a post meeting some form of Delphi consensus for such topics where the evidence is scarce. As we have various viewpoints, and that viewpoints must be published and reported. The minority viewpoints shouldn't be suppressed.
Yes.
Because
Absolutely.
absence of evidence doesn't mean evidence of absence. So we should get a consensus. We should say more than 80% or 90%. We should say that this is a strong recommendation.
Most Delphi, that's what they plan.
Yes.
Because in most questions which we have discussed so far, there is no evidence, and it seems that there is very little consensus also. So we will follow the Delphi process. I was reviewing the process of Delphi consensus. Most reports include 70, some have gone up to 60 also, but I think we would take about 70.
So I think I go to our medical gastroenterologist. So Dr. Anurag, so what is your opinion about role of endoscopic ultrasound in the gallbladder, suspected gallbladder cancer or gallbladder this thing, gallbladder stone disease, both ways?
So whatever that an ultrasound, an abdominal ultrasound can do, an EUS can largely do it better. So EUS would have a higher sensitivity and specificity of picking up gallstones when compared to an abdominal ultrasound. EUS has a better sensitivity in predicting the nature of lesion. Of course, end of the day it's histology, but it does have a higher sensitivity and specificity in predicting the nature, whether it could be malignant or benign. For instance, when you just mentioned, what features one would look for while doing an abdominal ultrasound to say whether it is malignant or not. So if there is this intra-gallbladder lesion, there are certain features, and especially if there's a center which is doing contrast-enhanced EUS, then almost up to 80 to 90% specificity one can predict whether this lesion is malignant or not. And the features would there include the irregularity, the surface irregularity, and the irregular uptake of the contrast. So both ways it slightly scores over, and whether it is early gallbladder cancer or gallstones, the neck gallbladder stones are picked up with a higher frequency with endoscopic ultrasound. So in these two instances which you specifically mentioned, an EUS scores better.
So I was thinking about there are certain lymph nodes in the gallbladder cancer management which are clear-cut taken as a metastatic disease, and these are basically becomes contraindication to the curative surgery, or they are the one of the indications to go for neoadjuvant. We make our some protocol based on these things. So do you think that it is like autocoil group of lymph nodes, celiac group of lymph nodes, can it be done better handled rather than going for CT and all, or then staging lab and all can be avoided?
So the present CT scans do almost an equal job, but
No, I am
yes,
talking about FNA.
compared to FNA, yes,
US guide.
FNA from the nodes or FNA from the perilesional hepatic infiltration. These are two areas where EUS, of course, is the best. I mean, it scores over CT, it scores over abdominal ultrasound. So these two, the lymph nodes, especially the ones around the cystic duct, and the perilesional infiltration, hepatic infiltration. The FNA done through EUS, nothing is even close to that. Sir.
Yeah, so I thought this would be the better, you can do a US guided FNF if there is a suspicion on PET or these things, group of the lymph nodes which are becomes contraindication to carotid intent are one of the indications to go for this thing. So I think sir asked me only one question to everybody, so I am going to ask Dr. Shahid Siddiqui. Dr. Shahid, can you just in short tell you where do you stand in terms of neoadjuvant therapy in a gallbladder cancer and adjuvant therapy? What regimen is being used and is it effective?
I am basically a radiation oncologist.
Okay.
So definitely there are reports in the literature that adjuvant treatment maybe in the form of radiation or post-surgery chemotherapy, they have a definite role to play in the management of the gallbladder malignancies, especially from 1B onward stage. And in the unresectable setting also, when the tumor is unresectable.
Palliative
Yes,
chemo.
that is for palliative tumor. As far as neoadjuvant radiotherapy or adjuvant radiotherapy are concerned, there are studies available in the literature in favor of both. And most of them are, of course, retrospective studies. And two of the studies are ongoing. One is the GAIN study and the one is POL CAGB. The results of those studies are still awaited and likely to be declared in next year or so. So, in the management, I mean, there is, of course, 1B onward, the adjuvant therapy can be given either in the form of concurrent radiotherapy or concurrent CRT, sorry, or maybe adjuvant RT also. But we have to wait for the results of the ongoing studies unless we have planned RCTs in favor of either of them.
So one more thing I wanted to discuss, but because time is gone, but we have caused the, I think this was being discussed when I entered. When you see Dr. Anurag, when you see a patient with gallbladder cancer and surgical obstructive jaundice, sure. So how you approach these patients? Suppose somebody refers that this patient is having surgical obstructive jaundice and there is a gallbladder cancer associated.
So for suspected carcinoma gallbladder presenting with jaundice, as we have seen, as it goes by the literature also, they're largely unresectable. So the issue here would be largely palliative. Tissue diagnosis then in unresectable lesions, we have then options of either taking percutaneous or through EUS or while doing an ERCP. But most of these patients who present to us with jaundice and are unresectable are given endoscopic palliation in form of self-expanding metallic stents, a brush cytology taken at the same time.
So I think that is the Shivendra is also listening. We are little bit different opinion we have, and that is the message I wanted to give, that every gallbladder cancer presenting with the jaundice, I think we should put some effort to first say that this is not resectable. And there are many reports where if you have been able to achieve R0 resection by doing different variation in your approach, then outcome has been almost same. The question is that is what tomorrow maybe I have my slide where metallic stent has been put, and then we gave a neoadjuvant therapy, and we have been able to resect a young lady and R0 resection. I will show tomorrow in this thing. So this was the message. Shivendra is resecting obstructive jaundice patient. We decrease the jaundice. We try to see the liver volume, and if at all confluence, it is below the confluence. Usually common site is close to the confluence, basically on the right side. But if it is below the confluence, by decreasing jaundice, we just took two segments, 4B and 5, and then do CBD excision, proximal and distal margin frozen, and do proper lymphadenectomy, and then go for adjuvant. So this can be done in a very small group of patient. And another group would be that where you have to, because of the right hepatectomy, that will include at least segment 4B preserving right hepatectomy or right extended hepatectomy. There we are little bit failing, because by the time our patients become ready, the disease become metastatic.
So in that scenario,
which is why I mentioned unresectable. Of course,
Yeah.
before hopping on to stenting these
Yeah.
patients, one would assess the resectability.
Yeah.
sir, in that scenario, what will you prefer? You will prefer PTBD to relieve the jaundice or metallic stent?
Metallic stent, what we are, I think, getting confused in pancreatic cancer and gallbladder cancer. For gallbladder cancer, to have a metallic stent, it's not something lower down where you go above the, that particular small metallic stent and they resect. Here you have to go either both sides, or you have to go above the, usually the site is common hepatic duct and above. So you have to, your metallic stent will go inside the either right duct or left duct. And here in that area, lots of reaction is there, and very difficult to go around the common bile duct and resect the common bile duct and resect from the portal vein. So I think we go for plastic stent. If our gastroenterologists are nowadays, they are trying to go at the without blockage of the confluence at type 3 type blockage. But PTBD is commonly done if confluence is blocked still in our center. Sir, if to house, please ask whatever points we have discussed. I don't think it was anything more than what already whole day it has been discussed, but if you have any question, we can still try to answer, or I will just close the session. So if not, then thank you all, and thank you all the panelists. Thank you.
Thank you, sir.
Thank you, thank you.
Thank you all very much. So all the faculty, a gentle reminder for the banquet dinner today at the Pride Umber. Thank you.